organized by Vietnam National Heart Association. And on behalf of the organizing committee, I would like to extend our warmest welcome and sincere appreciation to all distinguished faculty members and participants joining us today from Vietnam and particularly from across the Asia-Pacific region. Your presence brings valuable international perspectives to today's scientific discussions. Ladies and gentlemen, has evolved tremendously with advances in devices, imaging, techniques, and procedural strategy. We are now able to treat coronary lesions that were once considered extremely difficult or even impossible to approach percutaneously. However, as the complexity of our patients' lesions increase, an important question is, do we thinking about complex PCI? And that is exactly the philosophy behind today. Gather scientific evidence and real-world clinical practice through expert presentations, panels, live case, and hands-on sessions. We therefore hope that this meeting will provide not only an opportunity to learn new techniques, but also a platform to exchange ideas and perhaps develop new approach to complex coronary intervention. Great honor to introduce organizing. He is the President, ASEAN Federation of Cardiology, Vice President, Vietnam National Heart Association, Director, Institute of Cardiology, August the 19th Hospital, Vietnam. May I introduce Professor Phạm Mạnh Hùng. And we also have the kind presence of distinguished international experts from Australia, China, Malaysia, the Philippines, Singapore, Taiwan, Thailand, Korea, and British Indian Ocean Territory, as listed on the screen. Welcome. In addition to a productive scientific meeting, you will also enjoy your time and you experience the hospitality of our country. So, ladies and gentlemen, now it's my honor to invite Professor Phạm Mạnh Hùng to deliver the opening remarks and officially welcome all faculty members and participants to today's meeting. Professor Hùng, the floor is yours.
Thank you so much, Dr. Levokian, for the kind introduction. Good morning, distinguished faculty, dear colleagues, ladies and gentlemen. On behalf of Vietnam National Heart Association, it is my great pleasure to welcome all you to Hanoi and to our scientific conference, Beyond Techniques, a new philosophy for complex PCI. We are especially honored to welcome our and colleagues from across the Asian Pacific region. To our international friends, welcome to Vietnam, welcome to Hanoi. I would also like warmly welcome our Vietnamese colleagues from different parts of our countries and to express our sincere appreciation to Tiêp and its leadership team for their collaboration and support in making this meeting possible. Dear colleagues, the title of today's meeting, Beyond Techniques, carries an important message. Interventional cardiology has advanced tremendously. We now have a better device, better imaging, better technology, and increasing sophisticated techniques to treat even the most complex coronary lesions. But complex PCI today is no longer simply about whether we can perform a procedure. The more important question are should we do it? How should we do it? And how can we achieve the best outcome for this particular patient? To me, this is the real meaning of the Beyond Techniques It means moving from technique success, judgment, better strategy, and better patient outcome. Today, program reflects this philosophy very well. We will discuss this area includes CTO bifurcation and classification, contemporary device strategy, drug-coated balloon, and resolver scaffold technology with case discussion and hand-on training. I encourage everyone, younger colleagues, to participate actively, to ask questions, challenge as speaker, and share your own expertise. Because a great scientific meeting should not only show us what experts but understand why they do it. For the Vietnam National Heart Associations, this meeting also represents something broader. Vietnamese interventional cardiology has developed rapidly, and we are increasingly connected with our colleagues across the Asian Pacific regions. We hope Vietnam become not only a place to learn new technologies, but also exchange knowledge, share experience, conduct research, and building long-term collaborations. Because medicine advances through the science, but science advances through the collaborations. Before we begin, I would like to thank all our faculty, moderators, panelists, like case operators, organizing team, and all for being today. Again, let us learn from one each other, challenge conventional thinking, and go to beyond techniques towards better decision, better intervention, and better outcome for our patients. With that, it is my great pleasure to declare Beyond Techniques, a new philosophy complex beside officially open. Thank you very much. I wish you all for a productive and enjoyable meeting. Thank you.
Thank you very much, Professor Hung, for your inspiring opening remarks and for setting the stage for today's scientific program. So, ladies and gentlemen, we would also like to express our sincere appreciation to Teleflex for their valued support in making this scientific program possible. Thank you for your commitment to supporting scientific exchange, education, and innovation in interventional cardiology. So it's my great honor to invite the Chief Executive Officer of Teleflex to be on the stage to deliver the welcome remarks. Please welcome Mr. Jason Wade.
How do I advance? Thank you and good morning. I'm Jason Weidman. I'm the president and CEO of Teleflex. And really happy to be here with you all this morning. Really honored to be here, and I appreciate the opportunity to speak to all of you. So, although I've met several of you over the years, good opportunity to start by just introducing myself a bit and helping you get to know who Teleflex is. So, I was originally trained as a biomedical engineer. Spent the beginning part of my career designing medical devices. And so I say that because innovation is incredibly important to me, and really the foundational way of which I manage is how do we make sure that we continue to innovate as much as possible. I've spent years working in cardiovascular, looking in interventional cardiology. The last 20 years I was working at Medtronic. And for about the last decade, I was running Medtronic's coronary and renal denervation division. I have a really long history working in Asia Pacific. A lot of time here over the past 2 decades, A lot of efforts to do market development, to train, bring new products to the region, and to importantly do a lot of clinical research in the region. And just recently, about 2 months ago, I decided to move over to Teleflex, and it's been a really great opportunity, and I'm excited to tell you more about it. For those of you who don't know a lot about Teleflex, we're a mid-size medical device company. We have 3 different divisions that we're focused on. We have vascular and emergency medicine, we have a surgical division, and then of course the reason why we're all here, an interventional division. We are a publicly traded company. We trade on the New York Stock Exchange. We sell about $2 billion in revenue every year, and we have about 10,000 employees worldwide, so we are not a small company. Now, before I get started, I actually wanted to ask you a couple of questions. And I just want you to think about the answers, or you can write them down on a piece of paper. There's no need to shout out your answers. But I want you to think about these questions. And the first one is, your procedures that you do are coronary PCIs, the low percentage, medium percentage, or high percentage. And the second question I want you to think about is, what is your familiarity like? Low, medium, or high? And I'm guessing that most of you, as you think about these questions, I would guess almost all of you answered these 2 questions as high and low. That the majority of the work that you do every day in the lab is a coronary procedure, but that you don't know too much about Teleflex. And so I really consider it my job up here to try to connect these 2 pieces, and that's what I'm going to talk about. And I'm going to start by saying that, and I would argue more than any other company out there, Teleflex is focused on and investing in coronary interventions and coronary interventionalists. And this is a very important reason of why I switched and came to Teleflex 2 months ago, is that I've always loved the interventional cardiology space. I believe in innovating in this space to make outcomes better. But to be honest, the big companies are not paying as close of attention to coronary anymore. They're just by things like structural heart, cardiac ablations. So I wanted to find a place that was still dedicated to coronary interventions and to making your lives better and the tools better. And that's what this is. This is a place that is focused on coronary, and a place where, and we really aspire to be your partner of choice in this field. And so if you're wondering who exactly we are, the way I think about is it's really a collection of a few different innovative companies that have now all come together under the same umbrella. So Teleflex itself, many years ago, we had our own small portfolio of interventional devices. And then about 10 years ago, Teleflex acquired a company called Vascular Solutions that was very important. And then last year, Teleflex acquired the vascular intervention business of Biotronic. That was important because what it did was put together a really complete portfolio that at this point, I believe, really makes us a coronary interventional powerhouse. To bring to you and what we want to bring to this field, I put it into 4 categories. And the first category I've already kind of spoken about, and that's really about focus. We are focused on this space, on the interventional spaces. We really understand the disease and your needs so that we can come up with the best for you. That brings me to the second category that we really tried to bring forward, and that's about a really strong and differentiated product portfolio. What you'll see from us is a lot of unique devices that solve real problems that you have. Thirdly, we're incredibly committed to generating clinical evidence to really prove the value of our products. So across our drug-eluting stents, our DCBs, our resorbable scaffolds, we've enrolled tens of thousands of patients to really prove out that our devices work as well as we think they do. And then finally, we are absolutely committed to deliver best-in-class customer service and training and education. So we strive to get better every day. We're open to your input. You tell us how we can be better, but we want to be focused on you. And I can tell you throughout the world, Teleflex has long generated a strong reputation for our training programs and really bringing up the skills of physicians across the globe. Now, in doing all of this, we have been focused on Asia Pacific, but I would say now going forward, we're becoming increasingly focused in Asia Pacific. So to give you some examples, if we look across all of our DES trials, about 30% of the patients that have been enrolled were actually enrolled in this region, in APAC. So right now, about 15% of our sales, so only 15% of our sales, comes from the APAC region, but it's rapidly increasing. It's our strongest and fastest growing region. We're growing almost at 20%, and we expect that growth to continue, very high growth, with a lot of focus and resources put into this region to ensure you get what you need from us. You know, since I've come to Teleflex, and as I've spoken to interventional cardiologists, what I found is probably the biggest surprise that people don't really understand just how large and extensive and differentiated our portfolio is. And I would argue we compare incredibly. We really address the full continuum of care, starting at access. And I think that when you think about a strong coronary portfolio, it does really start, though, with that core product that every company has to have, and that's a DES. And I'm really pleased that DES with the ultra-thin strut for cyromission. This device was designed to provide deliverability and ease of use. And what I think is underappreciated is that it's actually one of the most well-studied DES products across the globe. So it's been studied in well over 7,000 in clinical trials, including a randomized clinical trial versus Xience, in which Cyros showed superiority in STEMI patients. Now, we continue to invest in this platform, continue to enroll new patients in new clinical trials, and we have new sizes coming out soon, so extra large diameter stents and extra long stents. But I think what's most exciting to me about Teleflex is that we invest in those important to you in your practice, even if a lot of other companies are ignoring those areas. And so I'll call out three specific areas here today, and that's complex PCI, managed scaffolds. So from a complex PCI standpoint, I can tell you that over the last 10 years, whenever I've talked to interventional, like the very first thing, almost always, that someone will say to me is that my patients are getting more complex. There's more calcium, vessels are more tortuous, the simple patients and the simple lesions have gone away. And so there's a need for more tools that are specific in these cases to help you with complex PCI. And Teleflex has long been dedicated to this space to provide those better tools. We were the company that pioneered guide extension catheters with GuideLiner. We've developed countless other complex PCI catheters like TrapLiner, etc. You'll see several of those outside in the hallway. We're continuing to be dedicated to this space. We have several new complex PCI under development. We'll be excited to get those out into the market, to launch them across Asia Pacific here in the future. Another area or clinical situation, it doesn't happen that often, but when it does, it adds a lot of stress and has some very serious clinical implications, is when you run into a complication, such as a perforation. Now, this is a low frequency event. It doesn't happen often, so it's kind of a niche area. And so again, most companies have just ignored it. It's been too small for them to worry about, but not Teleflex. We understand that although it doesn't happen often, when you have a complication, you need to be best prepared in order to treat your patients. And so we have not just one device, but a portfolio of devices to help in these situations when you run into a complication and you need to be rescued. So for instance, we have the PK Papyrus covered stent. And recently we just launched, starting in North America, the perfusion balloon you see on the screen called Ringer. So we're actively in the process of putting the plans together to develop or to bring Ringer across the globe and to launch in other countries in Asia Pacific. And we'll be excited to get this out here. And then finally, I'd like to touch on the area where we and that's in resorbable scaffolds. Ever since I've been in industry, probably the biggest dream in interventional cardiologists is to develop a stent that can do its job and then go away when it's not needed anymore. So that interventional cardiology has been trying to accomplish for decades. Anyone know what the first absorbable stent was that was implanted in humans and when it happened? Sydney. Yes, it was actually the Agaki Tamai stent implanted in 1998 in Japan. So the advent of absorbable scaffolds actually happened here in APAC. But despite that happening almost 30 a mainstream workhorse absorbable scaffold. And that's because it's very, very technically challenging to develop an absorbable product that performs as well as a contemporary DES. And the reason why it's so challenging, the vast majority of the past attempts at absorbable attempts have been with polymers or plastics. And simply put, it is going to be very difficult, if not impossible, to be able to use a plastic product to perform stent. And that's what really sets Teleflex apart, is we've taken a very different approach to this, and we've developed an absorbable metal scaffold. It's been under development, we're multiple generations ahead, but we're very, very confident in R&D team of what they've accomplished thus far, and I'm excited to see how. So far, we have very promising clinical results for Biomag 1 rates after 1 year. But obviously, what we all really want to see is how does this device perform head-to-head versus a DE in the first large random with Freesolve versus Xience, about 2,000 patients. We have finished enrollment. And so we'll see the primary endpoint results of this trial sometime late next year. I think the opportunity for this field to start growing again and to provide the solution that people have been looking for decades. Now, I'll just end here with one request of all of you, and that's that we need your help. So we've gotten to where we are today because of our close collaboration with all of our clinical partners, with all of you. And so as you spend the next day here at this meeting and you see and talk to other Teleflex employees, my ask of all of you is to tell all of the Teleflex employees, tell us what you need, tell us what your challenges are, and tell us what Teleflex can do to help you. We want to get better. We want to provide the tools that are needed for the field, but we can only do that with your help. So I'd ask that to happen, and I look forward to those conversations. I look forward to spending a lot of time with all of you over the next 24 hours or so. So thanks again for having me. Have a wonderful day.
Thank you very much, Mr. Jason Wayman. Today's meeting will have 5 sessions, including the 2 live case sessions listed on the screen. And before entering the official scientific session, allow me to introduce a corner beside gentlemen. Coffee is more than a drink in Hanoi, and it is a way of life. And during the break, we warmly invite you to visit our Hanoi corner, where our barista will freshly prepare a selection of Vietnamese coffee for you. In particular, if this is your first time in Hanoi, we highly recommend taking a moment to try egg coffee, a truly distinctive specialty of Hanoi, featuring rich Vietnamese coffee topped with smooth and creamy egg foam. You can also enjoy other Vietnamese favorites, including Vietnamese iced coffee, salt coffee, and cold brew. We hope you enjoy not only the coffee, but also a little taste of Hanoi. Please feel free to visit the Hanoi Corner and enjoy a taste of Hanoi during the break. So thank you very much, and let us begin our first scientific session. The first session is Managing Complex CTO. It is my honor to introduce the moderator, Professor Phạm Mạnh Hùng and Professor Lê Song, and also the panelists, Dr. Đinh Đức Huy, Dr. Rong Chong Huang, Dr. Jeffrey Chua, Dr. Viwat Khasana Ruzawiwat, and Dr. Đặng Duy Phương. Please welcome our chairs to lead the session. I wish you all a productive, engaging, and inspiring meeting. Please.
Okay, welcome back to our first session. So I'm Professor Phạm Mạnh Hùng from Vietnam National Heart Association. My co-chair is Professor Lê Song from China, and we also have a panelist, Professor Rong Huang, Dr. Đinh Đức Huy, Dr. Jeffrey Chua, Dr. Viwat, and Dr. Đặng Duy Phương. So for the first speaker, I would like to introduce and invite Dr. Sidney Law. We give a lecture about the new look at the enterprise for CTO.
Good morning. Thank you very much for the invitation, and I'm very happy to be here. First time in Vietnam. And of course, all the best things are happening in Asia right now, and so everyone's coming. So thank you, Teleflex, for organising what is promised to be a very educational event. So my brief is to talk about new insights and integrated CTO-PCI strategies and maybe an update. Now, we've learned a lot from the Japanese, particularly because they were in a unique position to identify a clinical need and then actually work with companies to advance the equipment necessary to perform a CTO-PCI, including the development of very pioneering wires such as the Miracle and the Conquest wires in the late mid-1990s. And commensurate with that, they developed microcatheters. Of course, the Corsair is the pinnacle one, and now we've got many microcatheters from Teleflex as well, Turnpike Spiral being a very popular one, and the imaging, the use of IVUS, and technique. Now, we moved very much from the integrate to the retrograde approach you can see here around 2005, 2006, and subsequently algorithms such as thinking about PCI, the thinking changed a lot with the hybrid algorithm, the review of the angiogram, for the CTO, and the ABCTO algorithm some years later, and now, of course, a slew of new ones which have been very useful, have made success much more approachable in the antegrade approach. So we move from antegrade. Now, mind you, at the same time, the risk of a PCI goes from a non-CTO PCI to increased risk with an antegrade CTO PCI, and even higher with a retrograde CTO PCI. So intra-procedure, you move from antegrade to retrograde, and you can see the wires help you in a technique such as cut and reverse cut. But the algorithms have reorganized how you think about it, have improved our success. And you can see that that is the movement. And in fact, the hybrid operators suggested you're stuck in failure mode, which you're failing in the antegrade, you move to retrograde. You fall in the retrograde, you move back to the antegrade. And so it is an attention deficit disorder, depending how much time you spend in each approach intra-procedurally and about risk. Now, the ABCTO Club spent a lot of time thinking about risk as we formed many years ago after the algorithm, and we have a global consensus recommendations on the safety of CTO-PCI because, mind you, we want safety for the patients. And it's a bit of a triangle. It's an axis of triangle, and we see safety being primary in this particular triangle, and you see speed, which is just the efficiency in the cath lab, how many cases I have to do, how many CTO-PCIs I'm doing today, versus, of course, success, which is very seductive. But mind you, the risk is dynamic, and during a case, you may decide to abandon. You may decide to move forward. You may decide to move backwards. You might decide to stop. And so this is a bit of a spiral and a triangle which spins around during a case. We have now refocused on the antegrade CTO techniques because CTO-PCI, there is no retrograde approach possible, or in a failed retrograde approach, all you have is antegrade. And of course, for simplicity, if you can do a great PCI this way, method. Mind you, the antegrade approach has never. The antegrade wire escalation remains the most commonly used strategy, as you see in some registries, Euro CTO registry, the AP CTO registry, recharge, and an open CTO. Now, I'll go very briefly, because I don't think I have a lot of time, about the thinking involved in the antegrade CTO PCI, 3D wiring, which has become particularly popular in the last 5 years, HDR, tip detection, ADR procedures. The conceptual thinking in the antegrade wiring has changed. So anatomy dictates strategy, function dictates choice, precision dictates success. These are very logical, necessary, beneficial even, and seems to be very correct in your mind. It represents the frontier of antegrade CTO PCI. So this is anatomy dictates strategy. So the way you approach how you're going to do the CTO, particularly, for example, the proximal cap ambiguity on the left upper corner, that I can actually move the cap, or you can actually use intravascular ultrasound to reduce the ambiguity in a case. You can have this very complicated looking slide about CTO crossing from the global CTO recommendations, and you can see various maneuvers like stick and swap, retrograde options, moving the cap and using side branches, etc., and attempting intravascular ultrasound imaging. So you can see here the CTO body, it can be tapered and soft or blunt and long. You may have maybe an old stent occlusion, which is very clear where the path should be, or a long, what we call long plus. Preferentially, can do certain techniques, for example, a retrograde knuckle wire with interval subinterval tracking, or intentional interval tracking in a blunt and long. And now we think maybe if you can see the distal cap or inside the stent, maybe you do 3D wiring, or if it's tapered, just use loose tissue tracking, which is a mainstay of the technique. So rather the question of which CTO wire should I use, it's more like, what do I want the wire to do? And so this is a very conceptual idea. I want to do this. This is the wire I would choose to do it. So do I want to do loose tissue tracking, intentional tissue wiring, 3D wiring, or subinterval tracking? So this is kind of the things. So conceptually, in the old days, XTA, for example, was designed to wiggle through these spaces in loose tissue and move towards and stay in the vessel, move towards the distal cap. But now we've moved towards using a Gladys EX or a Miracle Neo 3, and intentional tracking, more penetrating force, with Gaia wires, now Gaia Next wires and Ultimate Brothers wires, intentional subinterval tracking, we want wires that can knuckle and not go into subinterval space, color 200, glass EMG. And of course, 3D wiring, we need really stiff wires. We're looking at Gynex 4s, CP12, the Conquest Pro ST, more tapered and much sharper, and 840s. So this is a CTO body, and you can see the techniques involved. And of course, now we're looking at 3D wiring. Even for the blunt and visible, you can see the distal cap. Conventional wiring, if it's tapered and soft, and of course, we can step down all through 3D. And 3D may be applicable for a lot of these anatomies. But this is 3D. So who invented 3D? I guess Dr. Okamura is a mainstay person. But the adoption of this technique after 10 years was pretty much zero around the world because we cannot remember these positions that a wire can be in your artery. And of course, things like same in front, opposite, behind. We fail to understand the logic of this. Even though well-published, seemed to be very effectual. So we wanted to use the X-ray and the angiogram. So the ABCTO Club, after having reinvented ourselves, decided that we would focus on antegrade approaches, and we developed what they call the ADAPT wiring technique, angiographic 3D antegrade puncturing technique. This did not need the operator to make a 3D picture of where the arteries are, but we need precise rotation. So as you wire towards the distal cap, mind you, the key thing is to be able to see the distal cap. So it does require injection of X-ray dye, or if there's a red-gray wire, but we need to see where the distal cap actually is in at least two planes. Mathematically, you can actually correct for the distance between your shaft of your wire and the trajectory towards the distal cap, and you can adapt it. You can see that these are kind of the possibilities in antegrade and retrograde. Retrograde wire, you can maybe wire towards the balloon. See the colleague had developed what's the tip of the antegrade balloon. It's called end balloon wiring. But anyway, you want to be precise about how it maneuvers towards the heart. In stenosis, rotating as much as going forwards, need to be at least pretty close to it. However, the adjustments in ADAPT are very, very small. And so very, very small amount of rotation. It takes a finesse to be able to do it. But most of the time, it's really unclear if you're overcorrecting the situation. So when do we use it? Well, we need stiffer wires, particularly Conquest Pro 12. And really, if your first wire is subintimal, we try not to do parallel wire these days and try 3D if it's possible. How do you do it? We've actually advanced the ADAPT now in the last few years to what they call solution. Wiring is a zero overlap view, universal three-dimensional wiring. It allows us to actually correct and not actually have to correct so much because change scenario, but we need lots of backup, coaxial anchors in the microcarrier. Have the correction. So as you can see here, these are X-ray images, the up and down segments, the mid-right coronary artery, the mid to distal LED. They use the LAO, RAO, this is the red arrows in the angiogram, and horizontal segments of the left main, the proximal LED, the proximal distal right coronary artery. In the green arrows, use LAO cranial and LAO, such as PLV circumflex, use the RAO caudal and the LAO cranial. They're the ones in the blue arrows. Now you can find this out in this. I hope that plays. Okay. If it plays, this is the plays. Hope it plays. Here we go. So essentially, you can actually, if you have angiography, is quite helpful. But if the wire positions are on different sides, of course, soft view is in between the two views. If you're on one side of it, it's further away from the nearest view. Use the X-ray to find out where the zero overlap is. And this is quite important because we straighten the tip of the wire in the ZOF view. So you straighten it out towards a target, otherwise. And then essentially you go to a view now 35 degrees to 70 degrees opposite to the ZOF view, and then you look at the trajectory of your wire, and when you rotate around to the target and just advance. So if you completely around, rotate to 180 degrees until the wire is re-straightened, and then you basically then puncture. So you're sort of within 10 milliliters of distal cap for the advance. So the tricks of these things are just and it's quite quickly, but the views keep changing on you and you have to keep correcting it. So this is taking aim, such as Mr. and Mr. Smith here, and so aim is better than no aim. Of course, IVUS TD ADR, tip detection. If you have a CEDA-specific IVUS, that's really good, but we're not really parallel wiring Stingray or conventional IVUS wiring anymore. And if you fail, I think we're talking STAR, Mini-STAR, or LAST as an investment procedure. So this is a very hard model, the ETOS 1000, and we notice that barely any wire gets through this. Canvas is doing this for us. I'm going to play this. And on the right-hand side is conventional wiring. On the left-hand side is Zoft or solution wiring. And Canvas is one of the busiest CTL operators in the world. You'll notice when we correct for the 3D wiring in Zoft view versus conventional wiring, is that conventional wiring tends to be more close to the vessel wall, whereas it's more centralized in the Zoft wiring, solution wiring is much more in the middle of the vessel. And you can see that whereas the last bend on the right-hand side, actually you see in a minute, it will bend, it's more centralized. So because we actually maneuver, it cones down as your wiring. Keep changing is off, it cones down so you're more central in the vessel, whereas conventional wiring will take you outside of the vessel. And you can see that it's much more central in the left-hand side, and you shortcut that last bend in the right-hand side. So this is a Japanese approach that's been worked out for the penetration plane method. So if you know the axis the wire is parallel with, that is the PPV, which is the perpendicular penetration. This is the OPV, which is the orthogonal view for the orthogonal perpendicular plane, because orthogonal plane would show the depth and the distance to the distal cap. So notice that they always puncture in the PPV, but they adjust in the OPV. These are the planes that are involved, OPV and the PPV, the penetration plane. There's software made by Asahi Intech called Espelux EDU. This is now currently version 2. That will allow you to take your DICOM pictures and make and actually give you the angles. These are angles not 100% achievable on occasion. It's very similar to TAVI CT in calculating the coplanar view of the virtual annulus. So you can see here on 2 views, the arrows are the axis, the vertical axis of the coronary artery, and you calculate this best for the 2 UPV on the software system. And so they can actually mark it like so, and then you can actually go and do the procedure. Now, this was largely invented for the plasma wire, which is not currently available. It does mean that you choose to a further degree than you have in the past, able to identify the distal cap without contrast. Recently, we've seen a redevelopment called this is the hydrodynamic contrast. People would say this is a rebranding of mini color. And you can see that directly injecting, hopefully intraplaque, some contrast will actually allow you to visualize the course of the vessel, sometimes the bifurcation, and just different types of HDR patterns you may reach. Now, the problem is, if this is now developed into what we call a contrast-first strategy. Now, most people don't want to do the contrast-first strategy because if you are subintimal, it's a big space, and that is incredibly difficult to control, and that can end your procedure, unless you're a very clever operator into tip detection ADR, because that's the bailout. A failed HDR is really tip detection, IVUS directed antegrade dissection reentry, single guide technique, versus a retrograde bailout, which you have a retrograde option. But the rebranded Carlino minimize the number of contrasts. The contrast is probably not more than 0.3 cc's. Sometimes it's just enough in the microcatheter as you're moving the wire. That's as much contrast as you're allowed because you minimize subtraction. But we normally, and we have been in the last 10 years, reserving Carlino, which is stuck in a CTO case, rather than contrast first. Remains to be seen, but unless you're totally skilled, all the bailouts probably not in most people's hands at this point in time. The tip detection ADR is really using IVUS catheter, visualizing directly your true lumen, and using a maneuver, a very much slipping back and forth of the IVUS imaging to allow a very stiff wire to penetrate into this to the true lumen. It is a two-man operation, generally speaking. You need the imaging person is more important than the guy poking with the wire. So the first operator is just doing counterclockwise, clockwise, really directed by the IVUS operator, going back and forth, checking the front and distal end of your wire, and puncturing through. What we really need is a good IVUS system. And so in Japan, they have the Terumo system, the anti-owl, and that's been a mainstay for them because it's very slippery. You can try a Boston system, but we need very stiff wires, which is generally available by most people. Most people have a CP12, but not an ST. Most people may have an 820. So the tricky here is that you can do a zip lock around the Boston Scientific IVUS catheter and cut the tip. Not usually recommended, but basically the non-imaging tip, and just use that. And then it makes it much easier to slide back and forth repeatedly in the procedure. Okay, that's the Conquest Pro ST wire, very, very tapered. Looking at the last 5 years' experience with TD80 in Japan, it is incredibly quick, incredibly successful operator hands. It's something that everyone is trying to learn at the moment. So look at, there's a tip detection intraplaque tracking versus tip detection ADR. So sometimes you think it's stuck, but the IVUS tells you you're actually intraplaque. So the IVUS, so this is actually wires are intraplaque, and it's even faster. It takes them 6 minutes to get true lumen to distal. And then if you're doing TD-ADR, it takes them 7 minutes. Expert Japanese operators. Mind you, the numbers are small, but it's a very quick procedure, safe, no complications, and they use more wires. So very vendor friendly, but essentially a stiff wire. So you can see also the now it's everyone's trying to do this in a failed antegrade case. If a wire, I was direct. Just clinical update for everybody is Orbiter the randomized control trial CI work control. It's so meticulously performed that they remove clocks so then the patient time is, I don't know how much time they spent because traditionally it's 4 hours in the cath lab. Much like Euro CTO trial. So there's no doubt it's beneficial for patients. But this is the other interesting trial because it's called STAR. If you fail a CTO, what do? And for hybrid operators, you basically just knuckle your wire proximally and try to let it go, come back. So this was just testing if you came back at 5 to 7 weeks, 14 weeks, what is a 6-second procedure? How much are still open if you're early or late from your primary procedure? So testing maybe CTO PCI a lot of the time in complex cases, maybe it's a 2-procedure success rather than single procedure. The primary endpoint was negative, P equals 0.08, but it did suggest that more of these people were open by the investment procedure, or a flow, it came back earlier, 5 to 7 weeks. And the technical success rate early was a trend towards coming earlier, having better success, but it's still a negative trial at this point published. So, thank you for your attention. I'm glad to be here. Thank you for the comments.
The lecture, I think, as we go after all the speaker today. So the next, I would like to introduce and navigating city.
Thank you for the invitation to be here to present my topic is advanced. Today I will focus on the tortuous lesion and CTO case. This my disclosure. Moderate severe tortuosity is not an uncommon issue in our everyday practice, and I think particularly in CTO case, about 30% of the procedure is moderate to severe tortuosity. Tortuosity is associated with a higher CTO score, the longer fluoroscopy time and procedure time, and it also, more importantly, is also associated with the higher in-hospital MACC driven by rate of the malfunction. The tortuosity is not only a problem of the efficiency, but also the safety. And I think so the question is not whether we should use the microcatheter, but how to choose appropriate microcatheter in complex case. So the microcatheter have several tasks, including to enhance the get wear support and steering, and allows the wear easy to escalation or de-escalation, and direct the reshape the get wear tip, and depending on the anatomy, and help we also can use the microcatheter to do the microangiography and drug delivery, and protect the collateral during the retrograde approach. And in other words, we can use the microcatheter to move our operation base more forward, to more close to the lesion, and makes our operation of the wear to a more controllable system. The market now we have over 50 different microcatheter, in even more than 30 microcatheter we can use in coronary PCI. But the question is how to choose. And we should, depending on anatomy, the property of the microcatheter. The first parameter is the sizing profile, including the tip profile and the crossing profile. And the operation of the catheter is depending on its construction. For example, for the push only, not the rotation. For the corsair and other, we can rotate it clockwise. And for the turnpike, on its construction. Let's make an example based on the family, and to explain how the construction defined how we operation that. So the design of the turnpike family have to facilitate the road wear movement in the lumen, and the braid layer and the dural coil to permit this microcatheter can rotate direction, including counterclockwise, and the polymer layer to make the movement crossability is more easier for the operator. And using the one platform, the turnpike family have different use in different scenario. But regular turnpike is a workhorse microcatheter in regular and turnpike LP is appropriate for some very tiny tunnel and very resistant. The turnpike spiral is for fibro calcium plaque, and the turnpike like high resistance. And the tip and very tiny, very small tip is available for some small vessel, very tiny collateral, or some very small, very tight, very narrow regions. So, but the tip profile is not everything. Sometimes the crossing profile is also important. Sometimes the tip already get into the lesion, but the catheter cannot cross. That's why the cross. The question to appropriate catheter. We recommend that based on the anatomy, based on the tasks of our microcatheter, is generally used captain's lesions. The second question is the torque transmission. For some regular use, we can just push the microcatheter. For some very high risk, high need to torque in the high risk and calcium lesion, we need the straight delivery of the microcatheter. And for the regular use, for most of the cases, the fan cross, super cross, inside pass 1.9 French can meet our requirement. And for some very high risk, higher resistant lesion, then we need turnpike gold and toner's microcatheter. Some is a channel in the retrograde approach, and the special feature is that and lobulus the surface and the low crossing profile. And for some regular case of the retrograde or antegrade CTO case, the corsair pro turnpike head approach is useful. This technique. This catheter is wonderful balance the support and the crossability. And for some very fine collaterals, so we need coverall, we need a turnpike LP, the member flex sometimes. And for them very resistant lesion, gold or member is useful. And so the operator should balance the trackability and pushability. For some flexible the lesion, but only the torturers, and I think the trackability is device specially designed for the favored trackability. But the support, the force moving forward may be less performance. But for the pushability, for the device special designed for the pushability, I think like the torture, the turnpike gold, but maybe less performance in some torture situation. So after the gateway crossing, but microcatheter cannot cross, what we should do? We recommend to follow a structure algorithm, like the increase the support, use different microcatheter, dilate collaterals channel, or use different catheter or different strategy. And so we recommend to, if your progress have already stopped, you need to stop and thinking. You think and your next step. Okay, maybe worked, and this is the case. This RCA occlusion, and the operator crossed the epicardial channel, but the Corsair microcatheter stored in the mid of the collateral. And then we performed LVD balloon anchored, so increase the support of the guiding catheter, and the Corsair can cross the epicardial region. And this is the second case, RCA occlusion, the septal where the septal channel where I crossing, but the Corsair also stalled in this situation. We used an antigrade balloon to anchor the retrograde wear and push the retrograde Corsair to cross the septal channel. The increase is useful. And if it's not worked, we can use a microcatheter. This is the case also RCA occlusion. You have a very tortuous epicardial lesion, epicardial channel, and the seam wear can cross the channel, but the microcatheter also stalled in this very tortuous channel. So we changed to a fan cross. It's a very flexible, successfully cross this tortuous epicardial channel. So another option is that we can, and this is so the seam wear cross the septal channel, but the Corsair microcatheter cannot cross. And we use the 1.25 balloon, use a low pressure 8 atmosphere to dilate the. But it's depending on your confidence. You must, the operator must have full confidence of the wear position. Your collateral channel is big enough. You have some risk to injury of the vessel. Another option is that we use a different collateral. This is another example, also RCA occlusion, where has crossed the channel, but the Corsair stalled. We also use a 1.5 balloon to dilate the channel, but also the fan cross microcatheter, but still stalled in the channel. That's for this time, this situation, we change another. Now, if we keep what we do, like increase the support, use a different microcatheter, push forward, maybe cause the injury, maybe cause a complication. So we change another collateral and cross the microcatheter crossed. So change another vessel abandon this channel that cannot cross, that means a failure. It's active, it's a smart choice to avoid your injury, your complications. And finally, you can change your strategy. This is another example. They are also RCA CTO, the Corsair store, and so we totally changed the strategy, not retrograde, but anti-grade, using ADR technique based on the guidance of the retrograde wear, and successful. So, as a summary and take-home message, we recommend use the microcatheter routinely. It means that we move the base of the operation more distally, more close. And second, let anatomy define your task and let the task choose the catheter. And consider the profile, the breathability, the talker, and support. And importantly, in thoracic and the flexibility is more important. I think it's more important than the sport. And when the microcatheter cannot cross, you should stop. You should stop and think why, what happened, and stop pushing and start thinking is more important. And follow algorithm, escalation systematically, and support, and change your catheter, maybe change your channel, and maybe change your strategy. And thank you, and 谢谢。
Thank you so much, Professor Lei Xiong, for a very about using the microcatheter. So the next, I would like to introduce and invite Dr. Primero Hongyi Ng. We share a CTO case.
Good morning, all. Thank you for the invitation from the organizers. Thank you for the Flex for helping sponsor this event. Can I have my slides, please? So I've got two cases that I would like to share with you guys. I currently in Royal Perth Hospital in Australia. This one is a 64-year-old female with recent PCI of the referred for CTO PCI for revascularization. So these are the baseline door and geography shots. As you can see, it's an RCA CTO with kind of an ambiguous cap, but quite good contralateral collaterals coming from the septal branch, but it's quite a long, complex CTO with almost a marginal branch at the proximal cap. So we adopted a primary retrograde approach given the ambiguity of the proximal cap. We utilized a turnpike LP, a low-profile microcatheter, and a Xion black wire, and in very short time, managed to gain access to the distal right coronary without any problems. Then we switch our attention antegratedly, given that we have secured the distal wire, the strap liner and the pilot 200 wire. We managed to get into the subspace in the using the polymer jacketed pilot 200, and we had overlapping wires just at the mid to distal right coronary artery. We dilated antegratedly with a 3 and tried to reverse, but and was quite unsuccessful despite multiple attempts. And I think one of the main reasons for this is because the vessel itself and the subintimal space was quite big, and therefore, whenever we tried to wire the integrate trap liner, the retrograde Gladius MG kept sliding outside and basically could not make the connection. So what we did was that we had a ringer on the shelf. So we used a ringer balloon to basically try and wire antegratedly in 5 French trap. And it's managed that in very short time, within 2 minutes, we managed to wire the antegrade guide through the trap liner, as you can see, through the ringer balloon, whereby the wire just goes from the subintimal space into the ringer balloon and to the antegrade guide. And after that, we managed to externalize the R350 wire, converted to an anti-grade approach using a dual lumen catheter. And this was the result, which was good. So a little bit about the ringer balloon. The ringer balloon is a perfusion balloon that is designed for perforation. Essentially, it looks like this. And it takes a while to kind of inflate, but essentially what it allows you to do is to perform balloon tamponade without sacrificing ischemia. The ringer balloon is one of cases that, as you can see, there was an LED, a little bit ambiguous, completed the procedure, post-dilated, and you can see in this slide here, there's a large perforation just at the proximal LED. And what we did was that we basically got a 3-5 balloon with a 7 French guide liner in 30 minutes with no ischemia whatsoever. And this was the final result with no covered stent needed in the LED with a satisfactory result. So how does a ringer balloon actually help in reverse cut? Well, the largest internal diameter of an 8 French guide extension catheter is actually 0.07. But a 3.5 millimeter ringer balloon is actually 0.079, and a 4 millimeter balloon is 0.099. So the larger the target, the easier you can basically complete your reverse cut. As you can see in this diagram here, if the guide extension is this size and basically the subintimal space is quite big, the retrograde wire itself will keep sliding outside of the guide extension catheter. But basically, the advantage of the ringer balloon is that you can compress the surrounding tissue, offer a bigger space, and the radiant and basically improves the efficiency of the procedure. And time on table is equivalent to the shorter the time that you can have on the table. So essentially, another case that we did was a Circ CTO, as you can see, ringer balloon and cardio, and essentially the retrograde wire was able to just go into the anti. We actually published this as a case series in Euro Intervention. Basically, we call it R2 CART. Next, a 3-year-old male with angina with previous CABG, lima to LED, vein graft to diagonal, vein graft to RCA, and referred for PCI. So this is the vein graft to the RCA. We did a baseline, and the MLA was 2.34, and it was quite calcified, so we basically proceeded on to perform PCI of the vein graft. We used a intravascular lithotripsy balloon delivering 120 shocks and basically achieved a good result. And we stented it with a 4x38 millimeter drug-eluting stent, achieving a pretty good result actually. But unfortunately, we got greedy. We performed, and best here was 7.5, and the largest area was 13 millimeters squared. So we were like, why not? Let's just post-dilate them further. I think perfection is the enemy of good, and this was the next picture. So there's a large perforation in the proximal vein graft. Thankfully, the patient was pretty stable. So what I did immediately was basically get the balloon back in. But unfortunately, the reasons for that is because this was a paper published by Jai Catheri's group, whereby you can see if there's a perforation. Often you think that the perforation is quite distal, but it's actually the perforation a lot more proximal. Suggest where the perforation site is, do an injection and see whether there's ongoing extravasation, because more often than not, the source of the bleeding is quite proximal. So we performed proximal balloon tamponade of the vein graft. Quite ugly picture, but the patient was pretty stable, and we stopped the bleeding. And we utilized a 4.5 by 26 millimeter papyrus covered stent produced by Teleflex, and essentially achieved quite a good result. But given a covered stent in a vein graft and a kind of a craggy looking vein graft as well, we decided to bring the patient a native vessel PCI of the RCA CTO. As you can see, dual angiography, the vein graft is still open, the covered stent is still open, and it's kind of a complex RCA CTO, small RCA with quite an ambiguous cap. What we did that we used a turnpike spiral, which is quite good in this case because it's basically the only microcatheter in the market right now with spirals and little coils at the front. It was quite a calcified vessel, but it basically enabled us to track the calcium quite successfully. And using a polymer jacketed wire, we penetrate the proximal cap. Retrogradely, but despite using a dual lumen catheter and a supercross wire, we could not wire the vein graft retrogradely. As you can see, the vessel angle is quite acute, and so this is not surprising that we could not gain access retrogradely. So what we did was that we switched antegradely and we can here the pilot intimal space, advancing it with the microcatheter here. And as you can see over here in the second picture, we knuckled the pilot 200 of the subintimal space and was able to wire the distal RCA. Then we switch our attention to the vein graft, and essentially, as you can see, the distal knuckle, the knuckle is actually dancing with the kind of distal cap, and we put two wires down, one down the vein graft into the RPL branch, and one down the vein graft into the RPDA. And we facilitated AD. We put a balloon at the RPL, and basically, because we were in the subintimal space, the balloon was able to provide us with a target to the PDA. As you can see here, the wire was aiming at the balloon, and there it goes into the same thing for the RPL. By balloon in the RCA, to the vein graft, the RPL, and essentially use that as a target. As you can see here, the wire was able to wire from the vein graft into the RPL without any issues. Thereafter that was just IVUS guided PCI of both branches. And this was the final result, which we were quite happy with. In this case, we didn't coil the vein graft, but in most cases, we actually will coil the vein graft to reduce any competitive flow. So conclusions, essentially, the subintimal space is not failure. It's actually a workspace if you know how to use it. Number two, expand the target. So for example, an 8 French guide liner not big enough, the ringer balloon actually offered a solution. Expand the target, make the target bigger. You got to fail faster, like Sydney said before, recognize early if antegrade's not working, go retrograde. If retrograde's not working, go antegrade. And make your tools work harder. One of my mentors used to say, you do not know a tool until you use it until it breaks. Adaptability beats persistence. CTO PCI is not a strategy CTO PCI is a strategy problem and not a wire crossing competition. And intra-plug wiring is important still, it's the foundation, but extra plug mastery expands what's possible. Thank you very much.
Thank you. Thank you for your wonderful presentation. And next, please invite Dr. Ran Wan Tan to give your speech about complex PCI case sharing. Thank you.
Dear Chairman and panelists, ladies and gentlemen, I'm very happy to here to share my case in my hospital, which can still is only the beginnings, revascularization and osteoarthritis CTO in the vast labs coronary system. I'm from Thống Nhất Hospital, Ho Chi Minh City, and University of Medicine Pharmacy, Ho Chi Minh City. So my case with a clinical presentation on elderly patient with non-STEMIs, 92 years old, diabetes, hypertension, CKD, and DLB. In that presentation with the non-STEMI 5 and the KLIP1, hemodynamic stable, and holes. In this case, we want to achieve complete myocardial evacuations whenever technical feasible. So the first coronary soul here, we can find here, so the dissection from the arterial ligament to the distal related to the church, and the CTO from the arterial. We find the heavy calcify in the proximal to the MIC LAD. In another view, very clearly the dissection from arterial and the right side in the right coronary artery, so it's normal. So we look at the collateral from the right side to the left side clearly with raindrops 2 to 3. In this case, we listen to Triết first, left main, CTO, CBC medical therapy. So after we discuss with his family, and the patient denied to the CBC, so we continue to have the decision to the stenting and the CTO first, and then we complete left coronary reconstruction. And the crossing to the CTO, the first steps towards complete left coronary reconstruction, and we have planned to be a frog with interest by escalation. The first, I think that we should frog the audio LD CTO. The problem here, so the distal to true lumen, very important because dissection on audio left main and resolve left main bifurcation and the edible complex pre-construction. So my plans dual femoral access with safe frame in the right and the left side with a 6 frame, and we want to control lateral right injection. We get in EBU 3.5 to 7 frame. And the first, we try to cross the guide wire to the church, and after that we use IVERS to identify true lumen, the audio left main to the audio left main to the church, and after find out exactly the true lumen, so we continue to rewind one wire to the side front. Side front, maybe the audio go to the framers front. So the next, we use the guy second, but unsuccessful, and then we reply to the guy third with caravel microcatheter. After the time, we successful pre-plot to the audio stem to the distal AVD. So we use very small balloons, 0.S to 10 balloons, and the professional balloon upsize, and we did the rest of the SRS LD flow. After finish, so we use IVERS access LD to left main. So very heavy calcified from the distal, the mid LD to the left main. So we use scoring balloons, 3Os, and then we use NC balloons. After we prepare the lesion show here, so we find out the complete lesion from the left main to the LAD, left main to the source, and the fistula from the side front and LD to the maybe pulmonary artery. And so we continue to BCI in this situation. At that time, maybe the left main bifurcation lesion, very complete bifurcation lesion. So how should we reconstruct the left coronary system at that time? So we use the nano cross techniques with IVERS guided, stenting with S3O, 3-4 milliamps, and the left main stenting with DS. Maybe in this situation we use the 3O or 3.5 and the SMM based on the IVERS result. So the final kissing balloon and the pilot balls in the 4 euro. And this so IVERS, so everything is okay, and the IVERS result so excellent. Maybe no dissection in the edge of the stent, no apposition, maybe apposition another. That's the final result here. So flow from the left main to the LAD and the source. And so maybe a moderate fistula from the LAD to the pulmonary lipids. And even if for the CTO recalculation for the first step towards the left coronary reduction, I was confirmed true lumen asset and the guy the evacuation treasury through the procedure. Test CTO first approx enable set and effective left main LAD source bifurcation BCIs. The ultimate goals for the complex pre-construction of the labs are not simply successful zero regeneration. Thank you for your attention.
Thank you. Thank you, Professor Ran. Here we can discuss some about this section. We have a wonderful panelist, and if any audience have any question, you can raise your hand. And first, I will ask a question about to Professor Sidney Low. And I see we have a lot of progress in anti-greed strategy, and we now have algorithm, different algorithm, based hybrid algorithm, your CTO algorithm, and AP CTO, and even we have our China algorithm of CTO procedure. And based on your opinion, based on the progress of anti-greed technique, seed-3D, where errors guided, HDR, and the TD-ADR, and what you expected? Please join us.
Yeah, so
join us, please.
I think the sit here, the Dr. Sidney Law. I think the sit here.
You can sit here.
Yeah.
You can join us together. Yeah, please. Yeah. In your opinion, what's your expected the future algorithm for the CTO?
So I guess the algorithms were designed to organize the thinking involved. For example, the hybrid say, do you start with antigrade? Do you start with retrograde? Do you read the angiogram, the proximal distal cap? What is success of crossing, much like the JCTO score was. So algorithms are designed for perhaps beginners. And notice that the algorithm from a Japanese CTO operator was different. And then, of course, a Chinese CTO club, everyone has a different algorithm. So the truth of it is we tried to combine it, and we only got as far as the global consensus on CTO crossing. And even then, lots of debate. But I think it's, the thinking has kind of come together, and thinking now also moving apart. So because I think that at that time we're thinking how to think about it, and then we try to improve it. Everyone seems to be thinking similar. We try to come together and have a global view. I think now we're also a separate view because people have developed expertise. This is what we call style. Everyone has a personal style. And so if you're a very good retro operator, you can get very safe CTO PCI. Maybe it's not a bad thing, particularly if you're referred a patient already antigrade failed. You think, okay, I understand what they've done, and this is a retrograde case, just start retrograde. So the algorithm organizes thinking, doesn't dictate your style of procedure.
Thank you. So we have a panelist. Yeah, please.
Yeah, I have a short question for you about the cardinal technique.
Cardinal technique,
Yeah, the position of the microcatheter
Yes.
is intra-plaque or the proximal to the plaque.
Of course, it is the best if it's intraplaque. So it has to be intraplaque. So it works best intraplaque. If it's not intraplaque, then it's a complication. Well, basically it ends the case really quickly because, as you heard from Primero's cases, large subintimal spaces are very difficult. Even in tip detection ADR, a large subintimal space is still very hard for a tip detection ADR technique. So it is not good if you created a big space by your injection. Hence, Carlino refined to mini Carlino now to HDR, and it's very small on contrast. There's always been a risk with Carlino if you're very osteal or near osteal location, because you can create an aortic dissection if you inject a lot of contrast. And so there are inherent risks attached to it, but yes, it should be intraplaque. Yeah.
Yeah. Thank you, Professor Huang. Do you have a comment for this section?
I just have a question. Just I want to a concern because you use different the wire, and some is flexible and some is maybe give us more support. And how to choose in your case?
So this is where the anatomy dictates and function dictates over your choices, because it depends on what you think you need in the case. So you start with a workhorse wire, it's very hard proximal cap. So now you need a penetrating, if you know where you need to go, you need a penetrating wire to puncture the proximal cap. So then you're stuck in the realm of Hornet 14s, Conquest Pro STs, Conquest Pro P12s. So it depends on what you want to do in the case. If you want to knuckle antigrade or rectal retrograde, then you find a Pilot 200, you find something like that, a Gladys EX MG. So because you're trying to knuckle the wire, so it's designed to be knuckle. So it's a function versus I just take any wire and hope it gets through. So it's more like designed, the wire performance is better if you know what it can do and what you want the wire to do. So puncturing caps, of course, the penetrating wires. We found in solution in 3D wiring, you need very stiff wires. You need very strong support. They're very short distances. Essentially, you're puncturing with control. And so that's why they've invented the Conquest Pro ST. But it doesn't like corners. So one of the challenges is calcium, and the other challenge is angle.
Thank you.
Yeah, thank you. So, Professor Huang, what's your favorite device?
Just you know the angle, the safety, speed, and the success. So for my main aim, maybe success is the first my aim. So sometimes I use like you just integrate, but usually maybe I can see the angiogram and choose retrograde first. So it's a little different.
So for most people, it's loose tissue tracking anyway, or intentional tracking. We've found that many people are now using the Gladys EX. So it's a very good choice.
Yeah.
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 Yes, thank you. Please.
Hi, hello, Dr. Lo. I'm Dr. Chua. I appreciate your talk about the newer strategies for anti-grade approach. For someone who does a lot of CTO, including myself, and I would say that I'm slightly adept in retrograde approach. I think the more difficult part of incorporating those newer approaches is complications and failure rates for someone who are very adept with retrograde approach is quite already low. So you think incorporating these newer approaches definitely would simplify the procedure. Do you think incorporating this or learning these newer techniques would make you more confident to tell patients and relatives, yeah, I usually my success rate approaches 90%. Then if I learn to do this, would it be 100%? Would you be more confident to tell the relatives and patients?
Good question. And so everyone wants to be perfect, of course. But as you know, it's not reality. And so we have these things called non-inferiority trials. So you have to set an inferiority margin. So you have to set your failure margin. For beginners, the failure margin is very large because they fail a lot, because they're not inexperienced. For you, your failure margin is shorter, so it's smaller. So the questions are what you allow. Now, incrementally for you, unclear to me if there's much added to your already very good practice. So there may be some slight advantages in complicated cases. So learning any of these things may help you in a very complicated case and will translate some minor failures into more successes, but probably not 100%.
Yeah. Professor?
I think another question. I think the another question there is, of course, when you do CTO, the first approach is usually anti-grade wire escalation. If you face some ambiguity, try to do imaging, use these other devices to help you navigate through those ambiguities. I think the usual question is, how will I be able to know the correct timing of adapting this newer technique? Sometimes we get carried away with the way we're doing the procedure, and sometimes we already realize that it's already too late to do those newer techniques that are available nowadays.
Again, it gets better with practice. The more cases you do, the more you're good at managing the time. Time goes very quickly in the lab. You can ask the nurses to tell you when it's 20 minutes, 30 minutes, because time flies very quickly, and it's 2 hours, and some 3 hours if you use a lot of contrast. So all those things are kind of your own management of the case. And so I think it's an evolution. The more you do, any new technique just takes time to understand and practice. So it's like the thought of practicing. So it gets better with time. Unfortunately, or fortunately, the 3D wiring is very easy to learn, and success rate could be very quick. But some of the equipment is maximizing the microcatheter support. We found that we're doing a lot of inline anchors, so balloon trapping it in the proximal vessel, and then using a lot more stiff wires. So don't be shy, CP12, and yeah, you got to get really stiff wires to do it.
Yeah, thank you. Thank you, all the panelists. The time is limited, so let's start the final question. And for the Professor Huang, and please introduce for all the professor from Asian Pacific to introduce the CTO cases, CTO practice in Vietnam.
Thank you for the question. So far, I think in Vietnam, the number of cases of PCI are also increasing. We estimate last year something about 50,000 cases whole the country, and we have 130 cat labs whole country, but the number of cases now still increasing. But among them, so we get more and more the complex PCI, especially CTO, something about, in my practice, it takes about 10 to 15% of the case. But I think not many centers in Vietnam can practice very well about the CTO. But we are happy that now we have more and more the young doctor and have a lot of passion to do the CTO case. But I think it still have some challenges, something about the device consumption, the time consumption, and we need the time to increase our experience, as Dr. Sidney Law mentioned about that. So I think the scientific session like the two we had today, we can share a lot of very good experience, and I think it is can inspire our young doctor have more inspiration to follow the CTO, because we still left a lot of case with CTO behind. Yeah, not many center can do fluently CTO. Thank you.
Thank you, Professor Huang. Thank you, all the presenters. Thank you, all the panelists and audience. Thank you, everyone.
So we have, we have 15 minutes for coffee break. So you please enjoy the Hanoi Coffee Corner and to visit some booth, and then
Alo, 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 alo. Thanh ơi. Alo. Alo, Thanh ơi. Ok, em mở mic nói thử xem nào. Alo, 1, 2, 3, 4, 5, 6, 7, test. Alo, 1, 2, 3, 4, 5, 6, 7. Alo. Alo.
Phạm Nhật Lưu from One Life Hospital and we are going to have a case here and
Cái nào quên này?
introduce our way
Ok,
of
wow.
here,
Dạ.
from One Life Hospital is me, Dr. Ninh, Dr. Lê Văn Đạt, and Dr. Phan Đình Nhất, and we have our two guest operator that Dr. Nguyễn Đỗ Anh from Nhân dân Gia đình Hospital and
Anh nghe. Em có nghe rõ tiếng tín hiệu tốt từ phòng mổ.
today we are going to have negative complex PCI it is patient first operate anti-hospital PCI cột băng được chưa?
Nãy có 42.5 nãy cái là
Em tắt thành tiếng nhạc cho anh cái. Cho anh tiếng nhạc.
Xong rồi bảo cho tiếng trong này to lên một chút để tương tác với đội trường.
để cái bóng ngoài sân
Anh muốn dùng làm em 1.5
để
chờ chút
đây
chưa một cái trong 15 phút 15 phút nữa phải đã lên có thể
em dùng em rành em dùng phần bằng extension
trong cái mình gọi extension.
Vâng. 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 Em test đi. Alo. Anh ơi, em bằng giả cam hậu trường đi anh. Alo, 1, 2.
Ladies and gentlemen, we will now begin session 2, live case complex PCI. My honor to introduce the moderators, Associate Professor Nguyễn Ngọc Quang and Dr. Wen Bing Huang, and the panelists, Dr. Wei Guang Chen, Dr. Siripon Athik Sakur, Associate Professor Yus Hanif Isa, Dr. Lý Ik Chung, and Dr. Phan Thảo Nguyen. Please be on the stage to lead this session. During the session, there will be lunch boxes served at your seat. Please enjoy the session and the lunch.
So welcome everyone to this section for complex PCI. And now we have a live case from the Heart Institute 198 Hospital. So can we connect to the lab now? Yeah, can we have a connect with the cath lab now? Okay.
Thôi quét lại hoặc là mong luôn. Luôn đi, làm luôn tại cái này nó là phụ thôi, chủ yếu là cái kia.
Cho năm 30 nha, hai
Cái năm 30. 230.
Good morning, Professor Quang and everybody. Can you hear me?
We can hear you now.
Okay.
We can see you quite clear. So please show the case.
Yeah. So, morning everybody. So we are live from the cath lab of 198 Hospital.
Okay.
And my name is Dr.
Mình lên trước rồi mình mới
198 Hospital, and we have the team here with me, Dr. Minh, Dr. Lê Văn Đạt, and Dr. Phan Đình Nghĩa from the Heart Institute of 198 Hospital, and we have two guest operators today, and Dr. Nguyễn Đỗ Anh from Nhân dân Gia Định Hospital, and Dr. Phạm Đức Đạt from 115 Hospital from Ho Chi Minh City, and we make it a very wonderful team, and I would like to share our case today. Can you show our slide, please? So we have a live case with a complex PCI. Next, please. Next, please. So we have a 77 years old female patient, and she has history of hypertension and chronic kidney disease with mild lower of the
Nominal nhiều à?
For 56.
Nominal nhiều.
And she has the excessive chest pain a couple of months ago, and we did the first PCI about 3 months ago, and with the RCA PCI, and the PCI also review a very complex PCI of the left main LED and the circumflex. So today she was admitted to the hospital for the stage PCI, and during the time we follow up her, she still got some chest pain and
Anh đẩy giữ cho cái sông kìa, anh giữ cái sông.
Dyspnea.
Để em kéo cái sông không phải. Anh giữ cái xích, anh giữ cái xích. Xích để em kéo cái sông nó về để nó vô nó quay được.
From 55 to 60% and some peripheral arteries, the right anterior
Tại vì anh giữ cái xích.
60 to 70% femoral and polypectoral 30 to 40% bilaterally. Next, please. Under the functions, she has a little bit lower of the EGFA, and the troponin is quite normal this time. And the echocardiography EGF is preserved 67%, the normal LV size and systolic function. And as you can see from the lab test, she has a little bit high the cholesterol and LDL-C level, and echocardiogram show the sinus rhythm and normal PR, PRS, and QT interval, and no ischemic ST segment change.
Wow.
Next slide, please.
Okay.
Here's an ECG of this old lady. As you can appreciate that this time she doesn't have any change in the
Rất nhẹ đã tới đúng vị trí.
the ST elevation. Next slide, please.
Được rồi ha.
So this is the coronary angiography that we did for her a couple of months ago. So as you can see that she has quite a tight lesion of the circ, about 50 to 90%.
Anh muốn lên đây rồi test nhẹ đó. Test nhẹ đó. Test nhẹ đó.
Related to the
nhanh thuốc đó đấy.
the bifurcation of the diagonal also have a very tight lesion of 90 to 95%.
7.
Next slide, please.
7.
And here's the other view from the cranial and the LL view, so that we have quite a complex
Thời gian bấm gian cho.
proximal and proximal of the LED. And we also have the circ and the heavy control in the proximal of the LED and the circ also. Next slide, please.
Đạp hình luôn.
So we have a very tight lesion from 80 to 85% of the RCA. So previously, a couple of months ago, we did the PCI for the RCA first because this lady is quite old and refused by the cardiac surgeon, so that we decide to do the first PCI at the RCA and then do the chip PCI at the next stage this time. Next slide, please. So we fix the RCA with right radial access, and we do the pre-dilatation, and then we put an oscillomycin of 3.5 by 40 ds to the proximal to the middle part of the RCA, and then we post-dilate with a 3.5 balloon.
2 phút 15 giây. Bây giờ 2 phút.
Very
2 phút 15.
well expanded and 3 and no complication.
Đó em đợi.
So
để tổng biết chuyện gì xảy ra.
To show some of our thought about the case. Next slide, please. And then we'd like to hear the comment from the chairman and the panelists about the strategy and how can we do this PCI this time. And here's the summarize the case. He had a previously disease of a
đang ở ngoài em đẩy ra nó vô một chút xíu là
and the CAC showed that she had the RCA fixed with the stem of thyroid, but the left brain and the L disturbed. So we have very high and tight lesion. The first PCI was nice a couple of months ago, but this time the left main LDL and the circ. Maybe with the imaging, and then maybe the rotabrator and some modified technique, and we would like to hear some of the comments from the chairman and the panelists about the case. After that, we can know what we done from the beginning until now. Thank you.
So we can see a very complex case, and we already did the PCI to RCA, and now the Turkish lesion is L6. So what do you think, Professor Chiang? Professor Huang?
Isocat đi. Mai start để chụp lại cho đây. Mai start nhiều vậy?
The result. Can you hear me?
Thì start nhiều.
Yes, we can hear you. Well,
Start bao nhiêu? Đi start lại bao nhiêu vậy?
I'm Dr. Huang from Taipei Chengxin General Hospital, and you already done a good job in the RCA, and now you want to do the intervention for the most important, the LAD vessel, and so your plan is we'll do rotablation for this case, right?
Yes.
Very busy.
That's right.
the question from the Professor Huang is, do you want to PCI to the CERT today or do for the LAD?
We like to do the total revascularization for today. Maybe we do both the CERC and the left main and the LD because we really think that for the left main PCI and the LD PCI, we need to put a stand until the left main, and then afterward, if we do another stage for the CERC, there may be a lot of difficulty. So that our plan today is to do the total revascularization of both the LD and the CERC.
Okay. And will you use the image device to check the region, or just direct it using balloon and the stent?
Yeah, we will do the intravascular imaging, and today we prepare the IVUS, and obviously we also have the OCT, but maybe today we do use IVUS for the case.
Patient function not very well, right? So OCT is, I think, is suitable for this case.
Yeah.
Yeah. Can we show us what you did?
Okay.
So
Okay.
show to the floor what you did from the beginning.
Okay, so here's the here's the RCA from the beginning, as you can see. Sorry, I just did translation. It's okay. So here we do the RCA CAG, and as you see that we have a quite patent RCA this time. Can you see our screen? And and this is today the CAG for the left system. So as you can see that we still have the same circumflex lesion, but the LAD is occluded. So what do you think?
So compared to the lesion of the LAD 3 months ago, we can see the distal LAD. So this is a new lesion from the LAD, right?
Yes, because previously we still can see the flow from the LAD to the distal part, but today the LAD is nearly occluded, as you can see from the screen. And do you think that the lesion today may change our strategy, or we will remain the same strategy as we predicted before? So we would like to hear the comment from our panelists and chairman. So what do you think?
Yeah. Yes, Prahuan here from USM Malaysia. So I like that your plan to do both today because you're already on the left. Of course, the LED is worsening, but I think it's if you can really get a good guide and a good wire, I think that is crossable, like you did. And yeah, just wondering what are the stand. I think you have put a stand across the circumflex. Did you put it across the OM too? Did you put a stand just now, right? For the left, the LCX. So I think the LED, like my colleague just mentioned, you need to have IVUS, which you are doing, and you can show that, please. That's all my comment.
Okay.
So could you show LED again in the first image before you wiring? So today, proximal LED show total occlusion and the circumflex severe stenosis. So in my strategy, I would use EBU for 7 French, at least 7 French, and After we cross the guide wire to the LED and circumflex, I will check with imaging first. And in my opinion, if it's quite easy to cross the LED lesion, maybe it's a recent occlusion and it's not CTO, right? And after that, if we evaluate by IBUS, so we can plan to intervention to circumflex first, and after that, LED to left main. This is my strategy.
Yeah, Dr. Chan, please.
Okay.
In my opinion, I agree with the stage PCI strategy for this elderly the female with the CKD and the mouse blood vessel disease. Everything is very useful for this. The LED is a CTO. In my opinion, I didn't find the lateral from the other vessel. So you can see it's the through the layer to the distal. I look forward to the next.
Okay. In this situation, for me, so in here we have two vessel disease. The circumflex, the mid circumflex is very tight, and LED in the first procedure is still the flow. The night total occlude is already and very calcified in the proximal and mid LED. So for me, in any way, so we need to do the IVERS first. So in this situation, I think we need to use the small balloon for the circumflex, and after we cross the LED, we do the balloon, we do the IVERS both sides. So to have a look, distal left main, the plug, how big. So for the circumflex, we can see it's the diffusion. The diameter on the angiogram is around 75 to 0. So if we prefer the lesion is the optimal, we can do the DCB. This for my opinion. So for the LED, so after we do the IVERS, so have a look. So maybe we have prepared the lesion with the cutting balloon or rota ablation or IVL something, except to the calcify. So and for LED, I put stent for the proximal. So have a look if the distal left main, the lesion is the significant. So maybe we cross over the left main. Thank you.
Yeah, so this is the opinion from the panelists, and I think that in this case, the lesion is not really CTO, nearly like a subtotal occlusion, because 3 months ago, the flow is still there, the LV function is still okay, and hopefully that the operator can go through that. The issue here is the LVD is very calcified, and this is a problem, and hope that after you wiring the LED and then you do the IVERT and see what was going on, and you have a option for do with the rota or balloon or something like that. Yeah, so please show us what you did for the LED now.
Okay, so we are totally agree. So today we have do the case with 7 French from the femur. And then we agree with the panelists that we can do the hybrid PCI for the case. So we tried to wire the LD and the circ, and wiring the LD was not so easy because it was a subtotal CTO, as you can see, but we can manage to do that. But some technique and CTO wire from our wonderful operator here, Dr. Do Anh. And here's the after we pre-dilate the LD with the 2.5 balloon, and it is very tough here, as you can see. We can see there's so many ways from the balloon and the device here. Here's a 2.5 by 20 real ray balloon. And here's the CIG after we try to wire the circ. Next, please. So we write the circ and do the inverse. So can you show the inverse for the circ, please? Chạy cái inverse của cái mũ. Inverse one, please. So the distal part of the circ is roughly 2 something. And we can see some calcified from the distal part of the circ. The calcify is almost 180 degree. Here's from the circ to the proximal part of the circumflex. Yeah, and the proximal part is 275 to 30. So we would like to hear some more comments from our panelists. Should we do DCB or we stand in this kind of situation when we have a tight lesion of the circ and a little bit of quite heavy calcified
Lesion reparation.
So what do you think?
Yeah,
Should we
Professor
stand
Wang.
or we
Reparation. But the device.
kẹp cái đuôi
Lesion
Yeah,
preparation for
like-
this case is very important. So the calcified, will we use just like a lithotripsy balloon or other device to correct the calcium? Or we because this case originally the flow is good, but this time the flow is blocked. So rotablation or orbital rotablation may compromise the flow. So I think high pressure balloon to correct the calcium or lithotripsy balloon may help. That is my opinion.
Yeah, Dr. Isha. So
Ah,
we
well,
are
it's okay.
Yeah, about the circumflex, I agree with Prof. Wang. You see the calcium there from the ibis. You want to crack it first. If you have all the weapons in your hands, you crack with high pressure balloon. I use a scoring balloon as well as a cutting balloon, as well as if you have IVL, and you want to top up with a rotablator, you also can. But the question after that is whether you want to put a stent or a drug-coated balloon. So that we will see on the end after you did all those atherectomy. You want to see IVUS in the end too before you deciding these two approach. But usually, if too much calcium, I would just put a stent across. That's why I asked my question just now. Okay. So that's the way you're going to do it, and then you turn to LED later on.
Okay, so
Yeah.
next slide, please.
Yeah, how about Dr.
So we,
How about you?
I totally agree to preparation, to the best preparation before decision for stent or drug-coated balloon. The anatomy quite more distal circumference, and the vessel size is 2.7 to 3.0 millimeter. So in my opinion, if we can preparation of the crack the region like a cutting balloon or scoring balloon, and after that NC balloon and adequate preparation, we can use drug-coated balloons.
The others show us that the LCX, the opening is normal. So the LAD stands to the left main. I can cross over the LAD to the left main.
Yeah, Dr. Chung.
Okay, so we can see the result after prepare the lesion is the distal complex. On the angle, it looks so nice, right? So maybe for me, no extreme dissection, TB flow is 3. So maybe we can put the shock eloting balloon there Osteum circumflex no lesion. So for the LAD, it's very calcified. So the balloon cannot open. So maybe we need to do the rotor ablation there. Okay, thank you.
So I would like to.
I think that the people here considering the calcified lesion, but if you can prepare the L6 is in a good condition, then we can do like a drug coating balloon for the L6. So the LAD people here in the panelists prefer to standing because it is CTO, it is calcified, and you might need to protect the result after the PCI. So what the CAT lab already did with the L6 and what the plan for the LAD? Please show us.
Okay, so Dr. Doan, can you show what we have done?
Thank you for all the comment from the panelists. My team decided to use the NSF balloon, the 22513 NSF. With nominal pressure. Okay. Hello, can you hear me? Hello?
Yes, but we didn't see the angel. We only see the screen of the IVUS. Please show the angel.
Yeah, we will. Well, thank you for the comment from panelists. So in a situation like this, we decided to use Almeta NSD balloon, the 22513, and we deploy with the nominal pressure from the after the first OM. We see also the two lesions. The first on the proximal surface also have lesion, but it's not significant, and we decided to leave it alone. From the second lesion, it means that after the first OM, we decided to use the DCB after the lesion preparation with the NSD balloon. And the next, because we see the disparity between the proximal and distal of the lesion on the from IVUS, we see on the distal, the vessel just the diameter just around the 225, but in the proximal just around the 275 to 3. So we decided to use the DCB with the last 21513 from the proximal is after the first OM, and we deploy with the nominal pressure for the 1 minute and 130 1 minute and 30 seconds. And you can see on the screen that the balloon is deployed well, and now see the next view, so we can see the results after the DCP results.
Next, please.
Next, please.
Next, after the DCP.
After the DCP, please. Next. Remove the DCP.
Yeah.
Okay. The other view from the spider view. Next spider view. Yeah. That is results. We see that TB flow free with the contrast staining, and we also see that the lesion on the proximal structure, but we decided to leave it alone. So what is the comment from the panelists about our results?
Yeah, I like it because you got symmetry, and of course, like I said, some operator may use a stand, but it will be problematic because you have to go across a very big branch OM there, and because of that, you put it across. That's a good thing about DCB. I use a I think you use a paclitaxel, right? Paclitaxel drug eluting balloon. That's also good for the long term. I think the result is so good. If you decided to do balloon, then you can always go across the branch, and you can just accept that kind of result. You don't have to be perfect when you're doing balloon. I mean, in terms of lumen, because that balloon later on will do it works. So I think I'm okay with that. I'm happy. Good job.
Okay, so now we decided to rotablate the LED because we could not test the IVUS for the LD lesion. So, but now we have 2Y from LD and the circ, and we would like to hear the comment from our panelists about can we still do the rota with the 2Y or we should withdraw the circ guide Y in order to have a very safe rota ablation. What do you think, Mr. Chairman and panelists?
Yeah, Professor Wang. Do you want to do the rota with the 2 guide Y, or you just pull out the L6 guide Y?
Because if you use rota operation for the LED, the circumference wire may be damaged. So another technique is dual guiding or use the guiding extension caster into the LED, the rota operation. That's my opinion. But it needs another guiding.
We will withdraw the Y from the circ because we also really think that it is safer to have only one Y in the LED and okay. So we will now use. What do you think about the size of the rotator? What do you think? Because we could not cross I work for the. What do you think about the size, please?
I prefer 1.5. And after that, maybe if not inadequate for rotarator, maybe I will upside to 1.75.
Yeah.
You agree?
Dr. Chan, what type the rota you prefer?
So we also agree that we use 1.5, and as you can see from the first run of the rota, it's crossed a little bit to the proximal, but I think maybe for the better preparation of the calcify modification, maybe I will try to go a little bit further to the distal part of the LD. What do you think?
Okay. I agree with the rotations as a Russian mathematics. Okay.
Yeah, just go ahead with the 1.5.
Yes.
Yeah.
50. 150. 70 seconds. 20 seconds. 20 seconds. So what is your recommendation about the speed and the duration of each run? Because because as you can see that we easily cross the proximal, but the middle and the distal part is quite a tricky one to cross by the rotator.
Dr. Isha, you want to change the speed and or something about?
You are using 1.5. Yeah, if you don't work at currently you're doing 150, right? 150. You can try 180.
Yeah, 160.
Yeah, 180. You can try that, but provided you have crack it. I usually crack it a lot because I don't like to use so much of the high pressure, the high speed. If you have already pre-dilated with a cutting balloon, then you may be able to cross it. But that you did with the higher berth. Good job.
Yeah, they up to 130, 180, I think. Yeah.
What is the speed just now? Yeah, when you cross.
What is the speed?
I think we still remain 160 because we really think that with this kind of a little bit of the torches of the proximal part of the LED, and then we have a quite heavy calcification up to the middle and the distal part. A little bit risk of the sucking the burr if we increase the speed too much. So it's our experience, but we really want to know one and further experience from our panelists.
Hello. So I would like to ask the rota Y, this one we use the lobby Y or extra support rota Y. Dr. Minh and Dr. Doan.
Unfortunately, today we only have floppy Y, and actually from the beginning, me and Dr. Doan, we intended to use extra support, but it's not available today in our pen lab. So basically, from the beginning, we only use the floppy Y. So what is the difference between the floppy and the extra support Y? We hear some more comment and experience from Dr. Chung? Okay. Can you tell us?
Okay, thank you, Dr. Minh. So for heavy calcified and a little bit doctor and very tight, and this we can see this is a very calcified and long lesion and very tight. So if we need to more debooking, we can use the rota support rota Y is better. This one, if we use the extra support rota Y, is more support and we can debooking is better. This is the speed. So maybe we with high speed a little bit is around 180.
Just they're using floppy, right? I mean, can you use that high speed with this non-rota wire? I never tried. I'm afraid of cutting it too.
Okay, so now we withdraw the rota already because we think that the lesion is rota blade and prepare enough with the rota ablation. And now we from the beginning we use a turnpike 5 cross microcatheter by the reflex, and now we will use the turnpike one more time. And so what microcatheter do you think we should use in the case of combination between CTO and calcification like this case? We choose this one because we think that it is also good for the CTO and also quite good to cross the calcification that may occur during we do the rota ablation. So Dr. Chung, you have a lot of experience in the rota ablation. So what microcatheter should we use?
So I usually use the Corsair or Corsair Pro.
Okay, so now we will try to rewind, and then we change to the workhorse wide and do the IVUS.
Còn vua đâm trù này. Nó sớm.
So I also agree with some comment from the panelists that maybe we can upgrade the rotable one more time, but here we due to the save of the money for the patient, so that we only use one rota for the case. And now the turnpike this part, then now we get to the workhorse wide to the IVUS, and after that I hear some more comments from the panelists.
Cái này cũng phải xài được.
The strategy. So should we use from the strategy? Should we use the DCB in the proximal part of the LVD, or we should stand? What do you think?
So, Dr. Isa, do you put the stent or drug coating balloon for the LVD?
Oh, this is proximal. I rarely put a drug coated balloon there because logically, because you know, common sense patient already 77. If you put stent, I mean, it should last for the age of the patient. Right? I mean, I tend to put a drug coated balloon in the younger patient, whereby you may want to do again in the future, where there's no stent in the future. So this is elderly lady, a good stent with a small strap profile, like Osiro would do the job. That's what I would do. Okay.
Professor Wang?
Yeah. So because Osiro is kind of the quite ultra thin strap stent, so we have a lot of calcification in the case. So what do you think about the radial force and the expansion of the ultra thin stent in this kind of lesions?
I will put a stent, long stent. Yeah. Because you already done rotablation and already cracked the region, the calcium already cracked. I think after the IVUS image tell us more information.
Yes.
Other strategy.
So Professor Huang will wait for the IVUS. And how about the artist connect?
I also went for the IVUS, but in my opinion, at the first angiogram after the guidewire and balloon, maybe we can do hybrid for proximal ultra thin stent, and for the distal LVD, we can use drug-coated balloons.
Yeah. How about Dr. Chen?
Okay. 然后I used I used the tense back spirals for CTU's lesions. In this case, I tend to use the tense back macro catheter.
Yeah. How about Dr. Chung?
So I look for the result after we repair the lesion. Yeah. Because in the first procedure, we can see the LVD is very big. So now to occlude this, we just open after we repair the lesion. So we give some nitro and do the angio, have a look first. Thanks.
Yeah, so people here want to apply the hybrid approach with the stent combined with the drug coating balloon, but we need to see how the IVUS. So please show us the IVUS and then we can further discuss.
So now we will go to IVUS. The IVUS is going in. And then afterward we will show you. Cho nó chạy đi, cho nó xoay. Okay.
If the physiological study is available, full-pack facial gradient may tell us some information about the physiology.
Okay.
Long standing may help. That's my opinion.
Okay, không sao, cho móc pin. Có thêm móc pin. Okay, so here's the IVUS from the distal part of the LD. It's you can see. So we have quite a diffuse lesion, but not so much calcification from here. Here we can see the calcified from the 4 and 3 o'clock. The calcification is cracked. Here we can see that 270 and now nearly 360 cracked calcification. And obviously, in my thought, and also Dr. Đậu Anh and Dr. Đức Đạt here, we should use another calcify, modify balloon like the cutting or the scoring in order to have the better modification. So obviously, it's the best we can have the lithotrip C also, but unfortunately, it's not available here in our CAD lab. So we'd like to hear the comment from the panelists about the size and the further modification of the maybe cutting or scoring balloon.
Yeah. If you are planning to do a hybrid and at the place we're going to put a DCB, you will cut it a lot because you want to make sure the drug will go through the calcium plug that has already broken down. So it will stay there and make it magic. But if you are going to put a proximal stent, a big stent, based on the size of IVUS, you want to get a good size to make sure it's more than 8 millimeter square surface area. And you don't need to crack so much to me if you're going to put a stent. But if you're going to put a DCB, that's what you have to do. You do more cutting, and to make sure it will work in the future. So that's what I will do. Of course, it's a lot of calcium. As long as you can go a good TIMI3 after this, you must do IVUS after you put a balloon or stent. That will make your results much more robust, okay, for the future.
So should we use cutting or scoring or just NC balloon? What do you think? Okay.
The patient can accept prepare the lesion further with the lithotripsy, shockwave may be better. I think after rotablation, the calcium is already cracked, but not a circle, you know. So more lesion prevention is good, but the cost is different. Yeah, that's my opinion. Using stent or use NC balloon, higher pressure dilatation to test I think the lesion may be dilated after the NC balloon. If it work, then use a stent is acceptable.
Okay. So we are discussing now in the cath lab, and I think that we are trying to do the NC balloon, maybe 3.0, and then put a stand for the proximal part, and then we will do the dark-coated balloon for the distal part lesions.
Yeah, just go ahead with the 3.0 balloon and see what was going on. I think that we still need to prepare the lesion because very calcified for the long-term outcome. It still need to open further and of the calcification.
Còn 13 phút này thoải mái, còn mình nong cái này xong mình đặt stent luôn. Còn 13 phút nữa thoải mái thời gian. Mình cứ nong cái này xong.
Just a question. Would you protect the diagonal? I mean, for those operator, would you protect the diagonal?
Dr. Đỗ Anh, did you want to protect the diagonal or the circ?
For equal to the diagonal, so we predict that there is 10 not I think it's kind of close after standing. So I think that we can there we do the stand first, and after if the compromise the side compromise, we will do the white to the side later. No need to protect. Yeah. What is your comment? Do you want to use a white to protect the side plane first or not? It looks quite thick. Yeah.
Okay. So on the iris, we can see some segment, the calcified ring is not yet cracked. So I don't know. So after that video, the cutting balloon, something to open that or not. So if video there, we have still have on the iris, we can see the calcified, the necking ring is not yet cracked. So the short segment.
Okay.
So if we use the cutting balloon or OPN, it cannot crack. We can use the OPN there. So if we don't use the IVL there, so maybe before stand we still have the wet there because the burr we use just 1.5 only. Yeah.
So our operator did not protect.
So what size the balloon, Dr. An? This is what size? It's around 2.5 or 2.75.
3.0 balloon. People 3.0 Bantaralo 3.0 balloon.
You can open. I think it's okay already.
Yeah, I think I was fair. I think it's deploy the expand the fully well. Okay. Now the next proximal. No, wait.
Okay, cái
Được rồi.
Lúc này nói để cho nó tận lỗ, cái lỗ mà.
Thì em đang kéo gì?
Không, em nghĩ rằng nó tận hơn.
Em đang kéo nó vừa chút xíu người ngày tôi sợ rồi.
Ok.
Rồi lên. Nhiêu đây?
20.
Rồi.
Okay.
22.
22 and we use 3.0 track back Leo.
Down. Ok. Go to left main luôn nha. Nông. Vô rồi. Rồi. Cái này làm cái rồi.
I would have wire the diagonal when you do this, so you can use the wire in the main as a cutting tool, right?
Okay.
And also protect the diagonal.
I think in this situation, after you open with the rota, then the chance of the closing the sapran is low. But however, if you really want to use it, but you want as like a further cutting the lesion is okay. Yeah. In this situation, I think that the operator is very brave. For me, I will protect the cert.
I mean,
it is important
I'll
for me.
take my failure to protect the diagonal. Because if patient having chest pain, then you'll be, panicking and everything. Not good.
Check tốt không? Stand luôn không? Em muốn bệnh dưới là DCB không hay thôi mình lên stand luôn. I think maybe we should to use a two stand for the two stand strategy for the case. So maybe 275 from the and then 3.5. Thế mình lại quay vào mũ theo yêu cầu của Panelist về anh. Bảo vệ. Đánh đo sẽ phải đi rota mà không sợ nó mới thì đợi gì đó. Sẽ phải compromise. Đấy. Em cho anh cái quai này. Còn cái nãy còn á, lấy cái quai nãy xài nằm đâu đó. Anh đánh xuống spider view đi. Anh đánh xuống spider view đi.
Dr. Minh and Dr. Do Anh, we still got a two lecture, and now we switch to the lecture first, and you just do it stand as you want, and we come back to see the result after that. Is it okay?
Thank you. Thank you, Professor Quang. We will. Okay, thank you. See you later. See you later.
So now we move to the first lecture here. We would like to introduce Dr. Tom Devisia to present the topic about the hybrid PCI in multivessel disease.
Trường bên kia có đông người.
Good morning, Vietnam. Good morning, Hanoi. And warm regards from India, South India, Temple town of Udupi, and the global educational hub of Manipal. My slides, please. Audio team, my slides, please.
Show the slide of the presenter, please.
It is in that folder, live session.
Xin lỗi hội trường cho xin cái slide của báo cáo viên với ạ.
Yes, thank you. So wonderful live case going. Typical example of how a multi-vessel PCI has evolved from a multi-stent procedure to a hybrid PCI. Let's have this case. 62 years, male, diabetes, hypertension, comes to us with chest pain. ECG has ST depression, echo good ejection fraction, troponin minimally increased. Angiogram shows discrete critical stenosis in proximal RCA, long segment disease in LAD from the ostium, circumflex intermediate looking disease by angiogram, OM, critical stenosis. Multivessel disease. How would I approach the case? For the intermediate looking disease, I would use physiological assessment and if needed imaging. I would proceed with optimal lesion preparation. I would use imaging once again to assess the success of my lesion preparation. I would stent the proximal segments. I would consider using DCB for the distal small vessel long segment diseases. Heart team discussion, CABG versus PCI. Final decision, PCI. Proceeds with elective PCI, LAD osteoproximal, stented with 3x40 or 0 drug-eluting stent. Ramus, predilate, prepare, not a big vessel, drug-coated balloon, 2.5x15. LCX, even though looks discrete by angiogram, imaging-wise, long segment, hence DCB, 3x30. RCA, disease extends from osteoproximal segment, hence 3x20 or 0, DES. Post-dilate, confirm with IVUS that the result is good. Final result, the left system, LED standard, OM bar ramus and LCX DCB, osteoproximal RCA stent done. 4 lesions, 2 stents, 2 DCBs. And when we combine DES and DCB to optimize revascularization, we call it hybrid PCI, and that is the present philosophy in multi-vessel coronary artery disease. Why do we have to follow a hybrid strategy in multi-vessel disease? Because multi-vessel disease frequently involves a mixture of long lesions, small caliber vessels, bifurcations, calcified segments, and maybe focal lesions suitable for DES, especially at the proximal part. Previously, we used to put long stents, but we know that extensive metallic stenting increases total stent length and the metal burden. So DCB is always an option for us in addition to DES. Concept of hybrid PCI is not difficult. Prepare the lesion, assess the result, and then you decide whether you want DES or DCB. If there is a focal lesion, or if there is a significant recoil after lesion preparation, or if there is a flow-limiting dissection, DES is our choice. If after pre-dilatation, the luminal result is good, TIMI3 flow is there, and an acceptable residual stenosis, preferably less than 30%, DCB would be a good choice for us. And long segment, small caliber vessels, DCB is particularly attractive. Calcified complex lesions, most important thing is lesion modification. And then based on the final result and based on the location, the diameter of the vessel, you decide on DCB or DES. The new Asia-Pacific consensus describes this as a DCB-based PCI strategy in which lesion preparation is performed first and the final device, be it DCB or DES, is selected according to the post-preparation result. Why do we have to combine DES and DCB? The combined use of DCBs and DES offers distinct mechanistic, procedural, and clinical advantages over conventional DES-only PCI. DCBs and DES should be considered complementary strategies, enabling a more tailored PCI approach based on specific patient characteristics and lesion-specific anatomical and physiological features. We know the benefits of hybrid PCI with the complementary use of DES and DCB. When we reduce the stent length, when we limit the stent overlap, when we limit the total number of stents, when we avoid using stents in less than 2.5 mm vessels, we know that we are reducing the risk of target lesion failure. We would like to preserve endothelial function, and we know that DCB reduces mid-term acetylcholine-related vasoconstriction. DCB process promotes positive vascular remodeling, and late lumen enlargement can happen after DCB treatment. Another benefit of DCB is that DCB-treated segments remain accessible for future stent or CABG. DCB PCI will reduce carinal shift, so the risk of side branch compromise is less, as we saw in the previous case. DCB-based PCI is associated with lower major bleed, and your total duration of antiplatelet therapy is less. In bifurcation lesions, we know that the proximal segments or the main branch of bifurcations, we choose a DES. And a side branch, we prepare, reassess, and then consider DCB as our first choice. In long segment diseases, the proximal quick caliber vessels, we choose DES, and in distal, we choose DCBs. So in bifurcation, as I already told, main branch after preparation, in true bifurcations, DES, side branch, prepare, in true bifurcations, consider DCB, and if there is significant residual stenosis or flow limiting dissection or compromise of TIMI flow, consider stent. In non-true bifurcations, the trend is DES in main branch and DCB in side branch. In diffuse or long lesions, prepare the lesion, assess physiologically, and then most of the times you will be ending up with a very good result with DES proximally and DCB distally. When in doubt, use physiology. Yet another case, 62 years, male, angina, history of PCI 15 years back, ECG, ST depression, echo, good ejection fraction, creatinine 1.3, troponin, minimal rise. Angiogram, disease in RCA, osteoproximal and mid. LAD, stent is there, but in-stent restenosis and a de novo lesion in distal LAD. Image, prepare the lesion. Calcific in-stent restenosis, laser is the treatment of choice. Laser at 80 settings, 20,000 pulses delivered, and then after that, do non-compliant balloon dilatation. Prepare the lesion, confirm it is prepared well, then stent LM to LAD with 3.5, 35 or 0. Distal to it, minimum overlap 3 into 20 or 0. And then distal most LAD disease, pre-dilate, and then use a long DEB as per the choice, 2.5 into 30 based on imaging. This is the final result of the left system, confirmed with imaging. Don't image the place where you have done DCB. Once you have done DCB, that is the final step. RCA, DCB after preparation 2.5 into 30 from proximal part, and final result is good. TIMI 3 flow, no dissections, residual stenosis, minimal. Result accepted. We started with the one on the left and ended with the one on the right. Y or 0? Look at this, at 12 months, multi-vessel disease, DES or 0, target lesion failure, at 12 months, performed better than Zymes. DCB options presently available in our country would be Pentrelux, Agent, Solution, and Magic Touch, but you know that it is not a class effect. Each balloon has their own properties and behaves different ways. Yet another case, 59, hypertension, dyslipidemia at the time of admission, LDL is 287. Angina, history of PCI to LAD and LCX 1 year back. Post-pacemaker status, ECG shows ST depression in infralateral leads, good ejection fraction, creatinine 1.2, troponin minimal rise. 1 year back, I revised the angiogram, had critical stenosis in the circumflex, had intermediate looking disease in the LAD. Physiology to LAD and imaging confirmed significant disease. Stent to LAD done, stent to LCX done. The final angio 1 year back looked good. Somehow, the present angiogram shows significant critical disease in left main near the bifurcation. However, the standard segment looked good. LDL 270 plus is the problem. So what do I do? Had team discussion, patient decided on PCI redo. OCT for assessment of mechanism of in-stent restenosis confirmed neoatherosclerosis. Not surprising given the LDL which I saw. Not heavy calcium, so pre-dilate 1:1, LM to LAD 4 into 18 or 0, and then osteoproximal LCX, TEB with 3 into 15 in a final part, after KBD. The KBD, the LCX balloon is DCB. This is the final result. Sorry. This is the final result after the stent and the DCB to the bifurcation, confirmed with imaging, happy with the results. Start the patient on PCSK9 inhibitors. LDL comes down to 50. After that, 1 year follow-up, patient is symptom-free. Thank you very much for my team who helps me deliver good healthcare to all the patients who come to us.
Thank you, Dr. Tom David Vasya. And now we move to the next lecture, and after that we have a discussion. We would like to invite Dr. Deborah Radley to present a topic about expanding the utility of DCB in complex PCI.
Good afternoon. I'm Deborah from Singapore. So if I get that. Do I click the clicker? Okay. So while DCB has established and robust indication in in-stent restenosis and small vessels, focus is shifting more towards the other complex subsets like bifurcation, CTOs, and diffuse disease. So there's more emerging data in this field. And we all know that, of course, acute result cosmetically perfect with stents, and we don't have to fear acute vessel closure, but it comes at a cost where you suffer from neoatherosclerosis with stent adverse events at 2% a year, and the graph never plateaus. It just keeps going up at 2%. And if you look at the graph, the depiction of DES and BMS on the right, it basically shows from the timing of implant, when does neoatherosclerosis forms? And in DES, it's much earlier, typically at 40% of the cases when they did the autopsy, they found that it happens at about 9 months, whereas in BMS, it's a rare finding even at 4 years. So fixing a stent failure with another stent might not be a lasting solution because the more stents you put with additional layers, the luminal reserve decreases. And as you can see, by the time you reach a third layer, the incidence of target lesion revascularization almost triples. DCB, on the other hand, you might not get a cosmetically perfect result at the start, and not all vessels are treatable with DCB. If you get a bad dissection, of course, you need to bail out stent. However, if you manage to get good lesion optimization and do DCB, there's no permanent implant or polymer inflammation that you need to worry about. Plus, there's another benefit of late lumen enlargement with paclitaxel coated DCB. So perhaps in order to treat the complex subset of group of this patient might be a blended strategy where you're not competing with stent, but more like each benefit complements each other. This is a publication, basically it was presented in EuroPCR last year by Prof. Shin's group, where they looked at DCB-based versus stent-only strategy for de novo disease across different chip risk categories. But what you find here is that they look at DCB-based PCI, which involve pure DCB and also hybrid approach versus stent-only PCI. And when they did a propensity matching and re-stratified it across different CHIP scores. As you can see, the CHIP score involved patient factors, procedural factors. What they found was that with increasing CHIP score, not surprising, the MACE goes up. Another finding was that at the highest CHIP score, when you compare DCB-based PCI versus DES only, as you can see in the blue and the red line, there was significantly higher MACE in the stent-only group. And what's interesting to note is also when you look at operators in doing the DCB treatment, in lower CHIP scores, most of them did primary pure DCB treatment. But as the CHIP score goes up, there was an increasing trend for hybrid PCI, which means combination of DES and DCB. So of course, this will be anyone's nightmare, stenting from top to bottom, because long stents and overlapping stent segments is a non-predictor of bad outcome. This is a 53-year-old who presents with non-STEMI. As you can see, it's pretty diffuse lesion, but the most severe one is in the proximal, so we stented the proximal to mid with a Cyro. And this is what we got. So at this point, there's some downstream moderate looking lesion. Would you just leave it and go home, the end of the case? Would you go and stent it further all the way down? Or would you do a pressure wire assessment? So in our case, felt a bit iffy about it, so we put on a pressure wire. And basically it shows both IFR and FFR were significant. And when we did a pullback, basically you can see there's a lot more gradient in the distal now that we have fixed the proximal to mid. So we decided to further modify it, and we got a good pull bar result. So we treated with DCB and we repeated the pressure wire again. And this time around it was non-obstructive with IFR 0.91 and FFR 0.84. So here we are, treated with a hybrid approach, and should anything go wrong in the distal next time, the patient will have more treatment options. So this is a retrospective study from 2 Italian centers focusing on long de novo LAD disease. So when they compared the DCB-based PCI, which involved hybrid plus pure DCB, versus stent-only PCI, and the primary endpoint was 2-year target lesion failure, they found that the endpoint seems to be favoring the DCB, mainly driven by the target lesion revascularization. How about in bifurcations? It's not uncommon. We have up to 20% of our PCI cases, we have complex anatomy, and optimal management in this kind of bifurcation is controversial. So I'll just illustrate this. It's basically a dialysis patient who has triple vessel disease with RCA-CTO. We wanted to treat the RCA-CTO medically and do the left main to LAD. So basically because it was calcified with a huge circ, started to do a 2-stent approach, did an orbital and did an IVL, and this was our final result. And in fact, the IVUS areas were really amazing. We got really good areas. However, 2 years later, patient presented back with recurrent and STEMI, and here we are again. You see how ISR is developing in the left main and LAD, and severe ISR in the ostial circumflex. As you know, EBC main trial, which basically studied the true bifurcation, left main bifurcation, with a stepwise provisional versus 2-stent strategy, and they look at primary endpoint, which was composite death, MI, and TLR. And then what they found was that there was no difference in primary endpoint at 1 year and 3 years, but when you look at secondary endpoint, the target lesion revascularization almost doubled in the 2-stent strategy, and the point of weakness was the ostial circumflex. So why would you consider DCB in bifurcation? Basically, you don't have to deal with a metallic neocarina. You don't have to deal with crushed metal layers. And it respects the original anatomy of the bifurcation carina and allows homogeneous application of the drug to the vessel wall. So it is theoretically very attractive because it reduces neointimal hyperplasia, allows vessel remodeling. This is another interesting publication by Proshin's group, where they look at just by treating the main branch, how does it affect angiographic change inside branch ostium? So they compared the DCB group, DES group, and just optimal medical therapy. And what they found was that when they treated the main branch with a DCB, on angiographic follow-up of 6 to 9 months, they found that in the side branch, the minimal lumen diameter increased and there was reduction in diameter stenosis, whereas the opposite effect occurred in those with stented or optimal medical therapy. This is an angiogram of Medina 111. Basically, we were actually talking to the patient about going for bypass and all that. But on table, suddenly he complained of chest pain. Okay, So before that, yeah, what will be your strategy? Yeah. So would you do a 2-stent up front? Or would you do a POBA and then like a provisional stent? You know, so we were thinking about doing a 2-stent strategy because of the size of the circ and everything. And suddenly he complained of chest pain. He had hypotension. And in front of our eyes, it was TIMI2 flow in the LAD, TIMI2 flow in the circumflex. Okay, so what? End of surgery discussion. Go and open up the LAD and the circumflex. So we ballooned those up. And then patient at this point went into flash pulmonary edema. We intubated the patient, started on inotropes, did a POBA to osteocirc. So by this time, patient was also started on vasopressin, now on dual inotropes, right? So what is your PCI strategy in this kind of cases? So we decided to keep it simple. I mean, balloon pump was in, but basically patient had little hemodynamic reserve. We don't feel that the patient can tolerate like a kissing balloon is inflation twice and everything. So we decided to keep it simple and tried ballooning the circ, which looked okay. So we went on to DCB and we did a crossover stenting left main to LAD. Patient survived the episode. Of course, at the end, there's some pinched osteocirc that you can see. And we had the opportunity to bring this patient back at 7 months. And you can see the circ is still appearing pinched. So we did a pressure wire study across the jail circ, and it was 0.89. And as you know, the popular Korean study at 5-year outcome, when you do a hemodynamic study across the jail circ, if the FFR is more than 0.8, then it is good long-term outcome. Left it. This is another case just to illustrate how DCB simplifies bifurcations. So this is a 001 where it's an isolated osteocirc. And when we IVISed it, it looked, well, pretty calcified, but the NC was not opening it well. So we went on with IVL and Uvrin and Scoflex, and then we sized it based on the IVIS for the DCB. So got a good luminal gain. So you save many stents and kept it simple by achieving good lesion modification. So based on the publication on DCB ARC document, although there is still no evidence-based, intravascular imaging criteria established for DCB optimization, it's basically encouraged to size the DCB well so that it will oppose the vessel. And it also gives us idea when there's difficulty modifying the plaque, whether what tools to use, intravascular imaging will be the key. So does the more you gain, the more you lose still hold true? I mean, of course, in the PTCA era, when we did a balloon angioplasty with coronary dissection, luminal gain, but it comes at a cost, drawback of restenosis in the midterm. However, as you know, in the Transform 1 study on OCT, when they measured the more dissection you create, which was measured by the OCT dissection volume, the less late lumen loss you get. And in fact, there was a trend towards luminal gain. And this is another publication, as you all know, by Professor Clever, which basically relook the angiogram at follow-up at typically about 4 months. And so there's actually enlargement of the luminal diameter. So there's, so I'll illustrate this as a case. It's not a real CTO, but it's more like a subtotal occlusion, right? And then we cross-river filter XTA, and then we sequentially dilated the vessel. But there's really no distal landing zone in this case. And you can see some type B going to C kind of dissection in the mid-distal, and the dissection remains stable after monitoring. So we decided there's no landing zone. So we decided to do a long length DCB. And this was our QFR that we obtained at the end of the case. And we brought the patient for actually relook at 5 months. And look how big, well healed the dissection is. And especially at the mid distal where there was the type B going to C, dissection is well healed. And he presented again with some atypical symptoms. So at 14 months, we studied it and we did a QFR. It was normal. We did a pressure wire study, which was also normal. So a good enough RCA got better with time. So in conclusion, DCB simplifies complexity. You minimize stent-related adverse events. And also the concept of hybrid strategy is attractive. There's been rapid adoption of DCB in many complex settings, but this is all based on real-world data and supported by a strong clinical rationale, but I feel that at this point, we need more to solidify whatever this practice we are doing. We need more conventional trials in this complex subset of patients. Thank you.
Thank you very much, Dr. Deborah Lee, for the great talk. And now we move to the discussion. We would like to hear the opinion from the panelists about the two previous presenters. Dr. Isa?
Oh, there's good presenters for both of them. For the first one, actually the hybrid is the way forward, I think. Whenever you discover a complex lesion, you simplify it by using hybrid lesion. But of course, imaging IVERS will assist it so much. And if you can get a good crack of calcium, that's also a must if you're going to put a DCB. So again, for the proximal lesion, DCB, I think still we are looking for more evidence. But I've been many conferences nowadays. The DCB is the way forward. I think like our presenter said, in the proximal part, you need to be careful. As long as the ejection fraction is good, you can do DCB. I did it for 2 minutes. But if your projection is not so good or you don't have a protected vessels, then your DCB can be a recipe of doom. So that's one you want to be aware of. That's my comment.
Professor Wang?
Okay. I have a question for Dr. Lee. I totally agree the hybrid strategy with DS plus DCB. And my question is, do you think in the future, a biosubtle stent, just like a freeze-off plus the DCB, will be the perfect solution for the CAD, especially for the young CAD patient, because they truly fulfill the leave nothing behind strategy? Do you think it's possible, or do you agree this or it's not impossible? What's your opinion?
Thank you for the question. Yes, I think the freeze-off will be a solution for a part of the vessels that we've been doing DCB. But sometimes diffuse disease, which has really long, no stent landing zone with plaque burden of more than 50%, I don't think the freeze-off is the way, because the stent still stays there for 12 months. But during those times, it can still develop. And also like small vessels, I think DCB is there's still a role. So I don't think freeze-off will replace DCB, but it might, for large vessels and all that, proximal and all that, I think freeze-off will be a very, very useful thing. Yeah, please.
The strategy is still changing in the physiology study. Initially, we put a long standing for the diffuse disease, but now the strategy is changing. Spot standing may be better. Just treat only the target, and then we'll get more benefit. So I think the biosubtle stent plus the DCB may be the future trend, I think.
Yeah, I think it will be a game changer, yes.
Dr. Deborah Lee, I would like to ask you a question. If you really want to increase the size of the vessel for the long run, what kind of the drug coating balloon you choose, or it doesn't matter?
I think for now, there's more data in paclitaxel of DCB. So I think that would affect my choice. And there's also more data on late lumen enlargement for paclitaxel. So I would still be going there. And which paclitaxel balloons to use, I think is also, deliverability is also important. Yeah.
Thank you. So, Dr.
May I ask some question for Dr. Deborah? So do you use routinely physiologic study before implant DCB?
Actually, I don't routinely use physiology study, but I think I use it more on like diffuse disease. Yeah. And it also tells me if there's like a focal step up, together with a gradual rise, then he would tell me that the lesion modification there is not good, or there might be some recoil. Then, yeah, like what now the professor mentioned, like there might be a cause for spot stenting in those kind of scenarios.
Thank you.
I have a question to ask you. What what kind of the dissections after or before the DCB would you be concerned about?
Dissection, you mean?
What kind of dissection after the DCB would you be concerned about?
Okay, so I think people who have been doing DCB for the longest time, based on DCB consensus, is type A or B dissection that's acceptable to proceed on with DCB. Type C is a no, but I've seen my colleagues who are really, really experienced in DCBs. Some of the type C, they are able to differentiate which one is high risk and low risk. I've not reached that standard yet. Yeah, but those with type C dissection, I'll be concerned. And I think it's always good to monitor for about 5 minutes after you have vision prep to whether the dissection remains stable, whether there's recoil.
Yeah, Dr. Chung, the last question.
Okay. So I have a question for Dr. Lee. So when we prepare the lesson for the DCB, so the cutting balloon or scoring balloon, which is your favorite? So for the lumen gain is better and less dissection.
Actually, I don't think which one causes more dissection than the other. It's more like whether you know how to use it kind of thing. Like because cutting and scoring has different way of using. But I think both are effective. But my go-to would be usually Scoreflex because I find that cutting balloon is a bit less deliverable. But if I really want to get a good, lesion modification, sometimes I go after Scoreflex or after balloon, just semi-confined balloon, I will go to cutting balloon, where you inflate really, really slowly every 5 seconds kind of thing, and not go too high pressure because as you know, like Wolverine, the first pressure is 12, and so really going slow kind of minimizes dissection.
Thank you. So I would like to back to Dr. Tom Devisia. So we already seen the live case. So if apply your strategy, the hybrid PCI for the previous live case, what you should do for the LAD?
Great question. So what I would do is osteoproximal LAD, regular stand, and distal to it based on your physiology, DB, the quoted below.
So during the hybrid PCI, do you routinely use the FFR to assessment the result after the PCI?
Not routine. It depends on the financial aspect as well. We have to consider the financial aspect as well. But however, you can have an imaging which you have already used up, and based on the imaging, you can decide if you would like to use DCB. If the lesion is well prepared, you can use.
So for the hybrid PCI, usually like you put a stent as short as possible, or what? What kind of the approach for the stent if you apply the hybrid PCI?
So depends on clinical scenario. However, as in this case, I would stand from the ostial LAD till that diagonal takeoff where the lumen is very big. I'm very sure it will easily accommodate a 3.5 stent, and you can post dilate to 4. Distal to it suddenly tapers. It is somewhere around 2.75, 2.5. Anything less than 3, prefer to use DCB.
Yeah. So these are like, so now we back to the CAT lab of the Heart Institute, and we see how the result after the PCI. Can you see the CAT lab now?
Okay.
Yeah, Dr. Minh and Dr. Doan, what should you already did? Please show us.
Okay, so let's take a quick look at the IVUS after we do the rotablation. And as you can see that we can have quite a differentiate of the size of the distal part and the proximal part of the LAD. And we can see a lot of cracked calcification. So as we discussed, we decided to use an NC Pantera level of 30/20 in order to open up the lesion well. And and this is, can you see the angio slide? This is the image is after we pre-dilate one more with the NC balloon 3/0. And at this time, because of the patient has a lot of chest pain, so we decided to do the stenting right away because she was not quite stable. So that we did not try to use another IVUS run after the pre-dilatation of the NC balloon. So this is an 1275 by 35 oscillomycin stent. And as we discussed, we have no worry of the expansion of the stent because we have very good pre-dilatation and also the plug modifications. And then we try to do another stent of 3.5 by 30 oscillomycin up to the middle part of the left main to the proximal part of the LED, as you see on the screen. And we go up the stent up to 12 and 14 atmosphere. And then finally, we do the port with a 4.5 NC balloon parallel at the left main. And because we saw on the IVUS that left main is up to 4.5 something. And then we do another final post-dilatation with a 275 and 3.5 balloon. And let's take another quick look at the final IVUS. Here's the final IVUS, as you see, after we put two stents. Can you put the IVUS on the main screen?
Yes. Yeah, we can see the IVUS now.
Part is, yeah. So the distal part, we have a 275 stent, which is quite well opposed and with quite a good opposition here. You can see from the distal part of the LED stent. So obviously we discussed about the try to do the hybrid approach with the DCB in the distal part and the stenting in the proximal part, but unfortunately I could not find a very good landing zone for the proximal stent. So for safety of the case, we decided to have a two-stent strategy. So as you can see that some part of the stent due to the calcification is a little bit of under expansion, but we have quite a good opposition of the stenting. And here's the left main, and after we POT port by the 4.5 by 8 balloon, you can see that the left main stent is also well opposed and And I really think that Oscillo is quite a very good stent that have a very good expansion because this case we only have 3.5 stent and but we need to expand the stent up to maybe 4.5 and we use the POT by 4.5 and we inflate up to 20 atmosphere and here you can see that is the left main and we can have a very good opposition of the left main here. So because after that we try to use an angio-seal to close the femoral of the patient of this old lady, and now she's quite stable as you can see.
Yeah, thank you, Dr. Ming, for explaining the case. Yeah, and now I would like to get some comment from the panelists. Dr. Isa.
Yeah, it's good result as long as you can get the patient off the chest pain. Is your good diagnosis also still pattern? And of course, I wouldn't argue with a good result as long as you get good opposition of the stent based on your IVUS. That's a good thing when you do a stenting, you can do IVUS afterward. You cannot do that if you put DCB distally. But of course, as we mentioned about hybrid, always is good if you can do that in the distal segment. So I think it's a good result. Congratulations.
Professor Wang.
Congratulations for your result. And my question is, why you need to stent the left main? Is there any retrograde dissection or plaque inside the left main? And the second question is, will you open up the strut to the circumflex
Yeah, the left main stenting is our initial plan from the beginning because we really can see from the beginning CAG and from the IVUS that we have the ostium, the LED lesion, and with a lot of calcification. And after we do the rotablation, we can see a lot of dissection up to the proximal part of the LED. So we decided to put a stent up to the left main to the proximal part of the LED. This is a quite a tricky situation because the LED is only 3.5, but we need an but left main is 4.5, so we need a very good stand that can be expanded up to 4.5, and I think that under the IVUS and also the CAG afterward, we can see a very good flow of the circ. And we can see the ostium, the circ is also good under the IVUS, so that under our practice, we will not try to, as you can see here from the IVUS, we can see the ostium of the circ here, which is quite well. And then we really see that there's no need to put another procedure here in order to open up the strap to the circ. So what do you think about your current practice? Because I know that some of you may open up the strap to the circ, but under our experience, we will not do so.
Yeah. Thank you for the explanation. So basically, you just cross over the stand from the LED to the left main and doesn't not open the strut to the cert. So what do you think, Dr. C. Pirhon?
Okay.
First, yeah.
So I think they do the very good plan and we have very good result already. So for me, the hybrid PCI, so it's leafless behind and the procedure is more simple, but we have more, it's make it simple but safe. So simple and safe is better. So I think this plan is okay already. So for the awesome, the second receptor we put stand from the left main to LED. So we have no compromise. So the flow is good, so no need to open the stop.
Yeah. Thank you. Dr. Chen? Yeah.
So congratulations for your case. Very nice and academic case. So in my opinion, it's a very good job and no comment.
Yeah, I think this is the great case and a very good result. But however, I still want to put the stand in from the left main to the LED first. And after that, if the patient is still okay, no more chest pain, and then we put the drug coating balloon for the mid part of the LED rather than put the two stand. But however, it depends on the reality, because if the patient is unstable, and then the operator should act very quickly, and I think that this is the acceptable approach. And thank you again for the case, and thank you for the team. Is there any question from the floor and for the case or for our previous present? You want to summarize something? Yeah. Okay. So if no more question from the floor and panels, and thank you very much for the case. Thank the team. And now we close this section, and we move to another part. We still got a lunch here and also have got a hand-on station outside. Thank you for everyone.
Thank you, Professor Quang and the panelists. As you can see from the screen, that it is the picture of our team here. We would like to send our greeting from the CAT lab, and we wish you a very good lunch. Thank you very much, and see you again in the afternoon.
complex lesions. Please welcome our moderators, Professor Hồ Thượng Dũng, Dr. Raymond Phong, and our panelists, Professor Đỗ Văn Chiến, Dr. Rangun Ganesa, Dr. Zi Chao Cheng, Professor Hui Chao Pan, Dr. James Patrick Diaz, and Dr. Đặng Quang Hưng. And we also welcome two speakers, Dr. Ngô Minh Hung and Dr. Thanawa Suesat. Please be on the stage to lead the session. Thank you very much.
Okay, good afternoon. It's the time we start the session 3 with the topic contemporary management of complex BCI. I am Dr. Hồ Thượng Dũng from Vinmec Central Ho Chi Minh City, Vietnam. I'm very pleased to co-chair with Dr. Raymond Phong from Princess Margaret Hospital. And I would like to introduce the member of panelists. The first, Professor Đỗ Văn Chiến from Hospital 108, Hanoi, Vietnam. The second, Dr. Zi Chao Chen from Coronary Heart Center, Beijing, Anzen Hospital. The third, Dr. Ragun Ganesa from Zaibi Heart Institute, Policy, India. The fourth, Professor Hui Chao Pan from Department of Cardiology, Tokren Hospital, and Shanghai Southern University School of Medicine. And the fifth, Dr. Jam Patrice Diaz from St. Louis Medical Center. And the last, Dr. Đặng Quang Hưng. And we have the two presentations about a complex BCI. The first, I would like to invite Dr. Ngô Minh Hung from Chợ Rẫy Hospital, Ho Chi Minh City, Vietnam, with the topic, latest update of the bifurcation of BCI.
Yeah, thank you very much for the introduction. Good afternoon, Chairperson, panelists, ladies and gentlemen. It's my honor to be here to give you an update about BCI for bifurcation. So we all know that the guideline from the Europe give us a very good picture for BCI, for doing the BCI for the bifurcation lesion as I showed you here from 2022. And then after that, we have some gap in the trial and then clinical practice. So we see a lot of lesions like this. The patient, in my patient, the non-STEMI very high risk patient and soft slicing. And you can see that on the left side, the RCA, very severe calcified and tortured, and on the left side, the distal bifurcation lesion between the circumflex, LAD, and lemma. So that kind of lesions we cover every day at our CAT lab. So what we should do for this? So today we go through the, let's take a look at the literature and see how. And there's some updates for the BCI for the left main bifurcation lesion. So about 2 stents, provisional stenting, DCB strategies, and so on so far. And we know that 2021 we have the EBC man coming out with us. So what happened after 3-4 years after that? So we can take a look at 1 year. EBC man show that the provisional stenting still okay for provisional stenting, not 2 stent like a Coulomb's decay crush. But the 3 year, 4 year later, what's happening? Okay, this is the 3 year later. Last year they published. Last year they published this one, and you see that the provisional stenting, if we we choose a good lesion for the patient, and we also have the good outcome. First, some doctor, they still put a question on the true bifurcation on this trial. And then we take a look at deep inside this result, and to see that if the vessel diameter is under 3.25 and the length of the side branch is under 10 millimeter, the result is still okay. But if the diameter of the side branch is more than 3.25 and the length is more than 10 millimeters, so the outcome of the provisional tenting may be different from the beginning. Okay, so we have to take a look at that kind of lesion. So shall we put the stand for the side branch? If the lesion at the side branch is around like more than 3.25 and the length of the side branch lesion more than 10 millimeter. Okay, and the side branch still has it's still a main problem when we do the bifurcation lesion like this. So according to EBC man, you can see that about 2/3 of patients have the lesion instant restenosis after 1 to 3 years. 60% this happened at the circumflex. Okay, so we have to pay attention, much more attention on this lesion. That's the reason why they put the another research here, just published last year. Okay, they compare the treatment strategy can give us a different result. If we have the true bifurcation and we select suitable strategy, so the result almost acceptable. But on the picture B, you can see that it's non-true bifurcation. If you put the two stand for non-true bifurcation, the outcome is totally different, and that's about indication. So if we have the bifurcation, very simple bifurcation, but we worry a lot about the side branch, and then we put two stand. It means that we put the extra stand for the side branch. The outcome will be worse than we think. Okay, so about the left man bifurcation, you see that the true bifurcation had the worst outcome compared with the non-true bifurcation. And with the non-left man bifurcation, the outcome quite acceptable with a low ISR and low target vessel revascularization. Yes, and we all know that we have to use the DK cross technique in order to treat for the bifurcation lesion, especially with the left man. But sometimes we don't have time. We don't have the enough medical equipment, and then we switch to the mini cross. So this paper published last year showed that the modern this is performed in Turkey, and they compare between the DK crush and mini crush together with the name that the Evolute Crush Left Man Study. And you can see that the outcome is quite acceptable, non-inferior between the mini crush technique and DK crush. But take a look at the some parameters. You can see that the for example, at the Macy's, the mini crush is a little bit higher, but not significant different. Okay. But the so we go back to the trial, the DK, the father of the place where the DK crush coming out in China, Dr. Gao and his team this year still published the result from DK crush with the IVERT guided compared with the angel guided BCI. So you can see that with the IVERT guided BCI for the DK crush technique, so you see that 6.1% of target lesion failure compared with 14.7% of the which we use only angiography in order to guide the procedure. Okay, that's the reason why if we have time, we have the device and we have the good indication like a true bifurcation. So we have to go back to the DK crush, that's the information from the trial. And then we also talk a lot about the proximal rewiring or distal rewiring for the true bifurcation. So this study just published, and you can take a look at that. So they do look at the proximal and then proximal, proximal and then distal. It means that we have the two times we have to wire the lesion twice. The first time we have to wire proximal, and then the second time we wire the distal. So they take a look at the man up position, arterial wall stress, shear rate, and then the time average endothelial shear stress also. So what is that for. Okay, so they said that according to this trial, analysis, they say that if the bifurcation under 45 degree between the man and the cypern, under 70 degree, and then about more than 90 degrees, mean almost 100 degrees. So you see that if the bifurcation angulation, the angulation at the bifurcation is around like a perpendicular between the man and the cypern, so we shouldn't perform decay crust. The angle, the ideal angle for the decay crust in this situation is around 70 degrees. But you have to wire the lesion. The first wiring is proximal and then proximal, and the second is proximal and then distal also okay. But if the angulation is under 45%, under 45 degrees, so you have to rewire to the cypern distal and then distal. That the result from the paper. Okay, and we all know that we use the DCB for the bifurcation in order to let the procedure less complex, keep it simple. So this is the result from Dr. Gao and his team. It was that 1 year follow-up that the group with the DCB had a good better outcome between compared with this group where we have to put the high pressure balloon, and the DCB give the better outcome than the non-compliant balloon. Okay, so this is the paper from Dr. Ishihara just published this year. It was that if they have the group bifurcation and then we use the DES and we keep that for the cypern for DCB compared with the non-DCB for the cypern group. So we can see that with the DCB group, 8.1% cypern restenosis compared with 18.3% restenosis. So one more time, we have the very good outcome with the DCB for cypern at bifurcation. And we are waiting for the result from the IKIS trial that they performed the kissing balloon at the bifurcation, left main bifurcation lesion. And I think that we have this year or next year, we have to go have the result of this. Okay, about the non-left main bifurcation, just some updates for, we all know that we have to wire the cypern and membranes in order to protect the cypern, and it's very important action in order to protect the cypern. And you can take a look at this paper. The gel wire at the cypern have some role in order to protect the cypern. And then we do the kissing trial. If we worry a lot, we do the kissing for the cypern. And you see that the result is not support for the kissing balloon. If the cypern is not the timid flow, not the 2 or 3, not a 2 or 1, timid 3 flow. So we shouldn't do any kissing for this because it can cause some trauma for the cypern, and the outcome is not very good for the cypern. And one more time, we take a look at the DCB for the non-left main bifurcation lesion. If we have the bifurcation lesion and we just want to put the DCB versus we put the DES, so you see that 6.7% with the DCB group, and compared with the DES, the 5.3. So it's not significant difference between the two groups. So it's acceptable with the DCB. If we don't want to put any stent for the patient, for example, with a high bleeding risk or some high-risk patient, we don't want to keep the DABT for long. Okay, but non-bifurcation lesion, we shouldn't use the DCB because the DES had a better outcome compared with the DCB. Okay, and the updates about the device in order to use for the bifurcation lesion intervention. So we all know that we have to use the intravascular ultrasound or intravascular picture like OCT in order to have the good information from inside the vessel in order to have the good strategy for the lesion. So this is class A classification recommendation for us in order to apply in the clinical practice. And about the FFR and IFR, also the class 1A for the indication. And then this is the guideline from the Europe, and guideline from the US also have the same indication. Okay, about the intravascular image, OCT and IVUS. So when should we use the IVUS or we use the OCT? So this is the picture that we should use the IVUS in order to guide BCI procedure for the left main, the left vessel, and deep penetration of the when we require deep penetration, and here we calcification and some the impairment. We use the less contrast for the patient, and if we want to have the very precise the information from inside, so we have to use the OCT and require for the lesion. For example, we would like to rewire the lesion at the proximal, mid, or distal to the atrium of the sideburn, so we have to use the OCT, etc. Okay, so in some situation we have the MSCT, so we can use the MSCT in order to guide for the bifurcation lesion with the modern MSCT coronary computed tomography, angiography guided by bifurcation intervention. We can set up where is the true bifurcation and where is the one we would put the stent in. For example, in this picture. So if we don't have the OCT or IVUS, we have to use the some function of the CR machine, for example, stent booster, stent boot liner, to make sure that we don't put the balloon outside the stentic segment like this. And with the how about the FFR angiography derived FFR versus IVUS to guide the PCI for the bifurcation lesion. So this the analysis, it gives us the information about the composite lesion risk score. If the composite lesion risk score is high, so we have to use the IVUS in order to guide procedure compared with the less risk score, because the information from the IVUS give us a lot about the calcification, diameter, and the length of the vessel also. And recently we have the combine the two study together, October trial and DK Cross 8 together, and we still have the good result from the primary endpoint if we use the IVUS or OCT in order to guide the bifurcation lesion intervention. And of course, in order to do the intervention for the bifurcation, we have to understand the expansion of the stent. For example, this is the chart of the stent available in Vietnam. For example, Lion, we can go up with the until 9.7. With the Octeron Mission, we can go with up to 4.5. And that's the information that we need to know, because if a vessel bigger than that number, we have to select the other stent in order to get the good apposition. And in some situation, we have to use the mechanical cardiac support in order to support for us. So successful success with the around 24%. If we have that kind of device, we have more time, and then the number of vessels, the number of lesions can be increased with because we have more time in order to do the intervention like rota, and we do the ablation, etc. And about the DABT for the bifurcation, this year we have the result from the MasterDAP trial, and we can see that if we do the good intervention for bifurcation, we can stop the DABT, and we switch to the single antiplatelet therapy, and we protect the patient from the bleeding, from the major adverse cardiac event also. And this is my practice point every day. So we have to we can see that the provisional stenting remain the default strategy for almost every lesion, and the true bifurcation is totally different with the automatic two stent. As I mentioned with the EBC man result after 3-4 years, because it's a true bifurcation, but the very short length of the siphon. So sometimes we don't need to put the stent, we just do the DCB. That's the clinical point. And third one is the assess the siphon size, the length of the lesion and myocardial territory in order to know that this is very risky for the patient or not, because we have to put it into the clinical practice in order to select the good strategy. And the fourth one is we will have to wipe the siphon before we do any stenting, in order to protect, keep the siphon patent. And POT is very fundamental in order to the bifurcation. And the sixth is the after-man vessel stenting. Rewiring is a critical step, not a trivial maneuver. And kissing balloons is selective, not mandatory, because sometimes we don't need to do too much trauma for the vessel, because it can cause the dissection, and it's if we lost the flow after that. If two stents are required from the complex lesion, so decay crust for the left man, for the left man should be considered compared with other. But however, we have to think about the angulation of the bifurcation. If it is perpendicular with the main one, so we have to use like a T-stent technique or reverse T or something like that. And if the angle is smaller than 45 degrees, so sometimes we have to rewire to distal when we compare with the angle is bigger. Angle is bigger. So iversorosity is the tool that we have to have in the cath lab in order to support us to have some more information and in order to put the stent, make sure that the stent have the good apposition and expansion. And the goal is not the angiographic perfect picture. It is durable, well expanded, and well opposed stent and architecture with the preserved siphon flow is very important. And this is my patient again. So we just use when the patient came to our cath lab, we just use the CDOY in order to open the right first, and then remove the and within the intubation 5 days later, and then we bring back the patient to the cath lab for the stack PCI. So this is the hemodynamic at the cath lab when we just bring the patient back to the cath lab, and we have to put the IBB there, and in an inotrope with the inotrope and IBB, when we just you can see that very severe calcified lesion on the flow roll. And this is the rota. And under the support of the IBB and the inotrope, we do the ablation for the left main LAD, and we just keep it simple, as I told you that we have to protect the diagonal with the 1.5 balloon, and we use the protection balloon technique in order to protect the diagonal. And you see that the diagonal still patent and the timid free flow. And we take a look at the second bifurcation at the left main LAD and circumflex. So I use so the picture show that the protection balloon is the 1.5 at the atrium of the diagonal, and the stent at the main one. And we have to go up with the sideburn first, then the stent later, and and this is the 2020 balloon, DCB balloon at the atrium of the circumflex, is the DCB. So I just put one stent from the left main to the LAD, and the final picture is acceptable, and the 3 flow without significant residual stenosis. And you can see that the diagonal still have a very good flow, and the circumflex also have a very good flow. And this is the final result. I use the rotatipsy for the left main LAD lesion, use the DES for the left main LAD, use the protection balloon technique for the LAD diagonal, and protection balloon with the DCB in order to protect the atrium of the circumflex. And this is my conclusion. Provisional stenting is still the default strategy for the vast majority of lesion. Two stent technique, especially with the DK crush technique, remain essential for select complex through bifurcation with a large sideburn territory. And DCB has matured into a viable, effective option for sideburn management and intracoronary imaging and physiology. The guidance carry a class 1 recommendation and should be used routinely in complex cases. And technical precision. For example, we have to do the pulse, we have to do rewire, proximal or distal. We have to select KBI or not KBI. It's remain non-negotiable. And hemodynamic support in some situation we have to think about, because the last remaining or the very huge myocardium, we have to use the mechanical support because we have more time in order to stay with the patient, and we do finish our procedure like my patient. And sometimes we have to cope with the high bleeding risk patients, so we have to think about the complex procedure and simple procedure in order to make the DABT shorter for the patient, is protect the patient from the side effect of the anticoagulant or anti-platelet therapy. Thank you very much for your kind attention.
Very much, Dr. Ko. So our next speaker is Dr. Thanawat Suset. He's from Khon Kaen Hospital from Thailand. And today he's going to talk to us about the treatment algorithm of calcified lesion modification. So please, Dr. Suset. Thank you.
Thank you for your kind introduction. My name is Thanawat Suset from Khon Kaen Hospital, Thailand. Well, first of all, I would like to thank Vietnam National Heart Association for inviting me to share my talk today. It's a great honor to be here. So today I will talk about the algorithm calcium lesion modification. I have no disclosure. So chloride calcium is extremely common in daily practice. Its prevalence is increasing with age, also sex dependent. For the patients with age over 70 years, you can find prevalence around 90% of men, and for women, for around 70%. The risk factor is be quite familiar with the risk factor as one is hypertension, diabetes, dyslipidemia, CKD, and also male sex. So our patients have many risk factors together in one patient to do. Recalcification cause the vessel or stiffness and loss of compliance when compared to the fibrotic plaque or normal plaque. So they lead to complication. Calcium, we know that the calcium is chloride. So we think about the complication when we deal with the PCI or the treatment, or cause the complication entire the procedure. When we try to aggressive dilatations, maybe cause the infection or perforation. And if we try to put the stent, it's so very difficult to use the many devices to do it. And of course, it's a limit to stent expansion. And after we put the stent for the long term, it causes subsequently stent lesionosis in very early over the time. We have the data that the patients with too severe calcifications have the higher risk of target vessel failure in 2 years compared to the no severe calcification. Also with the definite stent thrombosis, around 1.8% compared to 0.4% in this group of the no severe calcification. Traditionally, when we classify or diagnosis the chloride calcification, we see from angiogram. For my classification, you only see the spot of the radial plaque And for moderate calcification, you can see the single wall of calcification with the cardiac motion. And if severe calcification, you can see the double wall of the vessels in without cardiac motion. Anyway, if you do only angiogram, is underestimate calcium detection. From this angiogram, you cannot see calcium in the LAD. But when you put the IVAS to the mid-LAD lesion, you can see circumferential calcium in the mid-LAD. So angiogram underestimate and IVAS or imaging is to increasing the sensibility to detect the calcium. When you do the PCI without imaging, the same like you drive swing in the night without to do not turn on the headlight off. You cannot see anything. You cannot see which way to go. But when you use the imaging, you can see everything clearly. You know which way lights are left to go. So for OCT, imaging is more advantage because the OCT can measure directly the calcium thickness, benefit over IVAS angiogram. So first we know how we detect calcium from imaging, OCT or IVAS. First feature, the superficial or the deep calcium. Superficial calcium is directly limit balloon dilatation and stent expansion, so usually require calcium modification. For the deep calcium, maybe you use a conventional balloon, AC balloon or special balloon to manage. The second feature is the calcium arch, concentric or eccentric. For the eccentric lesion, it has the higher risk of the dissection or population opposite side of the calcium. But for the concentric lesion, is the too high risk for stent under expansion if you don't do calcium modification. For the third is length, less than 5 millimeters or more than 5 millimeters. So if more than 5 millimeter length of the calcium is usually require calcium modification. And the fourth is the thickness. Thickness less than 0.5 or more than 0.5 millimeter. Okay, OCT can measure it directly to measure direct for the calcium. But when you use the IVAS, when you see only acoustic shadow behind the calcium, you assume that it's calcium. But behind the calcium, if you can see some plaque or anything, you assume thin calcium. So, and finally, nodular calcium nodule. I think it's the one of the special phenotype of the calcium that very difficult to manage. Even you have many devices nowadays, still to have the high rate of restenosis, even you use many devices. After you know that how to measure, so the next step, you calculate score, the calcium score. For the IVAS, we have the 4 point of calcium score. One from the calcium arcs more than the 3 quadrants, and plus length more than 5 millimeter is 1 point. Second point is the circumferential calcium. The third point is the calcium nodule present or not present. And the last point is the vessel score 2 or more is all require the calcium modification. For the OCT, okay, I have the 4 points as I watch, but first the arch of the calcium less than half of the vessel or more than half of the vessel. If more than half of the vessel, 2 points. And the thickness, okay, if more than 0.5 millimeter, 1 point. And the length, if more than 5 millimeter, is 1 point. For the OCT, if the score more than 3 or more than that, is to require calcium modification. So, and how device or which device do you use? Nowadays we have the many devices. Usually we use the traditional balloon, AC balloon or special balloon as scoring, or OPN with a high pressure balloon for the deep calcium or in the normal practice. But for in some case that the high calcium score, we need to atherectomy as the rotabation, orbital, or maybe laser, even intravascular lithotripsy. If device you should So how to use the device? Please look the lesion first and let the lesion choose the device, not device choose the lesion. So if the low calcium score, okay, you choose the tradition device, NC balloon, cutting balloon. And if you need to require calcium modification, please consider about the rotational atherectomy, orbital, lithotripsy, or excimer laser, and row or row. So this is the overview of calcium modification with difference for mechanism. Rotation, you know, there's a front diffraction cutting, orbital you to diffraction sanding. You can use antigrade and retrograde. Laser mostly work with the photoablation. Lithotripsy work the acoustic pressure to create the calcium fracture inside the vessel. This is to demonstrate that the use different device in the same lesion, similar lesion. If lesion is have the eccentric calcium at the mid LID opposite the diagonal branch. First case due to rotation atherectomy with wide bias. So the rotator is just to cutting more in the greater curve. You can see. So after you do atherectomy and put some SC balloon, you can see the imaging. You can see that even the lumen gain from balloon dilatation, but the calcium not cut by the rotation atherectomy. Calcium still here. Compared to the second case, the similar lesion, eccentric calcification, opposite side, the diagonal branch. This case, you use orbital atherectomy, and you use to antigrade and retrograde sanding. You can see that the device move or is a curve, and after the addition dilatation and do the OCT lesion, you can see that calcium before atherectomy and calcium after atherectomy. The atherectomy abrades some calcium. You see this. It is for demonstration. But in some cases, you maybe need more more combinations between many devices, maybe rotations with shock, IVL, or orbital with shock or cutting balloon. Of course, the higher cost if you need to more device. So for algorithm, it is from European consensus algorithm for manage for severe calcified lesion. So use with the imaging, also intravascular imaging first. The first step, you can put imaging catheter, yes or no. So if you cannot put the imaging, maybe you can additional small balloon dilatation and help you to put the imaging catheter. But if fail, you can consider the rotation atherectomy first to put the device. But if you cannot put the rotawire, laser may be considered. So, but in case you can put the imaging catheter, okay, you calculate calcium score from OCT or IVAS. So it's a low burden of the calcium to use with the conventional device, NC or cutting balloon. And for those with the high calcium score, you may require to atherectomy or calcium modification. And then you can see the result again. Imagine once again that the calcium cannot collect or not collect, can gain or not gain. And if everything is pretty good, okay, you proceed to and do optimization of stent. But it's still to you don't happy, okay, maybe you repeat again atherectomy or to use any device. And finally, after you put the stent, once again, staging to check stent optimization. It is to show that after you do the calcium modification, you can see the collapse of the calcium from the IVAS or OC here. You can see for the lumen gain before and after calcium modification. You can see the ablations of nodule, debulking of the calcium nodule before and after debulking. Okay, let's see the real case. from angiogram. This 80 years old man with hypertension, DM present with non-STEMI and echo show anterior wall hypokinesia. The target lesion is proximal LAD. You can see severe calcification. So imaging first. For this case, you can put the OCT. So we calculate the score. This patient have the circumferential calcium 2 points. And you can measure the calcium thickness, maximum 1.2 millimeter, 1 point. And the length more than 5, this cat around 10 millimeter, 1 point. For this patient have the full score, 4 point of the calcium score from OCT. So we know from OCT, this is superficial calcium, the high burden of the calcium. Okay, I think balloon can possible. So from algorithm circuit us to do the IVL from the algorithm. For this case, measure the size of the IVL 1:1 to the vessel. I use the 3 by 12 centimeter IVL. So after we use the around SD pulse of the IVL, you can see the final that the calcium was flat. The angiogram looks pretty good. And from the OCT, you can see the crack of the calcium in the right size. So after calcium cracks, the next step. Then, so this patient put the stent 3O by 22 millimeter and postulate with the NC balloon. And finally, even with success, the stent is not finished. Good to look the post-assessment. This patient have no dissection, expansion okay, and complete export. So finish the case. This is a common demonstration of the imaging and calculate calcium score for atherectomy or modification of the calcium. Let me to the second case, 65-year-old male with hypertension, cardiac MRI, straight head positive, anterior wall ischemia. So you can see the tight stenosis at the mid-LAD with the calcification. This patient, I use a small balloon 1O and 2O to gentle pedalization to try to put the IVAS catheter to the mid-LAD. You can see the arc of calcium, the more than focal, and you can see some circumferential calcium here. So for this case, do you choose IVL, rota, or orbital atherectomy? Okay, this patient score we calculate total is required atherectomy. For this patient, IVL is quite too bulky. It cannot add to the mid-LAD lesion even we do the pedalate before. So we choose about the rota or orbital. The rota, I think, is too wide bias and maybe need to more one burr to do the atherectomy. So for this case, I use the orbital atherectomy is a low speed for 25 seconds. And you can see the after orbital atherectomy, it looks better. And then we put the stent. So all the final case more complex. 70-year-old male status post PCI on circumflex and RCA tented with non-STEMI. You can see something in the left main. Looks hesitant here. So calcium nodule was suspect from angiogram. So we try to put the imaging catheter IVAS with the addition with the pedalization with small balloon first. You can see the very tight calcium nodule involve left main bifurcations and protruding to the left main lumen. So for this case, even be just one score, but you can see that severity of the calcium nodule and two very tight stenosis. So for this case, we use atherectomy or calcium modification. Start with the rota first, rota to the LAD and to circumflex. In this case, to high risk, we use the balloon pump for hemodynamic support. is usually used in Thailand. And after two rotator atherectomy, we use addition with the IVL 3.5 to the circumflex and LED, and followed by scoring balloon 3.5. And then from the population, I think it's okay. So put the stent for this case. We with bifurcation lesions. After you look the lecture from previous speaker, you know that this patient need to require two stent. So this case I do the two lot and stent with 3.5 and port with NC 4.5. This is the final result. I think it's okay. It's to achieve minimal stent area, happy with the neocarina, and stent area from osteal from the LD and circumflex. So this is just demonstration to use algorithm to the PCI in calcium lesion for modification or not. The take-home message: intravascular imaging is very, very essential for to do the PCI nowadays. Because angiogram is just underestimate to do the calcified lesion. And after you put the imaging, right, you need to characteristic the plaque or the calcium, length, thickness, depth, and morphology. And then choose the device from the lesion, not the lesion, not the device choose the lesion, but you see the lesion first and choose the device. Okay? And after you see the calcium fracture or not, finally re-image again to verify and optimize stent optimization for the long-term outcome. Thank you for your attention.
Okay, thank you so much, Dr. Thanawat Suset. So we have two presentations, and we have a remaining about 50 minutes for the question and answer and discussion. So by now, the time for the first speaker, latest update of the bifurcation BCI, Dr. Ngô Minh Hùng. So I invite the panelists have a comment, a question for the first speaker.
Sir, it was a nice extensive talk on bifurcation PCA. Now the data is coming for a double kissing culotte. So how is your experience and what's your view on double kissing culotte with decay crush?
Yes, thank you very much for your question. Actually, I also I think that in Vietnam, I perform around more than 50, 60 cases with the double kissing mini culotte, not culotte. So that the procedure that a lot, but the 1 year outcome is quite acceptable. But we have to follow the protocol: kissing, first kissing, and then second kissing, and then for also final post like normal. So but we have the device consuming a lot, you know, with the double kissing mini culotte, like decay crush. So that's also. I love that procedure, but nowadays we just use that for the very strict indication. For example, if we have the two vessels with the same size, for example, 0.9 to 1 or 1:1 is very good. That's the very good candidate for the double kissing. Of course, we have to have the true, very true bifurcation. With very short, I don't want to put two stents like my case. And I think about the literature also has a small number of the decay mini culotte, but not much data about that. So actually, in the whole nation, I also call some doctor from Vietnam come together work on that procedure. And I think in the near future we have the number is bigger, and we have to collect the number and then see how. Thank you.
So I'm Dr. Chien from Vietnam. I like Dr. Thanawat's presentation a lot. So, but actually we don't do it like in Vietnam so far, because the way you do very educational, step by step, very academically, but it's very costly. So in our opinion, just to make simply like you go straight forward for the IVL. So we do not start with the NC balloon or other device. It may cost because the IVI, like OCT, IVERS have shown you that the lesion is very complex because now we are get older and older, and then we can see that maybe we can simplify procedure. So how do you think?
So for in Thailand, even we try to follow the algorithm, but the decision of operator, it depends on reimbursement or not. So in Thailand, IVL and orbital atherectomy recently available in Thailand, but would not reimbursement. Or if the patients need to use this device, the patient need to pay by themselves. So in many cases, we try to use just the NC balloon, cutting balloon, and rotation atherectomy. This is in opinion. But if you can use everything, I think the algorithm is okay for the beginner to just to practice. So because in some time rotational atherectomy, you need to require to a long time of the experience. So IVL is, I think it's very easy to use. So the algorithm, if you cross the balloon, IVL first. This is my opinion.
I have one question for the second speaker. You know, the antiquated modification is critical for calcified lesion before standard implantation. But the over modifications might cause vessel injury, such as a huge dissection or the perforation and any other complications. So my question is, when to stop further plaque modification to avoid the vessel injury? So how to balance the risk and the benefit? Thank you.
Okay. So for atherectomy, okay, you know that it's to need to experience and maybe complicate with the complication. Your question is when to stop, okay, to risk benefit. Okay, first in my opinion, in my practice, when you shoot atherectomy, the vessel is population is not to dissection, is not to sometimes to accept to minimal dissection, maybe use the atherectomy, LOTA, IVL, or orbital. But in some case, to severe dissection, in some case, you cannot put the imaging guide, and you try to small balloon. Even sometimes you think just a little or gentle dilatation, but dissection is severe. So in that case, I think maybe the atherectomy is not proper to do. That is just my opinion. But today you can ask my master, Dr. Wasan here.
Afternoon, doctors. Thank you for the wonderful lecture. Dr. James Diaz from the Philippines. I have questions for our two speakers. First for Dr. Hong, who discussed the bifurcation lesion. So in provisional stenting, doctor, and the side branch is not compromised, do you routinely open the strut or you just let it? Like, I think the Japanese likes to open the strut after provisional stenting. And second, for Dr. Susat, for the calcified lesions, do you routinely do CT angiogram planning prior to your PCIs?
Yes, thank you very much for your question. I think it's up to the non-left-man or left-man bifurcation. It's the left-man bifurcation, so I think we wait for the IKIS and we have the final answer for that. But for me, I usually open the cell of the side branch whenever I see like a TME flow limit, like a TME 2 flow or TME 1 flow. So of course we have to open it, and the rest is up to us. we don't need to open because we have to open it, so we have to prepare it, kissing it. So we have to do a lot of things. So it's a left man, but with the non-left-man bifurcation, so I think crossover and symmetry flow under 70% stenosis at the atrium, just leave it about 7 to 90% is up to the TME flow. And of course, 90%, sometimes we have to rewind and open what's the smaller balloon, for example, from the atrium of the cypern. And we have the reference of that, so we just minus 0.5, and we just open it in order to get some more flow, and this is set for the atrium, because we open the same side with the vessel, maybe it's got some dissection. So with the dissection, so we have to control it. If we don't control it, so we can cause like a acute closure for the cypern. So sometimes we have to open, but such a smaller balloon, and we have to get the reference from the atrium of the cypern distally 15 millimeter in order to get safer for the cypern. That's the current protocol for the cypern open. And I think we still waiting for the IKIS trial. I think coming out end of this year or next year, we'll get up the result for the left man lesion. Thank you.
For the non-left main bifurcation, whenever you decide to rewire, do you rewire from the proximal or distal strut usually?
I think according to the trial, currently the trial, as I updated, the thing usually they open the distal cell of the stent, and then we make it to the cover the proximal outer atrium of the cypern. That we need some like drug go to the cypern. That the theory, because it's up to the bifurcation angulation of the bifurcation also. So with the angulation, I show you the picture that with the angulation like 90 degrees, so it's quite very perpendicular. So it's not necessarily like a proximal because it's not used, but like under 40 degrees. 45 degrees, so very, very strictly distal, and go to the make it opposed to the proximal of the cypern. That's the theory. So smaller angulation, we have to go further, and we open the cell. And perpendicular is up to the Y. It's go anywhere, and then I think it's not like a not significant difference. Okay.
For CT angiogram, right? So we know that CT angiogram nowadays data show that have benefit to procedural planning. But in my routine practice, I don't use CT angiogram before PCI because they have the additional cost. But except in CTO case, in some cases too very difficult that are more fail before. But in another hand, if the case sent from another hospital refer or from general cardiologist, maybe they do the CT angiogram first. And so we know how this case have the many severe calcification. So we plan that this case have maybe have the very difficult or maybe to have the complication when we do the PCI.
Thank you, doctor.
Okay, I have two questions. One for bifurcation and another for the calcium classified lesion. The problem is that, as you mentioned in your slide PPT, the left-main bifurcation, the strategy of from maybe the main branch stent and the side branch DCB treatment strategy, and how about your opinion about the sequence before stent deployment, do the DCB treatment, or after? The first question for bifurcation, and the second one for classified. What's your opinion for the calcium nodule? Because it's a big barrier for our procedure process. So thank you for these two questions.
Yes, a good question. I think it's according to the with the true bifurcation. So I think still a lot of argument between the operator to operator, because we tend to stay away from the stenting. So sometimes we have to prepare the lesion, the cypern lesion, and then we do the DCB. But sometimes after that, cause a lot of dissection somehow. Because before that, I still remember that the year the stent from Biotronic, that they did a bare metal stent. They did a DCB, and then it caught dissection, and then put the bare metal stent. It's okay. But nowadays it's called a dissection, so we put another stent. So stent and the DCB at the same location, same position. So not the like a cost effect. So according to the DCB BIF from Professor Gao from China, I think is that also the protocol for that in order to practice in clinical practice, that they after the stenting from the main one, and then you see that some residual synaptic at the orthogonal side plan that rewire the lesion. Of course, before that we have to do the BOT first and rewire to the distal, and then we do the ballooning with the NC balloon. Hit the NC balloon and then you put the DCB. That's the protocol. Okay, but so you see that the very good outcome with the DCB group compared with the non-DCB with the only NC balloon only. That's the protocol. And I think they still have another opinion that they put the DCB and then they put the standing. But we have to be very careful because it's after we do the standing BOT and then it's called the severe significant at the atrium of the cypern. So in that situation, we have to think about what we put the stand or not stand. That's the thing. But another thing is the after standing. Some people say that okay, because we put the DCB in, so it go through the cell of the stand. So it scratches the surface of the balloon, so the blood go away. So how? But I think that nowadays we have a lot of device like a attention guiding catheter, like a Guidezilla or Guide Floss or something like that. So I think it's very easy to go directly to atrium of the cypern. After we, of course, we prepare very good preparation already. So the balloon just coming and then we do the ballooning, DCB balloon for that. So I think it's also okay. So for the second opinion about the worry about the DCB, after the stent and the stent, the drug on the balloon go away. So I think it's nowadays no need to worry about because we have a lot of device to protect the balloon to the destination before it finish up with the itro on the lesion. Thank you. And you asked about the second question is about the calcified noodle. I think we have the very good publication from the Mount Sinai from Dr. Kinney. She had a very good protocol for the calcium noodle because with the calcium noodle with a very severe calcification. I think you guys, some of you will read that paper, and I love that paper also because when you look at the lesion, for example, the lesion like this colleague from Thailand. So you have to see that at the calcified noodle is under 1.5 or beyond, bigger than 1.5 or less than 1.5. If less than 1.5, sometimes we have to use the rota ablation. Ablation may be the orbital atherectomy or the rota. And if the bigger than 1.5, so it's very easy to put the IVL in. So we can use the IVL. It means that balloon-based approach. And if it's smaller one, so we have to use like rota, and then it's up to the picture like after that. For example, the picture after that is still has severe deep calcification, so we have to use one more IVL. So rota tips is like my case. After rota and then still very deep calcification, so use the 80 post on almost everything one for that lesion, and very good outcome. We hope that final the long-term outcome is okay. So I think the protocol from the paper published by a group of the Mount Sinai, New York, are very good for us in order to follow because we have the very good they use the OCT and IVUS in order to classify, and with that the result is very promising. Thank you.
Yes, for calcified nodule, I think it's very difficult for me to manage. I think nowadays we don't know exactly to manage with this lesion, but in my concept, the calcium nodule is a combination between the superficial calcification with the deep calcium in the same calcium. So the device, you need to ablate the superficial, and the device need to the fracture to the deep calcium. So in my opinion, I ablate superficial first, maybe from rotabator, is a common use, and maybe deep calcium. I usually use the IVL to fracture the deep calcium. Anyway, the result still too high stenosis over time.
Sir, if you get a post-stenting under expansion because of calcium, I got some 2 cases from other hospital which was done without imaging. But after stenting, they had under expansion, which they referred to me. I used IVL. It got a good expansion after the stent has been deployed. So what other strategies you use if you find the under expansion because of calcium after stenting?
Very interesting. You use IVL after stenting again.
Yeah.
Oh,
Okay, thank you so much. I think to talk it about the complete BCI, very interesting, and certainly there are many questions for discuss, but the time is stop. So thank you so much for 2 speakers with very interesting 2 presentation. And if we have a question with speaker, we can get the contact directly speaker. Thank you for every panelist.
Chắc năm sau đổi hướng đi TCP nhà và đi nhiều quá họ đi câu.
Good afternoon, everybody. Welcome to the afternoon.
So, ladies and gentlemen, now this is the time for the session number 4, live case 2, with the topic Leave Nothing Behind. So may I introduce the moderator, Professor Trương Quang Bính and Professor Giang Phang Duo, and the panelist, Professor Lý Yun Liu, Dr. Chu Xiang Kiong, Dr. Raymond Phung, Dr. Hoàng Văn. And may I introduce the two speakers, Dr. Chi Tung Chen and Dr. Phan Tuấn Đạt. Please be on the stage to lead the session.
Anh để tín hiệu nhá.
Hi, everybody. Good afternoon. We're going to start this section. This section going to have one case and the two topic. My co-chair is Dr. Dr. Bin. Okay, yeah, it's nice to meet you. And also there's a moderator from Vietnam. Yeah, could you introduce them?
Yeah. This session we have one live case and two presentation, two lecture. The first we have 1 hour for the live case from 19 August Hospital from Hanoi. Please connect to the CAT lab now.
So, good afternoon, everyone. So, dear distinguished chairman, also the panelists. Can you hear me?
Yeah, I hear you clearly.
Yeah, thank you, Professor Bình. So, I'm so happy to be here today to do the live case, the second case with all the excellent team here. I'm Dr. Hoàng Vũ from University Medical Center, Ho Chi Minh City, and next to me, Dr. Phạm Nhật Minh from 198 Hospital. And on the staff here, we have Dr. Phan Đình Nghĩa and also Dr. Lê Văn Đạt, and we have a lot of nurses help us to do the case here. Anh Tuấn, Nguyễn Văn Tú, Phạm Tuấn Linh, Lê Cương Duy, Phùng Tường Nguyên, Ngô Thanh Tuyền. Yeah, so we have a lot of staff here to show you I think this is very interesting case and also very difficult to make the final decision for the case. So let me introduce the case with Dr. Minh will introduce the case to all of you today. Please, Dr. Minh, please.
Good afternoon, everybody. So welcome all of you to the second live case from the CAT lab of our 198 hospital. So today we have a case that we intended to do the leave nothing behind or DCB hybrid with BMS approach. We have a 71-year-old male patient. He has a lot of comorbidity with hypertension, dyslipidemia, and he as a current smoker, and he has a prior surgical repair of the rupture of the sinus valve several years ago in 2000, and he has a little bit high of cholesterol. As you can see, that's the total cholesterol is about 4.6 and LDL-C of 2.41. And this time he admitted to our hospital due to extraction of the chest vein radiating to the shoulder about 5 minutes, and he has an acute episode, and we admitted him to the hospital due to phase of ACS. And under the medication, we are giving him aspirin, rosuvastatin, vancomycin, bisoprolol, trimetazidine, nicorandin, and pantoprazole. Can you have me the next slide, please? And we have no significant examination and echocardiography with quite patent blood pressure and heart rate. The LVEF is 64, quite normal, and with no rational motion anomaly. And he has troponin T and D-dimer negative, and ECG shows the sinus rhythm, and CXI is normal. And so we have the diagnosis of an unstable angina, and we put him on the CAG a couple of days ago. And can you see my next slide, please? So this is the ECG. So this sinus rhythm and no change in the ST segment. Next slide, please. CXI is normal. Next slide. So here's the ECG that we done a couple of days ago. As you see that we have a quite tight lesion of the proximal part of the LAD, and what is special in the case is that we have a bifurcation, which is quite a significant lesion at the ostium of the diagonal, quite close to the to the proximal part of the lesion of the LAD also, and we have a quite narrowing of the distal part of the LAD. And can I have the next slide? And here's some other view showing of the true bifurcation. I think that maybe Medina 111, as you see from the CAG that we have. And next slide, please. And luckily, we are going to have a quite a normal and patent RCA with no significant lesions. So from now, we would like to hear some of the comments from our chairmen and panelists about the strategy and what should we do with the case. Thank you very much.
Thank you, Dr. Phạm Nhật Minh. I want to I want to listen the opinion of the Dr. Raymond Phấn from Hong Kong. Yes.
Hello. Well, for me, it looks like bifurcation lesion, of course, and also I wonder whether how should we treat this so-called side branch lesion? Looks like the side branch is quite big and the lesion is long. So, so my question is whether it's good we put absorbable scaffold over as a bifurcation lesion, which it seems to be a bit difficult. I mean, we don't have that much data on this. So another option, of course, is to use the DCB and a combination of FreeSoft and DCB. That's another option. I don't know whether what other panelists think about.
I think what I'll do is looking at the bifurcation, they are all big diameters. I will perhaps do a pre-dilatation, maybe test it out with also an NC, and then see if there's a lot of dissections, and we take it from there. Perhaps we can still, we don't jail the side branch too much. We can still go with a single stent FreeSoft. Of course, it is not indicated yet, but sometimes having a slightly gel side branch, if you can get away with a good flow, eventually the stent goes away and it's a bit more forgiving. So in that sense, I have a bit more comfort, but the size is a little bit big. So perhaps it's a 354 millimeter on the main branch. So I will take that into consideration as well.
Professor Lu, about your opinion?
For me, it looks like a huge LAD, but I just wondering if you use the RMS to coverage the diagonal. So the diagonal looks big, greater than 2.0, maybe, yeah. When you do that, I really don't have any data regarding the bifurcation when you use the RMS.
Thank you. How about Professor Lu? Dr. Hoàng Văn. Okay.
Here I agree with you, my chairman and panelists. I see here with the true bifurcation here. First I think I use IVERS first and defines the region characteristics. If and after that maybe I think I stand use provenance stand, and after that I use DCB inside brands. It's my strategies.
Okay. This is typically bifurcation nation without severe classification. First, I think the branch protection is very important. Second, I would use IVERS to guide the strategy. If the plaque is predominant fibrous, DCB strategy maybe could be considered. If IVERS shows the attenuated plaque pattern, I would favor the LAD stenting. If LAD stent is needed, I would consider balloon preparation if the of the diaglow. DCB treatment of the branch may be suitable. This is my opinion. Thank you.
Yeah. For me, because of this is the ACS, acute coronary syndrome, and we have a slow flow in the LAD, also in the diagonal. So we need to do IVERS to see what is the lesion. The lesion have a dissection or chambers in the lesion or not. And after that, we have a plan to do DAS or DCB. So what about the plan of the operator? Dr. Wu and Dr. Min, what should you do?
So thank you for your opinion from the panelists and also the chairman. So the next step is you would like to do the IVERS. So I would like to show you the IVERS finding because we already done the IVERS finding. So this is the mình nói.
Okay, so this is the IVERS from the LAD, and we can see that we have a quite moderate lesion of the distal part of the LAD that we can see on the angio. So basically, from the beginning, we wanted to do a DCB also there if the lesion was significant, but in fact, the lesion is only about 60% of the plaque burden, and the MSA is about 3.6 mm square. So basically, we would like to treat that lesion medically. And now here we come to the lesion very near to the bifurcation. And I think that all we can appreciate that we have a very tight lesion with mix of the plaque of the a little bit of the soft plaque and the fibrous over there, and we also from the finding from the LAD IVERS, we can see that the ostium of the diagonal is very tight, and the one thing that we really quite hesitate to use the RMS in the case is that the proximal part of the lesion is quite big. It's about 3.9 to 4 mm, and we have some plaque over there also. Can you show us the IVERS of the diagonal? IVERS number 3, please. So this is the IVERS from the diagonal, and I think that all we have some negative remodeling over here with this vessel size is about 3.0, and here is about 3.5 to 3.75, and we have a very tight lesion very near to the ostium. From here we can see that mostly we have the soft plaque with the fibrous, not so many calcification, and here is the LAD. So actually for the plan, we have already prepared with the 7 French guiding catheter from the right radial, and all we are prepared for the bifurcation stenting if we have. But after the IVERS analysis, I think that we still stick to the initial plan of the very high pressure or the cutting or modified balloon from the diagonal, and we are going to do a hybrid approach of the DCB of the diagonal and then the IMS for the LD lesion. And that is the plan of the team here with Dr. Wu as the main operator. And then now from now on, we would like to hear some other comment of the panelists and chairman about after we have the IVERS findings.
Yes. Thank you,
Can you show
Dr.
the
Phạm Nhật Minh. Yeah. Okay, Dr. Raymond Fan, do you agree with the operator about the IVERS, the result?
I think from the IFA examination, it's good that at least the lesion is not very calcified, mostly fibrotic, it's soft plaque, and which is quite suitable for this kind of DCB or even the free-solve kind of stent. I mean, yes, absorbable stent. I mean, but I'm not about the size. It looks like the LED is quite big. What do you think, other panelists?
Just to add on that the limitation of the free solve is 4.5. Yeah, so I would also take that in consideration. So the IVERS gives a lot of information for us to prepare for that.
Yeah, I think because right now in China, we're going to start to use the IMS. We don't have a lot of experience. If you just go ahead DES, that's quite simple. Just go ahead, stand the LAD, and then see what happened for the diagonal. Maybe the diagonal is a very good response to the balloon dilation. Maybe you just DCB something like that and finish up the whole procedure. But for the IMS, maybe there's a little bit different story when you do that. So yeah, I just want to hear you guys' opinion for that.
And Dr. Chu San Kyung, yeah, from Malaysia.
And in my opinion, I have this quite early experience of RMS, but I think LD is very big. The biggest RMS is size about 4.0 millimeter. So I think more expansion to 4.5 millimeter. And I also wonder about the bailout strategy if dissection occurred. What will the operator do in such case with RMS? Yes.
Dr. Hoàng Văn, you want to put the RMS in the LAD or not?
I think after in IVERS cells, I don't think I am in the LED. I think it's short, it's a mid plug, and this plug in the I think in the LED it's okay. It's suitable for hybrid this strategy. Main in the main brand is stand and the side brand is this. Can you see?
I think a stent would be needed in the LAD. But if we considered implanting mechanism-based BRS in the AD, pre-treatment of the diagonal is critical, and effort should be made to prevent the branch occlusion. Thank you.
Thank you. So in the IVERS, we found that the diameter of the LAD is very big, nearly 5 mm diameter. So Prison RMS not have this size. So I think this simple. I agree with you to do a DES in the mind frame and maybe DCB for the diagonal. How about the operator? What should you do?
Yeah, so thank you, Chairman. Yeah, thank you, Chairman and panelists. So our team have I think it's not small discussion, but a big discussion, what to do for the patient. So because the lesion in the bifurcation is not so tight, it's not so much calcium, and we think about the little thing behind in this patient. So our plan is that we will prepare the lesion in the both membrane and side brain with the scoring balloon and cutting balloon. After lesion preparation, we can see what we have and we choose the strategy for this patient. But our team wish that we can have enough optimal lesion preparation for the diagonal, and we choose the DCB for diagonal first, and after that we choose the bioresorbable scaffold for the LED. And about the LED, we have the LED after the diagonal is about 3.5, and before the LED, before the diagonal, the lumen diameter is about 4.0, but the vessel is about 4.5 or even more. So that is the check point that if we think about the scaffold, we have to put the 3.5 scaffold for the LED, and in the proximal we have to do a POT, the 4.0 balloon to make it make the scaffold full expansion and opposed to the plaque. So that's our plan for this case. So now we use because
Dr. Vũ, vision or magma risk, etc. It means that RMS, the indication for bifurcation is not clear because we don't have the study about the RMS for the bifurcation. What do you think about my opinion?
Yeah, absolutely right. By the IFU and also from the company, and we avoid using the bioresorbable scaffold in the bifurcation, the true bifurcation, that the bifurcation will have the big side brain and significant stenosis like this. So I think this is a point. So, but I think this is the borderline case, borderline case to do, not to do. And I think after everything would be the final decision will be choose after the lesion variation first. After we do the lesion variation, and I think the final decision will ask all of chairman and panelists and also the attendant in the audience. Yeah.
I agree with you. It means that after preparation, careful preparation, and we decide to do DCB or DES or scaffold. Yeah.
Okay, now we use this is the scoring balloon 275 to the diagonal. Because the diagonal we have the proximal is the negative remodeling is about 3. Usually we choose the balloon smaller, one number compared to the vessel size, with the cutting balloon and scoring balloon. So this is the 275 scoring balloon, and you can see that the lesion may be full expansion, right?
We can choose. We can choose a scoring balloon, but why you don't choose the NC balloon?
Yes, because we I don't know. It depends on the center and depends on the operator, but we think that if we use the scoring balloon or cutting balloon with we can control the dissection not too much as the NC balloon. Is our opinion, but I think the data is still controllable zone when we use a scoring balloon and cutting balloon. So how long for that?
Do you have any tip and trick when you inflate the scoring balloon?
Yeah, so this is the scoring balloon. So usually we go very slow and keep it a long time, maybe 1 minute, to and hope that the scoring of protein balloon can cut the plaque and also stable the plaque during the procedure, especially for the DCB plan. So, and also when we keep the balloon for long inflation, we can check the patient tolerance with the DCB later when we use the DCB. If the patient can still okay after 1 minute, I think it's okay for the DCB. But if the patient have some chest pain or even acceleration after 10 or 12 13 seconds or something like that, we have to consider something more. Yeah, so the patient still okay with the lung inflation. So as the patient chest pain.
Cái đó được không bác?
So another question is, when you choose the balloon size, you're thinking about the 3.0, 2.75, even 2.5. Based on the IVUS imaging, the vessel is a 3.0, right? So you just undersize a little bit and then do the lesion preparation. So what's your strategy for that?
So after the scoring balloon, if possible, we use the NC balloon 3.0 for the diagonal.
3.020, áp lực cao. Pantera Leo.
So now we use the NC balloon for diagonal 3.0 and long inflation. So what do you think about the IVUS guide DCB in daily practice? Should we check the IVUS just before and after the DCB, or during the lesion preparation we need the IVUS or not?
We should do the IVUS before the DCB. After DCB, we shouldn't do the IVUS.
So this is a 3.0. The balloon is this is 3.0 NC balloon for the diagonal, very slow. Very slow. Yes. And keep it for a long time to see. And so what if we do the DCB for the side branch and IMS for the main branch? So I think we have to do the DCB for the side branch first, right? Because with the scaffold, we cannot do the DCB second after the scaffold implantation, right? Okay, so this is the final lesion preparation for the diagonal, and now we check the angiogram to see the diagonal before we go to the LED. And okay, check that.
Do you want to check the IVUS?
Check.
Okay.
Check the angiogram. So I don't know in the daily practice with the DCB, should we check the IVUS in this step or just the angiographic like this? Yeah.
DCB.
It looks like a very good result. Yeah.
Yeah.
So you still consider to use DCB for that, or just leave it alone?
Yeah.
We have to.
Of course. Yeah. Of course, we will use the DCB for the diagonal, but what do you think if we do the lesion preparation for the LED before we use the DCB for the diagonal, or just go ahead with the DCB at this moment?
No, I think you should prepare for the LED first. After that, maybe we look IVUS, and then we decide to do this DCB in the diagonal.
Yeah, thank you. I will do exactly what you have said. Yeah. So now we choose the 3.5 cutting balloon Wolverine for the LED. just low pressure is about 6, not too much, because I think the lesion in the LED is not so tight, it's not so calcium. So it's
What
easy to
size of
crack.
the balloon?
This is 3.5. This is 2, 4, and this is 6 nominal pressure. Okay. Keep it for a long time,
It's a
please.
cutting balloon, right? Cutting balloon.
Yeah, this is cutting
cutting.
balloon. Yeah. 3.5. I'm happy if we use a 325, but I don't have a 325 here because usually we choose this one. But if you use a 3.5, maybe cutting balloon should be in nominal pressure, not too high, because if we go higher than nominal, maybe the balloon could be oversized to the vessel, and maybe we have some risk of a rupture. So it's for a long time, and okay, replace. And we back the balloon. More, please. Okay, here.
Yeah.
And slowly, and only 6. You can see you can appreciate that the lesion well prepared. But I don't know the diagonal ostium right now after cutting balloon. Sometimes it's dissection from the LED to the diagonal. Sometimes. Okay, we inflate for 30 seconds and keep it and okay down. Okay, so now we have the lesion variation for the both fibrin and membrane. So we check the angiogram and making ask all of you the final decision for this patient should do the DCB and scaffold or DCB with the DS. Yeah, I think the diagnosis is still okay. So what do you think?
Yeah, I think the preparation is very nice. We should to do IVERS.
So usually when we do for the scaffold, we check the IVERS again after cutting balloon or swallowing balloon.
Đóng hộp thuốc.
So now we try to use the cutting balloon. The DCB
yeah.
for the diagonal frame. This is 30 by 20. So how about the DCB for the side frame? Usually, how length of the DCB protrude into the main frames? What do you think of the ideal length of the DCB? Give me some ideas, some opinion about that, and we will do exactly what you say.
It means that you want to ask the opinion of the panelists about how millimeter of the DCB protrude to the LED.
I wouldn't pass it beyond the lesion. And I would like to still do an IVERS on the diagonal first. And for me, the residual stenosis could still be further optimized. I would like to do an IVERS first, but I would protrude perhaps 2 to 3 millimeters more than the where the ostium is into the LED.
Yes, so I open the DCB.
Maybe take a look at the IVERS. The DCB or the
This is DCB, 30 by 20.
DCB, okay.
So we go to, how about nominal pressure? 7. This is the Pantheralax. This is a paclitaxel.
Tô cái vỏ.
So
how about the name of the DCB?
This is
we cannot the name.
Pantheralax.
Chiều nó gần tí nha.
Yeah, Pantheralax. I don't know company, but I know the name of the DCB. Yeah, so this is the 8. We go to 10.
The length of the DCB, I think it's a cover the distal lesion and then a little bit cover the osteo of the diagonal.
So what kind of drug for the DCB?
What type of drug? Paclitaxel or sirolimus?
This is a paclitaxel.
Paclitaxel.
But we
So,
can see you have a little bit waste there, right? In the proximal of diagonal. I think that's okay.
So the balloon, the DCB in patient for 1.5 minutes already. So I would like to go stay longer, maybe 2 minutes if the patient okay and hemodynamic is okay. So the longer the better for the DCB. I think it's almost 2 minutes. So now we deflate. Okay, 2 minutes. Okay, now we go to the next step for the scaffold. So that I think the key point in this case that we have to prepare we have to get the optimal region preparation for the both sides of the LED and diagonal, and also if we put a scaffold, it should be after that we have to do the port. Maybe the port should be in a very precise position, because if the port is too much, maybe the diagonal would be compromised after the POT of the scaffold and even the DDS. So now we choose 26 30 mình chọn này.
30 cái giờ chăng?
So Dr. Min say that this is the scaffold. So after 1 year, the scaffold will be disappear. So he said that the length of the scaffold is not so important. So now he choose 3.5 by 30.
Open, please.
Please.
Open, please.
So this is the LED, right?
LD.
So this is it's quite difficult to make a final decision for this case because the bifurcation. So
You choose the stand 3.5 or 4.0? 3.5?
Yeah.
3.5 by 30.
Because in the Vietnam market, we don't have the 4.0 scaffold in Vietnam. We only have 3.5 and 3.
The market.
Don't have 4.0, right?
Yeah.
Right. Oh, you don't have 4.0? You have? Okay, sure. Okay.
In the future, we have, reason we have the 4.0.
But anyway, the maximum diameter for that is reached to 4.1, as I know. The proximal, you can use the bigger balloon.
Yeah, I think it's okay. We have some spasm of the LED, but I think it's okay. The scaffold is quite long, but I think this one is very good position for that. We have the trio. So now we go slowly. 1, 6. No, 10. We just go to 10. This is nominal and keep it for maybe 30 seconds or even 1 minute and waiting for the scaffold full strengthen, right?
Vị bằng 4.0.
Cứ một cái 3.5, 375.
Rồi cái 375 một cái 4.0.
So it's about, it's over 1 minute, right? Okay,
No,
we have to
1 minute
replace.
inflation?
Yeah, 1 minute, maybe more. It depends on the patient and the hemodynamic. If the patient not feel chest pain too much and the ST not elevation and The pressure is okay. We keep it longer, maybe 1 minute. Yeah. Yeah, this is okay.
Nên vặn lên lần nữa.
No, no need
Okay.
for that. Okay. So this is the scaffold, and so at this moment, I think the eyeball should be checked before we do the post dilatation for the patient. Okay. So I think from the IFU, from the scaffold, at this moment we have to use a 4O balloon for hold the scaffold length. So what do you
Is there
think
any-
in the you use the
Is there any reason? Yeah, is there? Can I ask? Is there any reason why the diagonal wire has been removed?
No. Excuse me.
The diagonal wire. Any particular reason that it was not placed there as a protection?
Yeah, we removed the diagonal wire before the scaffold, but I think we can keep it. In some cases, we can keep the wire in diagonal and take it back after we take the angiogram. It's okay, but in this patient, Dr. Min prefer to remove the diagonal wire. But I think you can keep the wire in the diagonal even with the scaffold implantation. Yeah.
So
Because the reason is not so calcified, so it's easy to remove the diagonal wire even after the scaffold implantation.
So in my opinion, maybe in this case, because this is a live case, so I just want to make sure that the diagonal wire, it would not be trapped in the scaffold, which may damage the proximal part of the scaffold. I think we have quite a good result over here, and maybe a little bit of better post-dilatation needed.
So what do you think about the eyeball finding?
Can you run the IVOT one more time?
So the distal there's some blood here, right? Okay, but scaffold is okay. So what do you think about the NC balloon? 4O for hold the scaffold, or 3-5 for the LD after the diagonal branch, and 4O for the POT, or what do you think about?
I think the NC balloon is, we need the NC balloon for that. And the size going to be 3.5, maybe for this two.
You can try for the distal and maybe the proximal.
Yeah,
and
proximal, maybe 4.0.
4.0.
Something like a pod technique. Yeah.
Okay. But what do you think about the NC balloon for the proximal scaffold first or distal scaffold first?
Distal. Proximal first.
Yeah, you can see the marker of the scaffold very clear, even with just the fluoro. This is a new this is innovation of the Frizzo.
Frizzo.
Because
Yeah.
yeah, because with the previous version, Mark Morris, it's not easy to see the marker of the scaffold. So right now you see even with the fluoro, not a picture, you also see the marker very clear. So go to the proximal first.
Okay.
Proximal.
Proximal is here.
Yes. Okay.
Maybe
Okay.
beyond here.
So I have to test to see
We can,
the distal. Is it?
we can pot outside the stand. It's okay.
Yeah, I think it's perfect. It's perfect because we plan to this year 4.0 by 8 NC balloon. Pandra
Leo.
Pandra Leo, right? Pandra Leo. This we go to
How long?
this is
The length of
8 millimeter. So this will go to normal 14. very slow. We go very slow and timing. And we go to according to the IFU, we have to go at least 16. And now we go to 18. And we go to 20. Yeah, this is 20.
The both
just wait.
dilatation with high pressure, 18. Yeah.
This is 20, right? Okay, just a moment, just wait and see, maybe 30 seconds, maybe more. As long as we have. This is 20. Okay. 45 seconds and 1 minute. Okay, we deflate the balloon.
You want to push this one down more? No.
I think no need for that.
Okay. So we will use 3.5.
Yeah, maybe 3.5.
3.5 maybe.
How about the IVOS fighting?
I think 3.5 is enough.
3.5. Okay. 3.5. Nó 3.5 hả? Mình cũng 3.5 hả?
Xem lại cái iVerse còn. Chạy lại cái iVerse. Cứ chờ tí. Không cần.
This is 1, 2, 3, maybe 3.5.
3.5 is it? I see.
3.5. 3.5.
A minute for the like case, and then 15 for the lecture. Okay. 15 for the and addition.
One, we think that we have to go very high pressure. Okay, let's go. Mình xuống chút xíu nữa. Cái mặt cơ nó nằm, cái tem nó nằm, cái scaffold nằm ngoài cái mặt cơ tí. Đổi lại chút xíu. Rồi. Yes.
Okay.
10, 14, 3.5, 16,
16,
18.
18.
Okay.
This is 315 NC balloon.
Yeah, by 20. Okay.
Đây. Before.
8, 10. Nominal 14.
16, 18, 20, 22, 24. So we keep the balloon inflated for at least 30 seconds.
Okay, 40 seconds. Now we deflate. Okay.
Okay.
So take a balloon
Now
out
I
and
will take the balloon out
check
and
the IVOS.
check the IVOS one more time. Can I have the IVOS?
So Mm.
Yes,
So,
5 minutes remaining.
Yeah,
Yeah.
okay. So we will just check the IVUS and finish the case.
So, usually we use IVUS or CT for the scaffold, but I think the criteria for optimal result of the IVUS, for the DES, we have the criteria already, but for the scaffold, I don't know. Maybe we apply the criteria from the DES to the scaffold in daily practice, but I think we still need the new criteria for the scaffold in the near future if we have the more patients in daily practice. So what do you think about the criteria for that?
Now we don't have a criteria for IVUS for the scaffold, but I think in the future we should have.
Yeah, I think it's okay. The scaffold were opposed to the vessel, to the plug. We have some side frame, so the scaffold cannot touch the side frame, but it's okay. So should we check the IVUS for the diagonal frames? What do you think?
No, after DCB we shouldn't do the IVUS.
Yeah. I think the final entry, that's okay. Yeah. Insert the nitrogen.
Just make
Because if you do IVUS, but I think you have to do one. Okay, yeah, I think just leave it on. Yeah, looks good.
Okay, what do you think about results?
It looks very good, right? Yeah.
Yeah.
The diagonal is a very good flow, even a little bit, maybe a little bit narrowing in the proximal. I think that's okay.
Yeah.
Yeah, that's okay. Looks like.
Okay, so maybe we end the case from here.
So congratulations, right? Okay.
All right, well done. Yeah, congratulations. Okay.
Okay.
Thank you for your
Thank you.
demonstration. Bye.
Okay.
Okay, we just finished the case leave nothing behind with the DCB in diagonal and RMS in the LAD. So I think the result very nice. Congrats to the team. Yeah. So we go to the lecture. I would like to invite Dr. Chi Tung Chen from Taiwan with the topic RMS indication and clinical update.
Thank you for a kind introduction. I'm so happy to go a pleasure to be here. I'm Dr. Chen, interventional cardiologist from Taiwan. Today, I would like to introduce about the RMS indication and clinical updates from biosoluble concept to clinical practice, and also our own early experience in our hospital. Okay, let's start with a case. This is a 34 years old female, and she had hypertension, hyperlipidemia without regular control before, and also have strong family about CAD. And now she have suffered from exertional chest tightness for days. So I arranged further examination for her. And we clearly to see the de novo lesion over RCA, 2 lesion in RCA. And the vessel size is about 4.0 millimeter
no heavy calcification. And you guys choose DES, DCB, or RMS. And in honest, it's very simple case in our daily treatment. Maybe we can use DES and work perfectly. But she is only 34 years old and will live with our treatment, the permanent vessel, over 40 or 50 years. So let's talk about RMS. And the first beginning ideas come from 1990s, and the polymeric, the first polymeric tell us it could disappear, but not very well. And the limitation is about the thick struts and not resorption very well, and the scaffold thrombosis. So the mechanism tells a different pathway, from the drains first Mach and the two Mach Marys now to freeze-off. I think it's maybe a thinner strut and easier to deliver and more predictable because it can resolve within 12 months. So we can see it's more thinner, about 99 microgram to 140 microgram, and it can stronger over 3 months radial support, and we can more predictable because we can predict it's resolvable within 1 year, and restorative for vessels. Leave nothing behind later. So why are we interested about RMS? Actually is very simple because the first one we can support the temporary vessel support and provide scaffolding during vessel healing, and then almost 99 magnesium resolved within 12 months. And the final goal is leave nothing behind. But the concept is good. We have to some clinical evidence. So there was the first in human study, BioMech-1. In the BioMech-1 trial, we can see in the first year, only 2.6 target lesion failure. And 3 years later, only 3.5% target lesion failure. And most important, there was no cardiac death, nor no target vessel MI, and also no scaphoid thrombosis. So BioMech-1 enrolled 160%, and we can see the long-term safety and efficacy. And in this year, EuroPCR revealed 4-year clinical outcome. We can see the target lesion failure still have 3.5%, and there is still no cardiac death, target vessel MI, or scaphoid thrombosis. So the event remains flat. So it tells us the late catch-up, no late catch-up in our 4-year observation. But it's not good enough because it's, the sample size is very small. So the last previous generation Megamaris had large-scale clinical practice. And we can see 2-year clinical outcome in the select patient. We can see it's feasible because the 97 device succeed in procedure. And we can see 2 years outcome, only 0.8 scaphoid thrombosis. And so it could current safety and efficacy. What's important is technique still matter because almost 100% have pre-dilatation and 95% had post-dilatation. So optimal lesion preparation is very important. And we pending another trial. Because BioMech-1 tell us freeze-off look promising and safety,
But we still did not answer, is freeze-off good enough to compete with the DES? So we pending a BioMac-2 study. It's a prospective international multi-center, randomized and open-label, non-inferiority RCT to compare with the freeze-off to science DES. And we will look for it after. Okay, still another ongoing study is biohybrid pilot study. So we also pending this because we think about a different question, because the long lesion, we avoid full metal jackets. So we think we consider the hybrid strategy. Maybe use the RMS with DCB. And then the real question is, who should receive the RMS? I think technique determine the indication. And we have to strict adherence to the 4P implementation strategy. First one, patient selection. I think de novo lesion, a reference vessel about 2.5 to 4.0 millimeter, and the low to moderate complexity, and good distal runoff. 2, the proper sizing. The expert recommendation to use the IVI to sizing, and good pre-dilatation and post-dilatation. It's a 4P implementation strategy. So I think selection first and implementation second. Okay, the RMS 3 points is right patient, right lesion. As I said, younger people, long life expectancy, and avoid permanent metal cage. Okay. And also the right lesion. Okay, we choose de novo lesion and suitable vessel size, and not so very long lesion and low calcification lesion. Okay, let's back to our my case. Okay. Sorry. We can see it's about the in IVAS we can see it's about 4.0, and long lesion I choose to cover to freeze-off stent and post-dilation with NC Conquer 4.0. And in my this case, another important is H2H implementation, because we avoid overlapping, not like a DES, because much more overlapping increase metal burden and delay resorption. So the recommendation also tell us to H2H implementation. Okay, so we just see the titanium marker and H2H deploy. Okay, but I think in this case, other doctor will say we can consider other hybrid strategy, maybe DCBs or DS with DCB. Okay, the angiography result and IVAS result I think is quite good. Okay. How does it perform in daily practice? It's only one case. I just want to share my experience, our first 23 consecutive case in our hospital. Okay, my hospital first introduced freeze-off from December 2025 December, and I just analysis the within 7 months and 23 consecutive case in our hospital. We can see a relative young patient, about 59 years old, and supporting the RS concept, leave nothing behind. And okay, the patient with no longer with the longer life expectancy, and we can see the hypertension, diabetes, and this hyperlipidemia, high burden of the traditional cardiovascular risk. About more than 70% have the hypertension and the hyperlipidemia, and only 30% have the diabetes, similar to BioMac-1 patient characteristics. And I'm very conservative, so on a very low ACS portion, only one patient have non-STEMI. So I think I choose a conservative approach to careful patient selection. Okay, let's see the procedure and lesion characteristics. Okay, first, most lesion is LAD because I think it's more straight and the sizing is good, and followed by RCA. Okay, just like the other RMS registry, and which I choose appropriate vessel size and the relative straight vessel, so it's better for device to deliver. And I choose the conservative lesion selection. Okay, most over 57 classified ACCHA type A or B1 lesion. Okay, most important is 100% image guide implantation. Okay, the last, I just want to tell you guys a full message. First one is the right patient choose. Okay, young patient and de novo lesion. Okay, to avoid permanent metal stents, and right lesion, appropriate vessel size, not so complication, not so very calcified lesion. Okay, and the third one is to right technique. Always use the IVI and predilation and post-dilatation. And the last one, we can see in the previous study, we can see encouraging safety and feasibility in freeze-off, but still lack of large RCT or large-scale clinical trials to tell us the further story. I think the future may not be DS versus RMS versus DCB. I think the future is to choosing the right technology for each part of vessel. Thank you very much. Thank you.
Thank you, Dr. Chi Tung Chen. I think from 4P principle, we have a conclusion with 4R, right patient, right lesion, right technique, and right expectation. Thank you. And then we go to the second presentation. I would like to invite Dr. Phan Tuấn Đạt from Vietnam with the topic, the future of intervention, integrating resolvable technology and the DCB for a liver knotting reality.
So, good afternoon, Professor Chairman and panelists and all the audience. I'm very honored to be here today to present my topic about the future of intervention, integrating resolvable technology and DCB for leave nothing behind reality, DCB or the RMS. So, firstly, I would like to say that why the leave nothing behind still matters, because we all know that we have a lot of advances in stent technology, and but we know that the permanent implant never stops generating the MACE for the patient. The target lesion revascularization is about the 1% per year, and also definite stent thrombosis is still here. It's a 0.2% per year. So I want to give example that the 55 years old male patient you treat today, we carry about the hedges for the 30 years. This is the problem why the DCB and MRS exist to solve that problem. And I just want to tell what about the drug-coated balloon? Because we all know that all the meeting, all the conference tell us a lot about the DCB recent years. But what is the advantage and disadvantage of DCB? Because DCB have a lot of advantage, we cannot deny that. First one, that nothing left behind, no cake, so no for the late even, and DCB can preserve the vasal motion for the patient and positive remodeling the possibility, and we untouch the side branches, so it's perfect to do the side branch technique, and also that we have the shorter diabetes. I think one is the advantage of the DCB, but still there, we have a lot of data. We found the agent idea, we basket small for the small vessel for the DCB, solution, and also the red cake free, because we have the We have a lot of trial, but the result is not the same. We have the positive result like the DCB with the in Asian idea or the solution, but we have the negative result on the red cake free. So the DCB is still here, but not for everyone and not for every patient. Because DCB also has some disadvantage. I can show here that elastic recoil, because it's no scaffold to hold again the vessel. So in time to time, elastic recoil is the main problem for the DCB. And also, if you preparation for the lesion is quite good, sometimes you use a very big balloon, you make some you will make some dissection. Yeah, for the dissection after we aggressive preparation is the main problem. We have to change the strategy from DCB to DS or MRS for that situation. And also, it's no the scaffold here, so no mechanical support, and we always very considering for the DCB for especially for the proximal or high stress segment or to do the patient. And we unpredictable occur again and fail and modify the calcium is the most disadvantage of the DCB. So moving on, now we have the resolvable magnesium scaffold, and this one the stand have a lot of advantage. Yeah, I can tell here that from the beginning, from the absorbable, the stand strut is quite big, but till now the free sole you have the thinner stand strut, and also we have the resolvable after the years, and we also have the biomark data behind the preserve. I think that it is a perfect trial because zero cardiac death, zero target visual MI, and zero scaffold thrombosis. So all the data support that MIS is a good choice. Yeah. So the advantage of MIS now, we still have the real radial support, especially that we have to seal the dissection after the pre-dilatation. We have the predictable acute result. You can see the Q result. You can see that about the TB flow after we deploy the stent, and we scaffold long lesion that the balloon alone cannot hold, and we bite down, disappear, rather than permanent stent. So this one, I think that the most advantage of the MRS, yeah. But we always have the two sides of the coin. What about the disadvantage of MRS? We have to choose the lesion very carefully because you have to narrow lesion window. We just only to do the big vessel, non-calcium lesion and non-ostium lesion. That's why you have to prepare and you have to choose the lesion very carefully and not for small distal vessel below the 2.5 mm and gel the side brain like any scaffold, and the long lesion need 2 or 3 devices. So you have to know that we cannot overlap. So the technique very precisely when you want to do the two stent or you want to combine between stent and DES, and unsuitable for some situation like the thrombus, the latent STEMI, left main, severe calcium, you have to be very careful. So that's why the DCB and MIS still have advantage and also disadvantage. And what about the combination? Why I say that it is the perfect combination? Because we can combining DCB and MIS also, we have a lot of advantage. I can show you here that the scaffold only where the support is needed, especially for the proximal lesion, drug only where the drug is enough. We can use the long and diffuse lesion and neither leaves permanent with the metals. So what about when we combine this one, what we have to concerning about that? The first one, baseline lesion, you have to lesion preparation perfectly, and we can relook at the lesion with the IVUS or OCT. And after the pre-dilatation patient, you have to look at the vessel very carefully and to categorize what about the phenotype of the lesion. If the lesion is very stable, good lumen, TB3 flow, no significant recoil, you can choose the DCB alone. But if the lesion needs the mechanical support, like elastic recoil dissection, you have to use the MIS, the fissure only. But your lesion has a mixed vessel, very long, diffuse lesion, bifurcation, CTO, and one vision and two problems. You have to use the hybrid approach for that patient. So my slogan is do not choose the device first. You have to prepare first, and you risk the vessel respond about that. So what about the three combination I will told you here? It's the strategy is that for the long lesion. So with the proximal, you need to scaffold support proximally So this one, the optimally you can use the pre-sol for the proximal one. But the mid distal, you avoid the metal jacket. For the mid or distal, you can use the DCB for the good result because the drug delivery distally and no full metal jacket. I mean, so for that case, thanks to the teleflex, they give me the presentation from Dr. Stefano. So I have some case to share with you. The first one is the case of hybrid MIS result, the plus DCB on that case. This one is a 71 young male patient, and you can see that he has the 3 vessel disease. And when we look at the left coronary vessel, you can see that a lot of disease here. But the proximal LAD, proximal SUF, and distal SUF also, and OM also. So when you play this one, we choose the stand for the very proximal one, for proximal LAD, proximal SUF, and OM also. And we choose the DCB for the distal SUF for that case, because after we have the using IVR, the OCT and interventionist decided to do the hybrid approach for that case. So this one, use the preserve 3.5 by 22 mm for the LET, and for the OM, you choose the 3.0 by 13 mm, and use the sirolimus DCB for the distal SUF, and this one that the post preserve for the proximal LC. So this one, the final result. So I don't know how the video cannot play. So for the long lesion, use the proximal for the preserve, and you meet and distal DCB that for, because the scaffold support proximally, as I said above. So you drug delivery distally for the patient and useful for the long diffuse lesion, and to know the metal jacket here on that situation. What about the second situation that we can bite out after the DCB failure? For this one, I can give you an example. The reason with the PCB, and you can see that it's quite very long and diffuse LED, and initially we can use the balloon dilatation and use DCB to form the distal LED to the proximal LED. But after we use the DCB, you can see that there are some dissection of the distal LED. Often on that case, we have to choose the MIS here to bite out, because we have a lot of dissection in the mid LED here, so we cannot leave the lesion alone, and that's one where the MIS is working to bite out for the situation when the DCB make a dissection at the distal part of the LED. So for the bite out situation that we have to rescue after the suboptimal DCB result, when we make some recoil or we make some dissection, we can restoring the lumen and vessel stability and keep a no permanent metal strategy, because all the stand will resolve after the years. So lastly, I will tell you about the strategy 3, when you can use the MIS and DCB also for the bifurcation lesion. With the bifurcation lesion, that we can choose the MIS for the proximal main vessels. Nothing in the side brain now, especially for the carina. For carina, is very important that if you make the carina is not open or the overlap on carina, it will make the stand is very soon. So nothing in the side brain. We support only the proximally, that one such scaffold instead of the provisional or two stand, the stand truss. The problem here that carina is free again once the scaffold has resolved. So every option keep open. So I will show you it's a K illustration that we can proper lesion preparation, and then this one is the sub lesion we involving about the distal sub and OM side brain also. So from that one that we only deploy the MIS at the proximal sub, and we DCB in the both branches, main and side brain also. And this one, the final result is a proper lesion preparation. We keep only the preserve at the proximal sub only 3.5 by 13 mm, and then we keep the kissing the balloon for DCB for the OM and the distal the sub also. And this one is the final result. It's quite acceptable for the hybrid lesion. So with the hybrid approach for fabrication, we can choose as technique to that one. This one here is my summarize. So you do not choose the device first. The first lead that you have to prepare perfectly. Then we read the value response. You have to preparation very, very, very good. and we look at if the patient is very stable, we can choose the ECB. We need support needed version with the MRS or preserve, and if the mixed version, we have the hybrid MF or DCB on that case. So what about the diagnosis? The first one, the DCB and MRS, fail to opposite reason. DCB and MRS also have the some advantage, and this combination is perfectly because each one covers that other cannot. The scaffold only when the support is needed, a drug whenever drug is enough, and we stop choosing a device first. We just only prepare the lesion and then reach the post-preparation phenotype of the patient and three particle part. The example here can cover multiple areas, like with long lesion, after the viral, after DCB failure, or we can use for the bifurcation and leave nothing behind. The strategy is not a slogan. The method line often truly matter-free, and the result is achievable today and in selected patient and unsure the river physiology can prove it. So lastly, my slogan that do not choose the device first, prepare the version first, then let the version choose. Thank you so much for your attention.
Thank you so much. That's a great presentation. So right now we open up for the discussion. So yeah, 15 minutes. We have a very good demonstration and the two topics. I believe the keyword probably is hybrid, I think. So first question I raised for the first presentation is you just regarding during the 2 years follow-up, there's 0.8% of the patient have a thrombosis. So do you have any further detail regarding this information? The key point is I want to know right after 1 year, how many patients got a thrombosis? Yeah.
So you still tell the previous BioSoft 4 study or BioMag 1 study, but in the BioSoft 4 study is previous generation McMurray study. So the study show 2 years result is 0.5 scaphoid thrombosis. 1 year's data, I don't remember the 1 year data about this. Sorry.
We just thinking about the neointimal coverage right after the RMS. So normally it's 1 year done, right? It's
Yes,
fully
yes,
coverage.
yes.
Should not be any thrombosis.
Yes, yes.
If it happen, probably another issue cause that. So that's my thinking, right? Any questions?
Just my experience, I think when the early newcomers to this technology, I think they tend to treat this as a stent, a metal stent rather than a DCB. So I think the few fallacies or the few common mistakes is just know that it is bulky. That's my learning experience, just sharing. And it will not go through the conventional 6 French extension catheters, Guide Plus, Guideliners. And when you size and especially you post dilate, I tend to go a quarter size up if the size allows because of the slightly reduced radial strength. And I'm also excited about the future indications, and I'm glad they showcase a bifurcation case. I know it's not indicated for osteo lesions, but I think it's more a forgiving stent. And I've got a personal experience where I lost the stent in the aorta, and I was not too stressed about it. So that's my personal experience.
Dr. Triết and Trung Chen, when we use RMS pre-zone for the patient, how long we use DAPT for the patient?
The recommendation is at least 6 months DAPT. And in the registry, about almost 98% have the DAPT over 6 months. And 1 year DAPT is about 74% with the DAPT for 1 year. Yes, I think just a recommendation. Just depend on the patient's characteristic, like a high bleeding risk or what. But I think most patients receive the RMS is younger patient, and most patients will tolerate a longer DAP to use.
Do you have some experience with when we do the two RMS? It means that overlap something, or we not do overlap the RMS?
Sorry, pardon.
Yeah, when we need to put two RMS, how can we avoid the overlap between two RMS?
Because too much, not like a DES, minor overlapping, but I think RMS the recommendation age to age implantation, because too much magnesium overlapping, we don't know the resorption. The too much metal burden of magnesium. So we don't know how long time the magnesium will resorption, and too much metal burden of the vessel. I think so. The free soft recommendation is to age implantation. And in my case, because I think the long lesion, but the size is consistently from proximal to distal, so I choose the two RMS implantation. Yes.
You can actually do a proximal to distal if it allows. Then you can actually size the length accurately.
Dr. Chen, I have a question regarding the RMS. So what do you think about this new generation RMS compared with previous one? And the second question is, do you have anything you find it challenging when you use this do you have any challenging lesion that you think we need to overcome when we first use this kind of RMS?
I'm so lucky in my 23 consecutive case. I have no complication of this. So I think other doctor can help me to answer this question. And first, I think new generation of the free soft is better because it's thinner struts and more longer radial force than compared to the McMurray's. And much more predictable because the bench test tell us the over 99% of magnesium will resolvable within 1 year. So it's more predictable.
Continuing maybe the same questions, you just show us two RMS together, right? And the touchdown segment should be a band there. So when we do that, always have a not even between the inner curve and the outer curve. So if you really want to chase the optimal result, what can you do? Is maybe the inner curve a little bit overlap and the outer curve got better coverage, something like that.
It's very good question, but I think I choose the landing zone, the overlapping size more straight vessel. I avoid to bench a vessel to overlapping. Thank you.
Is any long-term result? Maybe you can give us some information.
Yes, I think because I have these 23 cases only within 7 months. Maybe I will follow up like a biomech 1 year or 2 years to follow up the angiography, maybe or MDCT or what. Yes.
Okay, thank you.
Dr. Chen, I have one last question. How about the severe calcification lesion? After use the shockwave or rota, can we use the RMS?
Technically can, but most registry or study exclude the heavy calcification lesion. But I think maybe some case report can tell us successful case. But in my opinion, I just follow by the recommendation, choose the much simple lesion and just not so very calcified lesion. But I think technically can, because we have the well lesion preparation, I think the magnesium also, if well expansion, I think the magnesium also offer the good support and result good, I think.
Yeah, well, we got another question is we know that a lot of time when we see the coronary vessel, they have vessel motion and also but bending when they have like RCA, right?
Right.
So if you have just have a lesion over there, so if we use the RMS there, it will be increase the risk of bending. Will it be better if you just use the DCB? So that's the question maybe for both speakers. Would it be better to do the DCB and or in combination? How would you treat this kind of dynamic changes? If a lesion just happen in the at the joint point where there's any motion, posture motion, especially in the RCA, you have the or LAD. Sometimes it's a mid LAD. When you look at it from one angle, you have a bending and the heart contract, right? So that kind of lesion usually is bad treated without stent, I would guess, because sometimes you have a lot of torsion or twisting. It can increase the risk of restenosis. I don't know whether it's better to use RMS that will resolve after 1 year or use a DCB just even without metal. Which one is better? I mean, in this kind of lesions.
Yeah, so I think it's a very tough question. Actually, that we don't have enough experience about all the lesion. So now that based on the company guideline that we should use that is quite very carefully lesion, very straight lesion, not consumed. But I think that because based on the characteristic of the stent thread is 110 mm. So just micro mm. So just stronger than another stent, conventional stent, like the O0 also, that's only that 18 mm. So I think that the radial strength somewhere, I think it's better than conventional stent. Do you think so? So I think that we can use that one. Yeah. And for up to 1 year, the stent was resolvable and the vessel motion, it restore. So this one, I think that, but we should have the data about that. Yeah, that's my thinking about that. What about the characteristic of the stent? Yeah, I think we need the data to show your answers.
For this issue, probably we need maybe animal model to dynamic bending. You mean sometimes I faced this problem before. You use the balloon and then maybe DCB, but what can you do right after the ballooning? Pre-dilation and then get dissection. So it's no choice. You have to put the stent there.
Sometimes it's make the procedural aneurysms. So sometimes it's very hard to find the length of the stent, and the stent will the shortening when you deploy the stent. So the reason why you do the very tortuous lesion, you have to be careful about that.
Right. Good. Yeah.
That's not only one. I think there are several other type like the bridging, because sometimes I find there's a lesion just proximal to the bridging, and this is very difficult to treat. If we use the conventional stent, it will cause a lot of restenosis, and sometimes if the patient has symptoms, we need to do that. And I have been struggle which type of stent should I use, or just do the DCB. That's one type, and also the osteo circumflex is another weak point when we do the 001 bifurcation of the circumflex, osteo circumflex, because that's the point that if you ask people, they think is the bending occur when the heart contract, and this is not a very good site to do the stenting. A lot of time when you do the two-stent technique, this is a point where the restenosis occur at osteo circumflex. So people also thinking whether it's the best place to put a conventional stent in, and whether we should put a DCB or even RMS. I don't know.
My gut feeling is it's just a gut feeling. I think it's a bit more forgiving I think if you have a dissections over where there's myocardial bridging, and as I've said again, and I've actually used it before in osteal lesions. No, not in dissections, in long dissections, yes, but no myocardial bridging. But I would think that it's a bit more forgiving, and because the stent disappears, the stent resolves. So I think you're there to just patch up the dissections. If I am in that situation, I would deploy the RMS rather than the metal stent. Yeah. Yeah.
Questions? So, no more? Okay, I think it's time to close this section. First of all, thank you very much to arrange this great section for the IMS maybe. And this session, there's a very good demonstration and the two fantastic topic. So the key message probably is the maybe hybrid I just mentioned. Yeah, so never treat the vessel, maybe use any device before the good preparation. That's a key what we learned. So another thing is probably in terms of the IMS, we need more data, more evidence to guide us practice eventually. Hopefully next year we got more data to do better PCI. Okay, and thank you the panelists and the operators and the presenters. Thank you so much.
Ladies and gentlemen, so thank you the moderators, panelists, and the speakers of the session number 4. Now we will move on to the session number 5, combined scaffold and DCB PCI treatment in specific setting. So may I introduce the moderators, Dr. Nguyễn Quốc Thái and Dr. Wasan Udayashalam. May I introduce the panelists, Professor Chang E. Chang, Dr. Hafiz Abhadi, Dr. Bùi Long, Associate Professor Huỳnh Văn Thưởng, Dr. Hồ Văn Phước, and also the speakers, Dr. Abdul Arif bin Shara Saparudin, Dr. Vincent Kwok, and Dr. Vũ Hoàng Vũ. Please be on the stage to lead the session. Thank you very much.
Good afternoon, everybody. It's the last session that we will talk about the combined scaffold and DCB PCR treatment in a specific setting. Let me introduce the moderator. I'm Dr. Thảo from Vietnam National Hospital, and Dr. Wasan from Thailand, and Professor Chiang Ai Chiang from Taiwan, and Dr. Hadi from Malaysia, Dr. Bulong from Friendship Hospital in Vietnam, and Associate Professor Huỳnh Văn Thưởng from Khánh Hòa General Hospital, and Dr. Hồ Văn Phước from Da Nang Hospital. And now I would like to present the first speaker, the Dr. Abdul Arif bin Saparudin, talk about why we need magnesium scaffold technology for today.
Thank you very much, Mr. Chairperson, for your kind introduction. Hello and a very good afternoon. So, why we need magnesium scaffold technology for today? Is this a practical, is this a legit question? So we live in an era where drug-eluting stent has been doing so good, drug-coated balloon has been doing so well, and in fact is catching up, and we have a bioadapter who has come up with a good RCT result. So the question, whether it is really practical for us to actually use magnesium. So basically the topic today that's been given to me, I want to compare in that kind of lesion in which we can put a DCB in, why I ended up putting a magnesium scaffold. So the question goes to the problem with the stent. So the stent gives you a good cosmetic, good satisfaction upon putting in, but it doesn't solve the problem after that, because the moment you put your stent in, the patient is committed with the metal for the rest of their life. So it doesn't come now, it comes 15, 20 years later. So you know very well, 2 to 4% from them to actually get the history of ISR as the years goes by. And even having said that also, if you notice in your practice, perhaps maybe around 30 to 40% that comes to you came with the ISR from the stent that has been put many, many years ago. And this kind of commitment is something that we have to actually bear in mind. So the moment you decide to actually put your stent in, there goes the natural physiology of the vessel. You lost the vessel motion, and then if there is presence of a side branch, you will actually lose potentially the side branch. And of course, when you have a stent, not only that you have incidence of new atherosclerosis within the vessel, but also within the stent. So whatever it is that you think that will save the vessel now might not be the same as what can actually save the vessel and the patient in the 20 years time. So this comes the idea of leave nothing behind. So why now and why not the polymer? So if you notice, compared to the 20 years ago, the patient that comes to us actually tend to be a bit younger. Okay, we tend to actually get, when we first started our practice, those patients who came with STEMI, ACS at the age of 60s, but now they came at a much younger age, at 40s, at 30s. So if you put a stents now, in 20 years time, they will come back and that probably will haunt you. The restenosis as well as that. But in terms of the bleeding also, we has come to a point that we want to actually make sure that the patient is on a shorter DAPT. So whatever it takes to actually put a patient on the shorter DAPT, you want to actually do that, DCB. And then we have a lot of trials involving the DAPT for the short DAPT. So we want to actually put the commitment of metal away, and the vessel will be needed again. This kind of vessel, you want them to actually be amenable for PCI in the future, be amenable for graft in the future. If you put a stent there, and then the surgeon will be questioning you, where would I put my Lima graft? Where would I put my SVG graft? So there goes the chance for the patient to actually go for the CABG. And we have a robust technology now. Okay, OCT, IVUS, we have all the calcium modification equipment. So we have the liberty of preparing the lesion very, very well. So for that reason, actually we do the justice to the vessel, and hence whether we can put a DCB there or put the RMS there. And of course, without the metal there, we can follow them up with the CT scan. Okay, of course, now with the photon counting CT, you tend to actually get a better resolution. But in a normal CT, with the stand there, whether you like it or not, the blooming artifact is something that's very, very disturbing. So when you look at the magnesium RMS, what is so special about it? So compared to the DS, actually it comes hand in hand in terms of the strength, okay? So it provides more or less the same metallic strength like the DS. But the good thing about it is that at 6 months, it starts to degrade, and it degrades slowly. Okay, it degrades slowly. It is not brittle. Okay, it degrades very slowly. It doesn't fracture, and by the end of 12 months, you can see that 99% is no longer there. And not only that, it has a good 4-year data. And if you compare with the usual PLLA, okay, you might remember the history of absorb. Okay, it has been a long journey for the polymer, which started around maybe 20, 30 years ago. But this long journey has not been straightforward either. Okay, because of what? Because polymer, it is weak. So in order for it to actually compensate the weakness, it has to make it a bit thicker. What happens is, let's say you make the strap thicker, the protrusion into the vessel, the risk of the ISR, the incidence of jailing the side branch, all that. And not only that, it tends to actually got reabsorbed a bit longer, 2 to 3 years. So you have to bear with it. For the 2 to 3 years of that period, you get the same incidence of ISR compared to the DS. So that is the drawback of the polymeric BS. And of course, the future, which is iron, something that I'm not talking about a bit more later. Of course, in terms of the strength, which is the better. Okay, but this technology is not yet tested. Of course, you can put the 70 micron there and then it can provide you with the same strength, but it's not yet defined in the humans. This is 20, 30 years from now, from now kind of technology. All right. So at present, when you are talking about the RMS, so what is the position of the freeze-off in my daily practice? Just a bit of interruption, a bit of overlapping also with the previous speaker. So this is the 3rd generation RMS, the second, which is the big brother, the Magmaris. So the drug is sirolimus. So the best part about the freeze-off is I like the 2 tantalum marker, which is easier for us to actually see where we put. Okay, it tends to be invisible before this with the Magmaris, but the freeze-off is so much easier. And then it comes in the multiple preparation and length. And you can see that even in terms of the strut thickness also, it is much, much thinner compared to the usual polymer. And the scaffold lasts for 6 months, degrade after 12 months, and there are few various lengths. So, Biomac 1, this is not an RCT, but it is a good start because it compares with the Magmaris and it tells that actually after 12 months, there is no TLF event. So this is the part that is very important because at the beginning of the 12 months, this is where the magnesium started to actually resolve. So when you go with the usual DES, it tends to actually go up because of the risk of ISR goes further after you implant it. But the moment the magnesium is no longer there, the scaffold is no longer there, you don't see any TLF. It plateau. So this is the benefit that you want to offer for your patient. And of course, Biomac 1, which is the non-RCT, but we are highly anticipating Biomac 2, okay, which is the landmark trial comparing between the Resolve, the Zions, and they're looking at the TLF. So this is the trial that we anticipated, that we hope that's going to get a good positive result that will change the way we practice our coronary intervention. Of course, Biomac 3 is something that has been done a much more bigger population to actually cater the population of United States. So DES is still a workhorse. Whether you like it or not, it's your bread and butter. You go back to your centers, 90% perhaps of the time you put the DES in. DCB is a good option for someone with a small vessel, ISR, perhaps bifurcation or side branches. It's a good thing to put in DCB. So where usually I put my freeze-off in, those patients with a focal de novo lesion, those patients that I can afford to actually put only one scaffold, those patients who are young, that will outlive the metal, okay, that will outlive the stand. Usually you quote the patient to have, ISR in 10 or 15 years time, the longevity. So those who actually live longer than that, those young people, those are the ones that you want to actually consider Freesolve, and the one that you don't want to actually put the metal behind. As I said, young patient, de novo focal, straightforward, type A, type B1 lesion, and those vessels that likely to be needed again. Those patients, for example, diabetes, strong family history, those patients that comes to you with accelerated atherosclerosis, that if let's say you put the stent there, it might come and bite you back. So those are the patients that perhaps you want to give them the liberty of not having putting a long-term metal there. Those patients with no bleeding tendency or low bleeding tendency. And of course, if let's say in terms of the do's and don'ts, the don'ts mainly those patients with a high bleeding risk, and ACS, especially those who came in with a STEMI, large thrombus burden, came in with an acute event, those are the patients that we tend to exclude. Remember, the reason why Absorb is not doing so well because they don't select the patient carefully. Okay, so we want the result to be good. So those patients who came in with a cardiogenic shock, STEMI, high thrombus burden, those patients that you don't know whether the mechanism will behave well or not, we exclude that. And of course, if let's say you cannot afford to do OCT and IVUS, exclude it. It is a must to actually do all these Freesolve cases with the intravascular imaging. So the goal lesion for, the right lesion to actually go for it, diameter 2.75 to 40, focal lesion. I prefer to actually put it in proximal LAD, has been advised and, has been seen by all the registry. And of course, a clean proximal and distal landing zone, because we have to remember, we treat this as how we put our stent in. We want the landing zone to be clear, less plug burden, so that it won't cause any distraction, don't cause any eyes. In the yellow color tab, so you think twice before you put your RMS in. Mild to moderate calcium. Usually for RMS, for Freesolve, my tendency to actually put Freesolve, if let's say they have calcium there, is a bit high. Because I don't know whether the calcium will do justice to the magnesium or not. Of course, if let's say it is tortuous, if there is side branch, if the side branch is perhaps small, maybe I can, consider that. If let's say it is big, there is tendency that it might close off, I tend not to put it. And if it's I cannot do OCT, I cannot do IVUS, I will just exclude it. And don't put your Freesolve at the left main, at the ostial lesion, highly calcified. ISR, yes, it's a big no. And as I mentioned just now, thrombotic STEMI. So how do you choose between DCB, Freesolve, and bioadapter? So as you can see there, if you look at the Freesolve there, it is like the best of both worlds, So you put the metal in, you give them the reassurance of having a 6 months period of metal there, of scaffold, to avoid the luminal loss. And after that, the metal will be gone. Okay, that is the advantage of Freesolve. And then you have the tantalum marker there to actually guide you where to go. Drug-coated balloon, it goes without saying. This is a fancy idea of leave nothing behind. But you have to remember that it comes with a drawback. Okay? There will be time that you put your drug-coated balloon, because we put so much drug-coated balloon in, especially within us, Asian population, that we tend to be over-brief. We tend to be actually complacent. The kind of dissection that we shouldn't tolerate, we tolerate. The kind of recall that we shouldn't tolerate, we tolerate. So that are the kind of thing that is quite dangerous. So you have to remember, if let's say you put a drug-coated balloon in, the threshold to actually bail out should be low if let's say it doesn't fulfill the criteria. If let's say the recall is a lot, if let's say the dissection is bad, you should be ready to actually put the stent or perhaps scaffold in. Whereas for Dynamax bioadapter, it is a bit different. It is a bit unique in the sense that you put the stent in, the metal stays there, okay? But after that, the metal will goes off, and the only thing that stand or lasts over there is the helical strand, the cobalt chromium tin strand. So it doesn't cage the vessel. So only, you remember our DNA strand like that? So it just provides the backbone of the vessel. It doesn't cage the vessel. It is quite a good idea, a good suggestion, or perhaps something that you can consider. So how do I decide? If let's say the vessel is small, if let's say the preparation is good, there is no non-flow limiting dissection, if let's say the bleeding risk is high, those patients that I cannot afford put on a long-term DAPT, I will put a DCP in. It's the same with the Freesolve in terms of the preparation. So you want to actually achieve perfection when you prepare a lesion for Freesolve. Okay, it has to be a good preparation, minimal recall, and then it has to be focal, de novo, less calcium, something that is perhaps, you can say perfection, that's something that you look forward to, because you want to make sure that it doesn't come back and actually harm you. Whereas you can consider DES or bioadapter, if let's say the recall is very bad, the dissection is very bad, long and diffuse, the kind of usual thing that we encounter in daily basis. So these are the cases that I want to share with you, that perhaps at first I want to put a DCB in, and then after the preparation, I decided against the DCB. So 60-year-old man, not that old, not that young, came in with a non-STEMI. Troponin is mildly elevated. Ejection fraction is only mildly impaired at 50%. Underlying diabetes and dyslipidemia, as you can see there. From here, there is a focal lesion over the distal circumflex. The RCA and LAD is rather non-significant. And then if you can see from the multiple view, and perhaps because this is quite a sizable circumflex, you can see even from the cranial view that it is quite significant. And if you agree with me, this is not a small vessel. It is distal, it is circumflex, but it is not a small vessel. So we went ahead and do the IVUS. It is a fibrolipidic plaque. As you can see that the MLA is only 2.22, the kind of a vessel that you need to intervene. And in terms of the size, it is actually more or less the same, 3.0, 3.0 at the proximal and the distal. And of course, you can see there is a good landing zone, and it is short. Okay, the length from here to here is perhaps around 15 mm. So what I do, I prepare it 1-to-1. Okay, because I want to put the DCB in. So I use an acid balloon because there is some fatty plaque there. I don't want any no reflow phenomenon. Patient came in with a non-STEMI. You don't want to actually induce a plaque rupture. So this is how it looks after the preparation. So I would say it is satisfactory. Might not be the best, okay? But because this is a big vessel, 3.0 mm, it's a young patient, low bleeding risk, good landing zone, and with this kind of 3.0 vessel, I'm not sure if, let's say, I put my DCB in, whether it stays open or not. Because we know all the data that we have is mainly for the vessel of 2.5 and below. If, let's say, 2.5 and above, we are still waiting for the reverse trial. Of course, we have few trials promoting the use of DCB, but the evidence is rather scarce. So I'm not sure whether this vessel will stay open after my preparation. And for that reason, I didn't put this DCB in, I put the free solve in. So as you can see there, it is very important to make sure that it's been placed properly. I look at the multiple view, especially this view, to make sure that I don't go across the branch. Okay, so it's a 3.0 18 mm at a nominal pressure, which is 10. And then this is a NC balloon 3.0 at 12 to 18 mm. And this is how it looks like. So of course, you can expect a stent-like result. And you know that you have to do the IVUS. The stent expansion is 92%, which is very, very good. And as you can see that it covers very well the distal end and the proximal end. There's a very low plaque burden. So this is the kind of lesion that you want to put your free solve in. Case number 2 is a young lady, no ACS, positive stress test, chest pain while playing a netball. EF is good, strong family history with diabetes and dyslipidemia. Look at the proximal LAD there. This is what we call like a juicy kind of lesion just before the band. And usually I decide for free solve after I prepare. But for this patient, I decide for pre-solve perhaps even before I prepare, because this fit the profile. Young lady, no ACS, no calcium, other vessel looks good. This is a kind of group that will benefit for free solve. So OCT is my default choice usually for free solve, because this is the kind of lesion that you want to have a lot of information. As you can see there, this is a fibrous plaque, and there's much of pain over there. So this is a fibrofatty plaque. Okay, not much calcium. This is 18 mm. If you can see in terms of the EL, it's a 3.0, 3.5. So within 0.6 expansion of your free solve. So this is a good case for free solve. So what I did, I prepared with Scoflex. This time around, why I prepared with Scoflex, because this is proximal LAD. I know there is a fibrous plaque there. I want to make sure that I achieve as best as possible in terms of the expansion. As you can see there, the expansion is very good. I could have just put the DCB there. But this is a proximal LAD that we are talking about, a prognostic segment, the kind of segment that you have to treat with respect. So I'm not comfortable to actually leave it without metal, even though I'm happy with my preparation. And it is young, and I told the patient, I could have just put the drug-coated balloon in, but I'm not sure whether it will stay open or not, whether the acute luminal loss will happen or not. And for that reason, we made a shared decision-making to actually put the freeze-off in. So we put the freeze-off 3018, size it properly, NC balloon 35, and then this is how it looks like from the OCT. As you can see there, the stat expansion is very good at 94%. So it covers very well. In terms of the angiographic image also, this is one of the most aesthetically pleasing angiogram that I ever put for a freeze-off. So this is the kind of result that you want, all right? So everyone reaches for a DCB. What is sometimes I don't go for the DCB? As the same as what I mentioned to you just now. When it comes to DCB, it has to be very, very careful, meaning that you are comfortable enough to actually leave no metal there. Meaning that if let's say you prepare the lesion very well, so you want to make sure that yes, it won't cause you to have a acute luminal loss. The fellow or registrar won't call you at night to say that the patient had STEMI in the ward. So of course, DCB, as we might already know, in small vessel, in ISR, that's where they are very good at. And just put it that way. Of course, we have a very promising trial from the solution where they tested the use of a Lima's DCB in a de novo lesion, which is not inferior, but we have to take it with a pinch of salt. But whereas if let's say it is not suitable for the DCB, there's elastic recall, dissection, especially at the proximal LED. Okay, don't ever tolerate the dissection at the proximal LED because it's a big vessel. The kind of data that we have from the literature is mainly at the small vessel. When it involves a big vessel, there is no predictor to actually predict whether a patient will get the acute luminal loss or not. Of course, you don't do IVUS routinely after you put a DCB in. But if let's say there is an undiagnosed intramural hematoma, you wouldn't know. And then you leave the patient without the metal and the patient goes to the ward, have a STEMI in the ward. All right, those are the kind of risks that I think is not worth taking. And yes, in terms of the trial, rash cage free is a good wake-up call for the DCB believer, meaning that leave nothing behind doesn't always mean applicable for all patients. So of course, when you want the vessel to actually stay open, you have to take it with a pinch of salt. There are patients that you have to put the metal in. Of course, they can see from the sub-analysis, those big vessels tend to do worse with the DCB. So 5 reasons why I reach for freeze-off instead. So it's the best of both worlds, as I mentioned. So it gives you a protection in terms of scaffold for the first 6 months to prevent the luminal loss. And after that, the metal will goes away and it will be metal-free. So predictable acute result, the kind of result that you want for your patient, the kind of result that gives you a safety net as an operator. And of course, after you prepare, because on one hand, you want to prepare the lesion very, very well with all your scoring balloon, your atherectomy, your aggressive modification. But on the other hand, have to tolerate with the dissection, which is something that is contradicting. So would you be happy to actually leave the preparation like that? So freeze-off gives you a comfort solution. And then of course, you want to maintain and preserve the physiology, okay, leaves nothing behind, and it protects the patient future, which is the best thing I feel for my patient. If let's say the patient age 30-year-old in 50 years time, they have to go for the CABG, and I put the stent at the mid-LED, the surgeon cannot put a Lima there. So there goes the chance for the bypass graft. The Lima is wasted, it's not used, all right? So of course, 4 Ps has been mentioned by the previous speakers before. I'm not going to talk too much about this. The main thing is about the pre-dilatation, which is mandatory. Prepare 1-to-1 is how you do with the DCB. And after that, it is not about the technology. Okay, technology is one thing. Okay, freeze-off has come up with a very good magnesium technology, but equally important, or perhaps more important, is how you prepare and treat the vessel. So you take it with a pinch of salt. Okay, you have to remember there is no RCT yet to compare in terms of the freeze-off against the DES. We are waiting for the Biomed 2. Of course, this result will actually change the way we treated our patient. The duration of the radial support, we know very well after 6 months, it starts to degrade. So the question is whether it is enough for that 6 months. Do you need it more than 6 months? We are not sure. Okay, narrow working range. Okay, the selection is quite narrow in a sense that you cannot need to be too big, you cannot to make it too small. So it has to be very specific. The cost is one thing, The reimbursement is also another thing that might differ between countries to countries. And as I mentioned, it is not about the technique. All right. I mean, it is about the technique. It is not just about the technology. So it has to come hand in hand. And of course, in future, okay, the technology of iron that might come, okay, maybe 10 years from now, is something that we waited anticipately. So this is my take-home message. So the need is now because our patients are younger. So we have 3 different modalities, 3 different devices. They all cater for a different patient, cater different questions. So decide after you prepare and after you image the patient. So DCB has its place in our practice. We have been practicing it routinely, but of course, the failure of DCB is the bailout stand. For that reason, we have to be prepared to actually put the stand in. Don't ever lower your threshold for that. And of course, you have a very promising Biomech 1, Biomech 2, something that we waited. And up until we get the Biomech 2, my advice is stick to the strict selection criteria. But because we don't want the history of absorb to repeat itself. All right. So with that, I end my presentation. Thank you very much.
Yes, thank you very much, Dr. Shaparuddin. That's a very clear message why and how to use the magnesium scaffold. Next presenter, Dr. Vincent Kok from Hong Kong, one of my long-time friends. He will give the talk about the is stainless strategy ready for prime time.
Good afternoon, Mr. Chairman, ladies and gentlemen. It's my privilege to actually walk you through my BRS journey in the past 10 years or so. So nothing to disclose. The original rationale goal of BRS platform or bioresorbable scaffold, of course, is no chronic inflammation, no late sand thrombosis, return of vasomotor tone, etc. And we were pretty excited when we were using the first generation device, the PLA absorb, and we were interviewed in TCT in 2013. And the major driving force for the scaffold is actually patient's preference, as we don't have any absolute indication for our BRS platform. We gathered together and wrote up some guidelines and case selection in 10 years ago. And But as you know, the first generation device is not so forgiving for young interventionists. Probably you haven't seen this before. And the angiogram couldn't tell you whether the scaffold is well expanded or whether there is any fracture. If you overexpand the fracture, you underexpand, there is malapposition, and worse still, adverse event can happen 3 years afterwards. All right, this is my patient who stopped everything because he thought the scaffold was resolved. And he sustained and STEMI. And probably you could see the footprints of the scaffold. And on the right panel, you could actually see the overlapping scaffold. So we didn't know what happened. Probably the inflammation went on. All right. So this is the that story. But we did have a successful story. This is again 10 years ago, a young patient with moderate to severe LAD stenosis, with symptom, multiple risk factors, and we put in the BRS, all right? That's the first generation device with some area of overlap. And you could appreciate that the radial strength is not that strong, and you had areas with a double scaffold, which means it's around 300 micron thick. But for this patient, he was lucky. 10 years later, they came back because of an ambiguous CT scan. So we took the opportunity to do an invasive coronary angiogram. It was all widely patent. And it's the very first time we could put the IVUS 10 years ago and HD IVUS nowadays, 10 years from the index procedure. You could appreciate a plaque regression and catering of the vessel and the positive remodeling at every segment. So this is the ultimate goal of a successful BRS story. And that's why the concept moved on of the concept of leaving nothing behind. And especially nowadays, we're stressing on lifetime management of our patients. For these young patients, is still very young, 47 years old. So with this result, I was pretty impressed. right? No medication alone can achieve such a plaque regression, positive remodeling, and uncaging of the vessel. But the disappointing randomized trial result in ABSORB2, ABSORB3 failed to reach any of the primary endpoints. And it was, as you all know, it was voluntary recalled in 2017, and BRS implant is now class 3 indication, and extended depth up to 3 years is recommended. But the BRS story didn't end here. The peripheral application continues, and the magnesium platform prevails. And perhaps we need other BRS options, stronger radial force, faster resorption time, easier handling, and low thrombosis rate. Then come the first generation McMaris platform. And this is the first implant in Asian Pacific area. And this is the very first time we could appreciate the stent, metallic stent-like performance of a BRS. And this is the OCT pullback. And this is the patient's CT scan before the procedure, critical stenosis in the RCA, salt plaque, McMaris implant, and 2 years CT follow-up, perfect result, and 10 years photon counting CT follow-up also showed very nice result, all right? With only marker, with no evidence of footprints of any implant. And that's what we are looking for. But the first generation device, of course, everyone would know that the markers were very difficult to see even under stent boost. And there comes the next generation, the Biomech platform, and all the previous speakers have come across this. I will not bore you about the data. And we have the return of vasomotor tone. After 1 year, we have the resorption almost completely within 12 months. And we have the 3-year and 4-year follow-up result with no signal of late events and a very promising TLR rate. Of course, we're eagerly waiting for the randomized control trial. And we now have a platform with a better size range, better length. We have 4.0, we have 30 millimeter, we have a thinner strut, less than 150 micron for the 4.0, and the 3.0 to 3.5 is below 120. It's a pretty nice platform. Extremely good for young patient, 42-year-old, CTFFR 0.74, over 70% LAD blockage. All right, this is the kind of lesion that we are looking for. All right, you're on the right-hand panel, you could see a critical blockage with MLA less than 1.7, positive CTFFR, 90% plaque burden. I always prepare these solutions with either scoring balloon or cutting balloon, and there's a 4.0 by 26 device with excellent OCT results, and 1 year photon counting CT follow-up with excellent outcome, and also preservation of the big side branch, as you could see in the middle panel. And edge-to-edge implantation, I think you've seen many cases before, and we aim at the balloon marker overlapping the scaffold marker of the previous scaffold. This is a long lesion in the LAD diffusely disease, IVUS guidance, 80% blockage in the mid, and first scaffold, and we position the second scaffold balloon marker over the scaffold marker. Probably you can see it on the right-hand side, and again, pretty good result. Pre-dilate with cutting balloon, high pressure post-dilation is very important. Intravascular imaging, and we proceed to the left circumflex distal lesion. Again, IVUS guidance, cutting balloon, resolve, and we then proceed to the right coronary. So this patient has a triple vessel disease, distal right, and also proximal right. IVUS, proven critical stenosis, moderate stenosis in the proximal RCA, but anyhow, we left nothing behind. So what the heck, we just fix everything. And IVUS guidance, and this patient with good angiogram result and IVUS result, 1 year photon counting CT follow-up with widely patent scaffold. Interestingly, this patient stopped his step 3 months after the implantation because of another elective procedure. But fortunately, he didn't have any CV events. And But I think if you have intravascular guidance and you have a good expansion of the scaffold, you ensure that all the struts are embedded in the vessel wall. After 1 to 2 months, they would be completely endothelialized. So it doesn't matter whether it's completely resolved or not. If this have been covered by the healthy endothelium, I think it's still safe to just interrupt the step within 6 months. And you could see on the left-hand panel, we saw the edge-to-edge implantation with not much gap between the two scaffold, with the two markers next to each other. And the left circumflex scaffold is widely patent, and also the RCA scaffold is widely patent. Hybrid approach is very attractive, leaving nothing behind. And personally, for proximal vessels, large vessels, I would prefer a free solve. For distal, smaller vessels, say less than 2.5 millimeter, I think DCB is preferred. Again, young patient, high calcium score, critical proximal LAD and circumflex lesion, the diffuse left circumflex OM lesions. All right, you could appreciate the critical proximal LAD stenosis, subtotal occlusion, and proximal circumflex over 70% blockage, diffuse long small vessel disease in the OM1 and the OM2, on QFR and IVUS guidance in the proximal LAD, cutting balloon, followed by free solve, right? And we carefully position the scaffold without protruding to the left main, all right? This is very important because if you protrude to the left main, it would be hanging around and it would pose a threat of future scaffold collapse or thrombosis. And the IVUS guidance and showing a good scaffold apposition and positioning. I want to advance the speed of playing. So just to show you that it's exact position at the osteo LAD without sticking out to the left main. And this is very important, and you would know why. And after we finish deploying the scaffold in the left circumflex. So here comes it's close to the osteo LAD. Initially, I want to fast forward this, but we didn't have the mouse here. By injecting contrast, you can make sure that there is no malapposition or gap, especially at the edge, right? And I think the left circumflex is coming in. This is side branch. This is the osteo LAD, right? It's well opposed without sticking out to the left main. There you go, all right? The exact positioning of the LAD stent. Then we proceed to the left circumflex, and for the OM branches, because it's small and diffusely diseased, we did some balloon angioplasty and then treat them with DCB and blowing up to 2.2 size with 2 DCB treatment of the OM branches, and then we did the cutting balloon of the proximal circumflex and implant the free solve in the proximal circumflex with the IVUS guidance. All right. But after finishing pulling, we did the final angiogram. We pull everything out and except the guiding catheter. It dive into the LAD. And then we went back to look at the LAD, and you could see on the left-hand panel, the IVUS, there was some malapposition of the osteo LAD scaffold, all right, especially with the contrast injection. Just pay attention, all right? So we went back and post-dilate further. That's very important because if we leave this malapposition, it may cause a late scaffold thrombosis. We didn't know whether there's a guiding catheter mishap or just a scaffold recoil. But anyhow, we have to be very meticulous in handling all these devices, all right? And the final IVUS showed a well-opposed scaffold without gap. So you know all the 4 Ps, all right? And case selection, not just the age, the lesion is very important. And we did have a colleague who attempt to implant a long scaffold across the tortuous left circumflex, but end up with a dislodged scaffold. He was lucky enough that he could pull the whole system back to the radial artery, and we have to ask the surgeon to remove the scaffold from the radial artery. So for tortuous calcified left circumflex anatomy, I would advise against using the scaffold, or if the patient insists, better prepare for a guiding extension, all right, to protect the scaffold. And STEMI is not an absolute contraindication. We have some European colleagues doing STEMI patients, implanting STEMI, resolve in STEMI patients. When I was in Zurich visiting the Basel University Hospital, they did a young STEMI patient who is only 30-something. And after removing all the thrombus, you had the OCT, you have the exact sizing of the vessel, you could still consider resolve for those non-calcified plaque rupture lesions. Proper sizing is important. For me, I think intravascular imaging is mandatory, and you always predilate the balloon, the lesion with a cutting balloon or scoring balloon, and post-dilation is very important. And although the expansion limit was recommended to be 0.6 millimeter, but if you have an underexpanded scaffold, you can always expand it further, because it's more important to have greater expansion than leaving an unexpanded scaffold in the coronary artery. So is standard strategy ready for prime time? I don't have the the absolute answer. Case selection and meticulous handling of the RMS is very important. Scaffold dislodgement can be disastrous. DCB, not all DCB the same, as you know from this symposium. And ISR, of course, DCB is a reasonable choice over DAS for obvious reasons, to avoid multiple layers of stents. But for de novo lesions, is the solution better? If you look at the data and dissect it, for bigger vessels, performance is not as good as smaller vessels. So for small vessels, less than 2.5 millimeter, of course, DCB may be the first choice. But you have to be prepared for bailout stenting, and the risk of aneurysm and rupture closure is genuine. And we don't know whether it would cause damage to the vessel. We have to respect the vascular biology, because in the cases of DES bailing out the DCB, we are doubling the doses of drug on the vessel. So we don't know what would happen in the future. Hybrid approach is very attractive, but we need more experience and data. And we are seeing more comeback of BRS platform. And we know that the Eversolve is now undergoing clinical trial in Japan. It's a thinner strut PLA platform. And we would see more standard strategy in the coming years. Thank you very much for your attention.
Thank you very much, Dr. Vincent Kwok, for about great talk about the history of BVS. Now we learn about the negative result from the BRS, but now we have a very attractive result from magnesium scaffold free zone RMS. But now we are waiting about the RCT trial to compare the conservative DS to answer the final question. But then the last speaker, Dr. Vu Hong Fu from OMC Ho Chi Minh City, will talk about the RMS case sharing.
So good afternoon. Today I will present what we are doing in our center for the magnesium scaffold. So first thing, the key points of the magnesium scaffold, I think, is not the DS. So it is delivered like DS, but I think we should treat it. It's a different kind. So we have to follow the 4P, as we have heard from the previous presentation from Vincent, that select the patient, the right patient is first, but I think this is the most important. The second one, we have to use the pre-dilatation, also the IVUS or OCT intravascular imaging, also the post-dilatation. So that's it we have to do in daily practice. And the benefit of the scaffold in the first year, I think it's not different from the DS. We hope that it's similar to a DS, but I think the benefit of the scaffold should be we wait for the after 1 or 2 years is in the biomark 4 years follow-up we see the result. So what we do, this is the first ideal case. It means that the right patient and we can do the procedure straightforward from the beginning to the end. The first patient, we see the 72 females, unstable angina, and we have the circumflex lesion, very focal. We have the bifurcation, but non-significant. This is not a true bifurcation, and the side brand is small, so it's ideal for the scaffold. So we check the IVUS. Distal lumen area is about 3. So it means that we choose the scaffold is about 3 mm is suitable for that. And the lesion is not so classification we see on the screen. So I think this is the ideal case for the scaffold. So what we did for the patient, the first one, we choose a cutting balloon, 2.75 by 10. We go to the 16 ATM because the cutting balloon is smaller than the vessel a little bit. So we are confident to go with a high pressure to prepare lesion well. And after that, we choose the scaffold, the Friso 30 by 22, go to 12 ATM, and we use the NC balloon 3.5 by 15, go to the 20 ATM. So you can look at the result, excellent result with the very simple case. This is the ideal case for daily practice. And the second case, this is a very young patient, 31 male, anterior STEMI. But I think the STEMI patient, the lesion focus, not too much tumors inside. So I think it's very, very suitable for that. DCB, I think in this situation is not so, I'm not so confident with DCB in STEMI patient, but I'm so confident with the STEMI patient, young patient, and not too much thrombosis in the lesion. So this patient, we put a free zone 3.5 by 26 in LED and post-dilatation with a 4.0 NC balloon for the patient. So you can see 2 patients. I think this is the, in our center, this is the ideal case for the free zone. So how about the borderline case? The borderline case, a previous we see in the live case, we have some situation that we have to check off what we have done and what we have to pay for the lesion and also for the patient. So this is the patient with the quite young patient, 41 male and non-STEMI patient. We see the public lesion in the LED. And the LED, we have the proximal, we have aneurysm a little bit. It's about 4 mm in terms of diameter. And the middle of the LED is about 3. So this is the trade-off. We use the scaffold because the scaffold only we can exceed oversize about 0.6 mm with the normal diameter. So what we have, what we do for this patient. And the RCA, we have the CTO, the young patient with the CTO in the RCA, and we have the RCA in the distal. We have the significant lesion just before the bifurcation. So what we done? So this is we put the scaffold in the LED 3.5 in the LED you can see on the screen and the red arrow here. And for the LED, for the RCA, we try to crossing the Y. And the first free zone in the RCA in the distal is the 3.5. And the second one in the mid RCA, you can see on the screen, this is the longer one, is 30. And the last one in RCA, this is the last one, we do the overlap, not overlap, touching the two scaffold in the left-hand side picture. You can appreciate that the third one and the second one just touching is not overlapping. So it means that in the RCA, this one, we check the IVUS, we found that it's not so calcified in diameter is suitable for the scaffold. And the patient convinced, the patient said that he don't want to get any metal inside the body. So we try to use the scaffold. It means the RCA we have 3 visual, and in LED we have 1. And the case that I do not do for the scaffold, this is the last one. So we have to come back to the drug-eluting stent. So this is the case. I didn't do this case, but the fellow do the case. You see the significant lesion in the RCA, distal RCA. It's quite focused. It's quite easy to do But this patient, I don't know why, but the fellow did the case and without any IVUS and without OCT guidance. So I don't know why. And you can see in the picture pre-dilatation with the NC balloon 2.25 by 15. And the Prizo with the 3.5. This is the Magmaris, I'm sorry, this is Magmaris, 3.5 by 25. And this is the result. But 7 months later, the patient come back with the unstable angina. And you can see in the left-hand side, the scaffold, we have some haziness inside of the scaffold. So what we see in the IVUS, the scaffold under expansion or something like that, we measure on the IVUS. So what we did for the patient, we put a DS, this is the Ocero to cover all the scaffold previously. So this is the left-hand side. After 7 months of the first scaffold, we put the Ocero inside the RCA. And 4 years later, we check the angiogram again. You can see that the 4 years later that the RCA excellent result after the scaffold, even one more the DS is inside the scaffold. So for conclusion, I think the implantation of the scaffold nowadays, I think is easy. It's not so difficult, but we have to do the right patient and also the right lesion and also the right preparation. So the pre-dilatation, post-dilatation, and also intravascular imaging are not optional. They are the must. They are the must. It means that we have to do the intravascular imaging to choose a patient, to choose the length, to choose everything, prepare the lesion well before we decided to go with the scaffold. And always keep the DS as a backup plan and never hesitate to use it to cover what happened with the scaffold. So thank you very much for your attention.
Thank you very much, Dr. Wu, for all the excellent cases. Now I think we are open for the questions or the comments from the panelists. Yes.
Yeah, Hafiz from Malaysia. Excellent presentation to all the speakers. I think basically the important point here is to emphasize on the 4 Ps, choosing the right patient, right lesion, and then preparation, as well as post-dilatation, pre-dilatation and post-dilatation. Probably I would like to direct a question to I'm not so sure either of the panel, the speakers may address this concern about when you have a discrepancy between sizes, for example, a 3O and a 4O size, and what size would you choose in terms of putting a RMS? This is always the question which being posed. Anyone would like to take the?
Can you repeat the
Dr.
question?
Dr. Vincent, you'd like to take?
Vincent, yeah. The size.
When you have a size discrepancy.
Yeah.
Yeah, sometimes I think we choose a bigger size. All right, you can under deploy a little bit, and then use a bigger balloon to expand the proximal and avoid dissection of the distal. Because if you put in a smaller one, it can expand to your desired size. But according to the engineer, in fact, you can go beyond 0.6 expansion. You can go higher. So it's important to make sure that the scapula is well expanded and opposed to the vessel wall instead of hanging around. So intravascular imaging is very important. I think we all learned from the first generation device. 10 years ago, there was a pretty, painful experience. But we learned a lot, right? If you look at the absorbed data, the absorbed China and the absorbed Japan were pretty good because we over 90% of the cases we use intravascular imaging, In my previous experience, I used both IVUS and OCT together in checking the scaffold. So our scaffold failure rate is not that high. And for the patient I've shown you, he stopped all medications. So if you leave the scaffold undissolved and with the polymer around, it's still got some inflammation. So if you stop all medications, it may pose a threat of late events. Even for DES, I've seen some patients with metallic DES stopping all medications end up having a STEMI.
Yes. I have one question by Dr. Wu. Okay. I'm sorry. Because the BVS say you use say short lesion is better, but I see LCA very long lesion, 1 or 2 it's enough. But she want to see 3 BVS. And after say second say if you use 2 BVS to see it's head to head or edge to edge, it's better you use overlap. So you tell me why reason you see it.
So thank you for very good question about the how many scaffold is enough for that patient, because this is the CTO case. So when we wiring everything, we have some dissection along to the RCA. So we cannot put very short over there and one scaffold in the proximal. So that reason why we have to choose 3 scaffold in this patient. Yeah. So and the second point is that the 2 scaffold touching, right? We don't want to overlap any for the scaffold. So in the picture, if you see in the Vincent slide, and also in my case, the first the second balloon marker of the scaffold should be aligned with the marker of the scaffold, the first scaffold, because the scaffold is protrude a little bit outside the marker. So that what we doing in the daily practice to keep just touching the scaffold, not overlapping anymore. So we check IVUS again to see. Yeah.
Yes.
Also, thank you for 3 comprehensive lecture, and we have very technician opinion. So we have 2 theoretical questions. The first question about in the biomarker study, you can see the 0 stent thrombosis and very low TLF as compared to the initial BVS more than 10 to 15 years ago with the Upsoft. There is the high grade of stent thrombosis, but with biomarker and free zone is the 0 in the long-term follow-up. So what is the mechanism of the very low strength thrombosis? Is the related to the rapidly endothelializations of stent compared to the BVS or the DES? And the second thing is this the less thrombogenicity mechanism between the magnesium and polymer and some in cobalt chrome alloys. It's the first question. And the second question is in the nearly trend of the study in the free zone. You know, in the biomark 1 and biomark 2, they exclude many subgroups of patients. STEMI patient, bifurcations patient, long lesions, and small vessel disease and heavy calcification. So in the near, if what the subgroup of patients should we choose to study on the free zone in the next series of study? Thank you very much.
Dr. Vincent, to answer the question.
A series of questions. Well, I think what I could catch is the thrombogenicity, right? The thrombogenicity of the PLA versus magnesium platform, right? So I think the PLA is more pro-inflammatory and pro-thrombotic. So again, you have to embed all the stress into the vessel wall, and in order to have good renal endothelialization. But said that, even with good endothelialization, if the polymer remains inside the vessel wall for 3 years, it would continuously promote the inflammation. I think that is one of the issue of the PLA platform. For magnesium, it's very thromboresistant, and if you have a good endothelialization and it resolve, say within 6 to 12 months time, then into amorphous and harmless substance, then there would theoretically be no late events, right? Because the vessel recovers. It's vascular biology, right? I think that's the major difference in terms of late scaffold thrombosis in the two platforms. But we do see some case reports of, scaffold recoil and scaffold collapse with the magnesium platform, but it's been quite sporadic, and we didn't know whether they were done under straight intravascular imaging, right? And the other question is, the subgroup of patients. Well, we also learn from the absorb experience. Once it's been released in the market, the doctors do crazy things about it. All right, they put it in the osteo, left circumflex sticking out to the left main. They put it in the left main, tortuous calcification, small vessels, leaving the scaffold underexpanded. So I think we still have to stress the meticulous handling of the device. All right, and it's not for all comers. I can assure you, it's not for all comers. In fact, with say CTO long CTO cases like the presenter's case, if the vessel is not that huge, maybe we could just do with DCB, right? But your case is very big, huge vessel. Then I agree that you need scaffold to tag up all the dissections. So that is a good choice for young patients. But heavily calcified lesions, elderly patients, I don't think is a good choice. We're talking about lifetime management, just like TAVI, right? If for young bicuspid aortic stenosis patient at the age of 50, nowadays I think we would not recommend, TAVI right away, all right? So because we are expecting TAVI and TAVI, maybe a second TAVI and TAVI. But for elderly 70 or 80-year-old, of course, you go for TAVI. I think it's the same logistics. Yeah, if you have a young patient, have a long life expectancy, and with a suitable anatomy, I think that's another option.
Yeah, how about Dr. Chaparudin? I think the magnesium scaffold, they also have the PLA together at the coating, yes, on the magnesium, yes, sirolimus and the PLA coating. So how about your comment that is that because of PLA or any reasons that the absorb is different?
Well, you mean the
okay,
the freeze-off. I think the freeze-off also got a biodegradable polymer for drug delivery alone, all right? So it would not remain permanently inside the coronary artery with, which would promote inflammation, just like the PLA in the Absol. Yeah.
Dr. Atun?
Yeah. I have a question. In some selective bifurcation lesion, after the provisional stand with the RMS, after that the study have a recoil or fracture or the side fan compromise. What should I do in this case?
Well, we learned from the previous absorb experience. In the absorb era, when we are dealing with a side branch, and we do what we call snuggle kissing, all right, mini kiss. But I think for the magnesium platforms, it's a more metallic-like feature. And sometimes if we really need to do a side branch salvage, we can still do kissing, all right, center kissing balloon angioplasty. Of course, whether you would put in another scalpel or a DES across the side branch, it really depends on the situation. But in most of the cases, we don't touch it if there is no flow compromise. As you can see in the follow-up CT scan, it would uncage or release the side branch over time. So long as there is flow with no significant compromise of the side branch ostium, I think we would do less is more, all right? Or you can do a FFR to check whether the side branch need any further intervention.
So I have two short questions. The first one is go to Dr. Shaparuddin. So thanks for your very excellent talk. Okay, yeah. So I really appreciate the very nice result of Biomech 1. But if you look at the Kaplan-Meier of TLR, it rises quickly from 6 months to 18 months. So do we recommend a longer DAPT in those patients? Okay, and my second question is for Dr. Guo. Since Hong Kong is the pioneer of many new devices in Asia Pacific area, so the freeze-off have a long scaffold, 40 millimeter. So I would like to ask your experience in those long BMS. Thank you. BRS. Thank you.
I think if I can take the first question, yeah, one of the reason why the behavior of the Kaplan-Meier is doing so is because of the mechanism of the magnesium, because we understand very well that it started to actually degrade and dissolve and become small after 6 months. And after that, before that, it behaves just like the DES. And after 6 months, it started to degrade and the effect of DES disappeared after 12 months. In terms of the duration of dual antiplatelet, I would say if we look upon the mechanism, I don't find there is any indication for longer antiplatelet, because even though it comes with thicker stride, but looking at the Biomech 1 in which they did the OCT, 99.9% actually fully dissolved. And whatever TLF that happened after that, I believe is not related to the metal and the magnesium. So perhaps there is some other, for example, a new atherosclerosis, accelerated atherosclerosis, which is not related to the technique itself. Yeah.
Okay. So you don't recommend a longer DAPT?
Yeah, the longer the APT, it depends, I think, mainly on the patient clinical criteria. But in my practice, I don't practice longer the APT more than 12 months just because I put the magnesium scaffold in. Yeah.
The second questions?
Well, for us, we normally keep the patient on DAP for 12 months and then drop the aspirin and continue with P2Y12 monotherapy. And for the scaffold choices, we have the 4.0, we also have the 30 millimeter. I think the performance was pretty excellent. And for 30, I like the 30 millimeter because with better complete coverage from normal to normal segment. But as I mentioned, for very tortuous lap circumflex, you should always be prepared to use a guiding extension. And in those cases, we sometimes for large vessels, we usually use a 7 French guiding catheter. All right.
Yeah, I think we're running over time now. There is a lot of discussion and maybe many questions left. I think we can discuss later. So thank you very much for all the speakers, 3 speakers, and all the panelists, my co-moderators. I must close this session. Thank you very much.
you.